Good morning, everybody. How are you all? How was your test yesterday? Good. I hope you revise the OBG also after giving test as we discussed in the class. We will give the test and then we will revise yesterday's class. So I hope you all are set. You all are ready with the revision of yesterday's class and day before yesterday's class. So we'll move ahead with our journey of gynecology today. Should I ask you a few questions just to assess whether you revise the things or not? Let's start. Few things. Let's interact. Tell me, what is the treatment for a 30-year-old nulliparous lady? What is the treatment for a 30-year-old nulliparous lady having uterine prolapse? What comes to your mind? Speak in your room. Just shout in your room. 30-year-old lady having uterine prolapse. She is a nulliparous lady, means she wants future childbearing. What is the treatment for her? Speak out, बोलो 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 बोलो, क्विकली क्विकली. इतनी जोर से चिल्लाओ कमरे में कि आवाज पड़ोसियों तक जानी चाहिए, पड़ोसियों को भी सुनना चाहिए क्या हो रहा है. That is abdominal sling operation. And what is the name for abdominal sling operation? Synonym, another name of abdominal sling operation, cervicopexy. Wow. What is the treatment of the same prolapse if the lady is multiparous? Multiparous means she doesn't want future childbearing. Then we can do vaginal hysterectomy. What is the name for this? Wide Mayo vaginal hysterectomy. MCQ number 3. Same lady, suppose. She is multiparous, but she is unwilling for hysterectomy. She doesn't want a baby, but she denies for hysterectomy. What is the name of the procedure? Fothergill's operation. What's another name of Fothergill's? Manchester operation. MCQ number 4. What is the treatment for the same prolapse if the age is around 65 years? Suppose 65. What should be the treatment? Treatment is Lee-Ford colpoclysis and Daniel stitching. Lee-Ford colpoclysis and Daniel stitching. We discussed these procedures in detail yesterday. What are the indications of ring pessary? Where is it used? Indications of ring pessary are: it can be used to treat prolapse in pregnancy, puerperium, in any young girl who is unwilling for any surgery, or there are some contraindications. Anesthetist refuse to give anesthesia. Maybe she is severely diabetic or hypertensive or some other contraindications for anesthesia. And if you want to give some temporary relief for the prolapse, because these ring pessary, they can be changed or they can be removed after 3 months. So for a temporary relief also, a ring pessary are used. What is the treatment of vault prolapse? Vaginal vault prolapse. What is the vaginal vault? When we do hysterectomy, we leave a small stump inside. That small stump is called vault. So what is the management of vault prolapse? Sacral colpopexy and sacrospinous fixation. We discussed yesterday. What is the prevention of prolapse? Prevention of prolapse is by the exercise, Kegel exercise, tightening the perineum. So this was about the treatment of prolapse. What was the most common type of prolapse? Speak out. Bolo, 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 bolo. What is the most common prolapse? Cystocele. Most common prolapse is cystocele. Acha, 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 acha. Tell me, what is the most common fibroid? Most common fibroid is intramural fibroid. Intramural or interstitial fibroid. Okay. Treatment of fibroid depends on what? Treatment of prolapse depends on parity. Treatment of fibroid depends on symptoms. If there are no symptoms, if she is asymptomatic and size of fibroid is less than 10 centimeter, then we do just monitoring or observation. No symptoms. So treatment of fibroid depends on what? Symptom. If symptoms are present, if she is symptomatic, then size does not matter. If she is having symptoms, what is the management of fibroid? then it depends on parity. If she is multiparous, total abdominal hysterectomy. If she is nulliparous, myomectomy. Then we discussed if she is unwilling. I hope everything is fine. You can hear me properly. Am I audible? I forgot to ask. I hope everything is fine. Am I audible? Is the video clear? You can see me properly? Fine, fine. Thank you very much. Thank you so much. Fine, 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 good, good, audible, can see. Thank you very much. Thank you, thank you, thank you. Means you are listening with attention. My God, that's wonderful. That's wonderful. Such an energetic response from everyone. Wonderful, beautiful, overwhelmed, so happy. Because we can't see each other, no? But we are sitting in one room. Yesterday also I received many queries, and the queries were almost similar. So what I will do, there were many queries related to questions also. So these two options look similar, the Telegram questions which I posted yesterday. And we will be discussing those questions today in the class as well. We'll discuss all the questions. We discussed day before yesterday's question in yesterday's class. We will discuss yesterday's Telegram questions in today's class. So what is happening? Everyone is clear because I tried to put lot of googly balls in those Telegram questions. And the idea behind it, whether you are trapped or you are able to see the swing of the ball and you can escape. You can escape the ball, you don't commit the silly mistakes. That's the whole idea behind these poll questions so that we can discuss them in the class here. Fine, wonderful. So, we are discussing if she is multiparous, then total abdominal hysterectomy. If she is nulliparous, myomectomy. Then we discussed if she is a multipara and there are some contraindications for surgery or she is unwilling for surgery, then we do two things. Uterine artery embolization with polyvinyl alcohol and gel form and MRI guided high intensity focused ultrasound therapy. So these focused ultrasound waves, we are firing them on the fibroid. Then we discussed if she is a primee or nullipara, she wants future childbearing. And there are contraindications for surgery or she is unwilling for surgery, then we give drugs to her. Continuous GnRH can be given, letrozole can be given, danazole and gastrinone can be given. Then we discuss ulipristal and mifepristone. Because she is having severe menorrhagia, what is the drug to control the local bleeding, to control the menorrhagia? Tranexamic acid. And we can give her iron to boost up her hemoglobin. So that was management of fibroid and management of prolapse. Now, which fibroids cause abortion? Which fibroids specifically cause abortion? Subserous fibroid or submucous fibroid or intramural fibroid? Specific to submucous fibroid. Infertility and abortion are specific complications of which fibroid? Submucous fibroid. Pressure symptoms are specific complications of which fibroid? Subserous fibroid. Anterior wall cervical fibroid causes frequency of micturition. I received many messages yesterday that, sir, how come posterior wall cervical fibroid will cause retention of urine? We all know the anatomy. It's not easy to understand. But if it is a large posterior wall cervical fibroid, it gives pressure to the bladder neck and it causes obstruction of the bladder neck. This is how it causes retention of urine. Then we discussed, yesterday we discussed various other topics like polycystic ovarian syndrome. What is the drug of choice to treat hirsutism due to PCOS? Tell me. Drug of choice to treat hirsutism in PCOS. Whatever questions I am asking you, they are different from Telegram question, which I will post today. And they are of course different from your weekly topic-wise test, which will be held on Tuesday. Now we are not having that, but we will do a good practice of all these questions. Don't worry about that. We are discussing these questions, rapid fire questions in the class. Then we will be having Telegram discussions. So you will be equipped with Ops Guide. Don't worry about that. What is the drug of choice to treat hirsutism in PCOS? Speak out in the room. Just shout in the room. Drug of choice to treat hirsutism in PCOS. Oral combined pill. Then we wrote one more thing. Which generation progesterone should be used to treat hirsutism? Fourth generation progesterone. In an oral combined pill, which generation progesterone should be added? Fourth generation progesterone. What is the drug of choice to treat infertility in PCOS? Letrozole. What is the answer? Letrozole. Which estrogen is increasing in PCOS? Estrone, E1. So let's begin our today's journey with urinary fistula. Fine. Urinary fistulas. There are three types of urinary fistulas, three common types of urinary fistulas. What are these urinary fistulas? Fine. Let us draw a ray diagram here. This is urinary bladder and this is urethra. This is urinary bladder and this is urethra. And this is vagina. And this is ureter. There can be a fistula between ureter and vagina, and we will call this fistula uretrovaginal fistula. There can be a fistula between urinary bladder and vagina. We will call this fistula vesicovaginal fistula. There can be a fistula between urethra and vagina, and we will call this fistula as urethrovaginal fistula. So let's number them. The fistula number 1 between ureter and vagina. So the name is uretrovaginal. Fistula number 2 between urinary bladder and vagina. So this is vesicovaginal fistula. Fistula number 3 between urethra and vagina. So this is urethrovaginal fistula. So we have these three urinary fistula. Let's discuss. Uretrovaginal. If there is a fistula between ureter and vagina, what will be her complaint? What she will tell us? What will happen to this urine? The urine present in the ureter. The urine present in the ureter now will start entering this fistula and will enter vagina. So what will be her complaint? She will say, Doctor, I am having continuous dribbling of urine through vagina. She is continuously passing urine through vagina because there is an abnormal connection between ureter and vagina. But at the same time, if you ask her, do you feel some urge? Do you feel a full bladder? And do you feel a urge to go for micturition on your own? क्या आपको लगता है कि आपको खुद भी अपने आप से यूरिन जाना है? Do you feel this urge? She will say, yes, I'm feeling it. There is continuous dribbling of urine through vagina, but at the same time, she is also feeling a desire to go for micturition on her own as well. Why she is feeling so? Because urinary bladder may be filled to that threshold extent that she is feeling a desire via another ureter. There is another ureter as well. And via this another ureter, urinary bladder may be filled to such a threshold level that she is feeling a desire to go for micturition on her own also. Fine. If it is a fistula number 2, vesicovaginal fistula, what will be her complaint? Urine from urinary bladder will enter this fistula and will be passed to vagina. It will be transferred to vagina. Again, she will say, Doctor, I am passing urine continuously through vagina. So she is having the complaint of continuous dribbling of urine through vagina. Now you will ask her, okay, do you feel a desire to go for micturition on your own also? She will say, no, doctor. I don't feel a desire that I should go on my own also. I don't feel that much full urinary bladder. Why? Because there is only one urinary bladder. Whatever urine is contained in this bladder is transferred to vagina. There's only one bladder. So she is not feeling any desire to go for micturition on her own. Okay, let's talk about fistula number 3, which is between urethra and vagina. So if it is the case of urethro-vaginal fistula, what will be her complaint? Normally, urethra are empty. They don't contain urine. Urine enters urethra only at the time of micturition, voiding, when she is passing urine. So her complaint will be, Doc Saab, I feel I am having dribbling of urine through vagina only at the time of micturition. When I go to pass the urine, then urine is not only coming from urethra. At that time, urine is coming out of vagina also, only at that time, not otherwise. So this is how we can clearly, clinically differentiate or suspect she is having which type of fistula on the basis of her complaint, symptom. That is clinical diagnosis. Let's write down. Fistula number 1. Uretrovaginal fistula. Uretrovaginal. What is her complaint here? Her complaint here is continuous dribbling of urine through vagina. There's continuous dribbling of urine through vagina and normal micturition also. And normal micturition also. Continuous dribbling of urine through vagina and normal micturition also. Now, if it is fistula number 2, that is vesico-vaginal fistula. What is her complaint? Continuous dribbling of urine through vagina, but no normal micturition. But no normal micturition. We know that. And if it is a case of urethrovaginal fistula, the third one, what is her complaint? If this is urethrovaginal fistula, her complaint is dribbling of urine through vagina only at the time of micturition and not otherwise. Only at the time of micturition. This is her complaint. Screening test. What is the name of screening test? Name of screening test is methylene blue 3 swab test. Name of the screening test is methylene blue 3 swab test. What is this methylene blue 3 swab test? Why this is called methylene blue 3 swab test? Have a look. What we do, we instill methylene blue dye in urinary bladder via a Foley's catheter. With the help of a Foley's catheter, we instill this blue colored dye in urinary bladder, methylene blue. And then we put 3 cotton swabs in vagina. 3 cotton gauze piece, 3 cotton gauze piece, 3 cotton swab, or 3 cotton balls in vagina. Now we have to see what is happening to these cotton swabs. What is happening to these cotton swabs? If this is the case of uretrovaginal fistula, fistula number 1, what are you thinking? How these swabs will be affected? If it is uretrovaginal fistula, swab will become blue or wet. First of all, theoretically, although practically we can't say which swab was affected first, theoretically, for MCQ purpose, if it is a uretrovaginal fistula, which swab will be affected first? Of course, the topmost swab. The second question is, how the swab will be affected? Will it turn blue also, or it will remain wet only? Of course, it will remain wet only. It will not turn blue because methylene blue is present only in methylene blue is present only in urinary bladder, not in the ureter. This is why, if this is uretrovaginal fistula, topmost swab will be affected first, that's for sure. But how will it be affected? It will turn wet but not blue. Done. If it is fistula number 2, vesicovaginal fistula, theoretically, practically, we can't say which swab was affected first. Of course, you understand, I understand. Theoretically, which swab will be affected first? The middle one. How will it be affected? It will turn wet and blue both because methylene blue is present in bladder. If it is fistula number 3, which swab will be affected? Only lowermost swab will be affected. That's also for sure. And how will it be affected? Of course, it will turn wet and blue. So let's write down. This is why, this is how these swabs are affected. Then we can suspect which type of fistula is there. We are almost sure. This is called methylene blue 3 swab test. This is why the name of a screening test is methylene blue 3 swab test, because we use methylene blue dye and we have put 3 cotton swabs in vagina. One in the upper part of vagina, one in the middle part of vagina, one in the lower part of vagina. If topmost swab becomes wet, if topmost swab becomes wet but not blue, which fistula is this? Vesico, sorry, uretrovaginal fistula. Which fistula is this? Uretrovaginal. Uretrovaginal. If middle swab become wet and blue, theoretically, later on due to gravity, all will be affected. We are talking about the first one. If middle swab become wet and blue, which fistula is this? Vesicovaginal fistula. If lowermost swab turns wet and blue, only lowermost. If lowermost swab turns wet and blue, this is uretrovaginal fistula. We can call uretrovaginal as high vaginal fistula. We can call vesicovaginal as mid-vaginal fistula. We can call uretrovaginal as low vaginal fistula. Uretrovaginal, high vaginal. Vesicovaginal, mid-vaginal. Uretrovaginal, low vaginal. We can even write the uretrovaginal fistula. It is high vaginal fistula. Vesicovaginal fistula, this is mid-vaginal fistula. Why? Uretrovaginal fistula, this is the low vaginal fistula. Very simple, logical thing. No rocket science here. So uretrovaginal is high vaginal fistula. Vesicovaginal is mid-vaginal fistula. Uretrovaginal is low vaginal fistula. They are placed high, mid, low. Now, with this methylene blue 3 swab test, we are almost sure which type of fistula is there. But if we have to go for the repair of fistula, you want to repair the fistula. Did methylene blue 3 swab test give us any idea about how many fistulas are there? Whether this is 1 or 2 or 3? And what is the exact location of fistula? Where they are exactly opening, in the bladder or in the vagina? No idea was given. Methylene blue 3-step test gave us idea only about which type of fistula is there. But it did not give us any idea about how many fistulas are there. No idea about number of fistula. No idea about exact location of fistula. So to know the exact location of fistula or exact number of fistula, we have to switch over to a definitive test or a gold standard test. Gold standard test, definitive. What is the difference between? Few students ask me this question also. Let me clear. Few students asked me this question also yesterday. Sir, what is the difference between investigation of choice and gold standard? Investigation of choice is a handy investigation which we can perform easily without much difficulty, and that gives us a good diagnosis. But gold standard, when you can stamp, yes, this is a disease. That is called the definitive test or a gold standard. Definitive or gold standard is the final one. After that test, if you get the report of that test, you are done. You don't need any further test to diagnose this disease. That is the gold standard or a definitive test. Investigation of choice gives us a good idea about the disease process, but that's not the surest step. That's the difference between investigation of choice and gold standard. Let's write down. Fine. So gold standard investigation for vesicovaginal fistula and urethrovaginal fistula. For vesicovaginal fistula and urethrovaginal is cystoscopy. Gold standard investigation for vesicovaginal fistula and urethrovaginal is cystoscopy. What is a cystoscope? Cystoscope is the camera of urinary bladder. This is camera of urinary bladder. Let me show you a cystoscopy image. This is the cystoscopy image as we can see. If we put in the camera of urinary bladder inside the bladder, we can see these are the fistula orifices. This is the place where this fistula is opening in urinary bladder. So how many openings you can see here in this image? We can see two openings here in this image. How many openings in this image? Two openings in this image. So this is the fistula orifice. So by this camera of urinary bladder, which is the cystoscope, we can see how many openings are opening in urinary bladder and what is the exact site of these openings. So exact number and exact site of these openings, we can get the idea if you put in a camera of urinary bladder, which is a cystoscope. And we know these are present on which bladder wall? They are present on posterior bladder wall. So we know their exact location, we know their exact number. So what is the gold standard investigation for diagnosis of vesicovaginal and urethrovaginal fistula? Cystoscopy. But this camera of urinary bladder, this is the cystoscopy image. This is the cystoscopy image. But this camera of urinary bladder, cannot see the ureter. So this cystoscopy cannot diagnose which fistula. The cystoscopy cannot diagnose uretrovaginal fistula. This is gold standard investigation for which fistula? Vesicovaginal fistula and urethrovaginal fistula, but not for uretrovaginal fistula. So what should be done as a gold standard investigation for uretrovaginal fistula? First of all, we want to reconfirm the uretrovaginal. How to reconfirm the uretrovaginal fistula? For reconfirmation of uretrovaginal, we can either inject the IV indigo carmine. IV indigo carmine is a blue colored dye. If we inject this IV indigo carmine in the blood, this blue colored dye will travel all the way via circulation, will be filtered by kidney, will be filtered by kidney and now will reach ureter. So if you have injected a blue colored dye in the blood, not in the bladder, injected in the blood, so it is traveling via the circulation now, and then it will reach ureter and topmost swab will become blue. We can even use some pyridium tablets which give red color to the urine. So if she takes pyridium tablets and then urine will become red. So then topmost swab will turn red. So whether you are injecting a methylene blue dye, we don't inject the methylene blue in the blood. Instead of methylene blue, we inject indigo carmine. Methylene blue has a reaction in the blood. So which blue colored dye is used for blood? IV indigo carmine. Or she can even take pyridium tablets. Pyridium tablets will make it red. IV indigo carmine will make it blue. Whatever it is. So topmost swab will change the color. And then how many fistula, exact location of fistula, where they are exactly opening. This can be done by IV urography, IVP. This is the IVP image. In this image, we can see where exactly the fistula is entering, uretrovaginal fistula. We can see that this is coming out here. So this is a fistula. We can easily see number of jets and exact location of jet. So let's write down for uretrovaginal fistula, what is the gold standard investigation? For uretrovaginal fistula, we can give IV indigo carmine or pyridium tablets. IV indigo carmine gives a blue color while pyridium tablets give a red color. So topmost swab will change the color. Just write down topmost swab will be stained. It will be stained with color. If we put methylene blue dye in the urinary bladder, topmost swab does not stain the color. But if she is eating the tablet, then it is passing through the blood circulation now from above below. Similarly, if we inject a blue colored dye, then again it will enter urine. So indigo carmine gives a blue color, pyridium tablet gives red color. So it confirms topmost swab will be stained with color. So it is reconfirming. Yes, doctor, you are right. You are dealing with uretrovaginal fistula. And this is followed by IVP. You know the full form of IVP. You are done with radio, intravenous pyelography. Most common fistula, let me write this followed by IVP here to save some space. Most common fistula is vesico-vaginal fistula. Most common fistula is vesico-vaginal fistula. What is the most common cause of this vesico-vaginal fistula? Most common cause of this vesico-vaginal fistula in developing countries is obstructed labor. Obstructed labor. What is the obstructed labor? what happening in obstructed labor? Let me explain you, but we will discuss this obstructed labor in obstetrics. Obstructed labor, very simple to understand. There is some obstruction during labor. That's obstructed labor. What is that obstruction? If fetus is descending down, suppose this is fetus and this fetus is descending down and there is some obstruction here. And because of this obstruction, this presenting part, which is head in most of the cases, it is not striking over cervix. Rather, it start striking over the urinary bladder neck or urinary bladder wall. So what happens to this urinary bladder wall due to continuous strike by this fetal head or presenting part? What will happen? There will be compression of this urinary bladder wall. There will be tear of capillaries in urinary bladder wall, so she may pass urine. The first feature of obstructed labor is hematuria. She says, Dr. Saab, I am passing urine in the blood. Then what will happen due to compression of wall finally? There will occur ischemia. After ischemia, there will occur necrosis and sloughing. This will fall off. So a gap will be created here, and a fistula will develop. That is vesicovaginal fistula. But in developed countries like America, these sillistic things don't happen. These silly things don't happen because they diagnose the cause of obstruction much before, much earlier, and they go for elective cesarean section. So, in developed countries like America, the most common cause of this vesicovaginal fistula is hysterectomy, some accidental injury during simple hysterectomy, mostly while separating the urinary bladder. Let's write down. In developed countries like America, simple hysterectomy or total abdominal hysterectomy or type 1 hysterectomy, simple hysterectomy. Fine. Management. What is the management of this vesicovaginal fistula? Management. Let's write down. Management of vesicovaginal. Most common fistula is vesicovaginal fistula. We have categorized the management in three parts. Means we will do an operation, so that is the operative management. Before operation, we will do few things, that is pre-operative management. After operation, again we will do few things, that is the post-operative management. Very simple, no rocket science. So pre-op, op and post-op. Why we are so particular that we are categorizing the management in pre-op, operative management and post-op management? Because the place is like this. The location of fistula is like this. She has to go for micturition, she has to go for toilets, defecation, intercourse, there are jugs. So we want a very good healing of this area. For very good healing, we want to choose the best antibiotic also, which we can start before the surgery. That is the pre-op management. Then operation and then post-op management also plays a magical role in good healing, because we want very good healing to avoid the recurrence. If healing is not good, what will happen? There will be recurrence. A fistula will be created once again. So we want a very good healing. Pre-op management, most important aspect in pre-op management. What is our purpose before operation? What we want before operation? We want to choose the best antibiotic, the most appropriate antibiotic. And for this, we have to go for urine culture and sensitivity. Important MCQ, put a tick. What is the most important aspect in pre-op management of vesicovaginal fistula? Urine culture sensitivity. To choose the most appropriate antibiotic. The purpose is to choose the most appropriate antibiotic. This is the purpose. To choose the most appropriate antibiotic. This is the purpose. And what is the best source for urine collection? What is the best source for urine collection for this urine culture sensitivity test? The best is the ureteric route, although the theoretical. Ureteric route. If you can collect the urine directly from the ureter, because once it enters bladder, that's contaminated. So the best source would be ureteric route. If ureteric is not given in option, then we can try with Foley's catheter. We can put in a Foley's catheter, and with this Foley's catheter, some drops of urine may come because otherwise most of the urine is transferred to vagina. That's why midstream clean catch sample has no role here. Then operative management. We just have to remember the names of operation. Nobody is going to ask the procedure, how this procedure is done. We have to remove the fistula, but we remove the fistula and then we have to stitch. We have to stitch which place? Nobody will ask you. I'm just telling you for your understanding. Suppose this is a vesico-vaginal fistula. So openings are at two places. So we have to first of all remove this fistula, take out the fistula, and then we have to put a stitch at vaginal wall. Then we have to put a stitch at urinary bladder, and then we put a stitch in between also. So we have to put 3 stitches, one by one. We just have to remember the name. No one is asking the procedure. Procedures are Chesser-Moyer repair, Chesser-Moyer repair, let's go repair, or layer technique. Let's go repair and layer technique, they are almost same, just a little different. So just remember the names of repair for vesico-vaginal fistula, Chesser-Moyer repair, let's go repair, layer technique. Then the post-operative management. Important MCQ. After operation, we want to restrict her movement. We want to restrict her movement. We don't want that she should go for micturition on her own. What is happening if she is not going for micturition on her own? The urine is not continuously passing through that area because we have just repaired the area. Most important aspect is continuous catheterization. Continuous catheterization. Continuous catheterization of urinary bladder. Continuous catheterization of urinary bladder for 2 weeks. This post-operative management is also called rule of 2. This is also called rule of 2. Continuous catheterization of bladder for 2 weeks. This we can do after the surgery. This continuous catheterization is the most important aspect we have put a tick. Even when you are suspecting the obstructed labor, we know that the fistula may develop. Even if at that time, for prevention, if we catheterize the lady for 2 weeks, we can avoid the formation of fistula. But things are missed, and a fistula develops. The most important aspect in post-op management is continuous catheterization of bladder for 2 weeks. No per speculum examination. No per vaginal exam, no per speculum exam, no intercourse is allowed for 2 months. No pregnancy is allowed for 2 years. This is the rule of 2. Continuous catheterization of urinary bladder for 2 weeks. No PV-PS intercourse for 2 months. No pregnancy is allowed for 2 years. We want to avoid any recurrence. And if she becomes pregnant, how will you take out the baby? Will you allow a vaginal delivery to happen? No, we can't allow a vaginal delivery. Otherwise, there will be recurrence. We will take out the baby by cesarean section. In cesarean section, you want to cut the uterus in upper part of uterus or in lower part of uterus. In upper part of uterus, because there is a fistula in lower part. So if she become pregnant, baby will be taken out by upper segment cesarean section, not by lower segment cesarean section. In obstetrics, we will discuss most commonly performed cesarean section is lower segment cesarean section, upper segment cesarean section. And this upper segment cesarean section is also called classical cesarean section. Classical cesarean section. Another name of upper segment cesarean section is classical cesarean. What is the timing of repair? When do you want to repair the fistula? That is the pathological principle. Healing by primary intention, healing by secondary infection. If you have diagnosed the fistula within 24 hours, we can go for immediate repair. Immediate. If you have diagnosed the fistula after 24 hours, then if you stitch the fistula at that time, if you stitch the vaginal end or the urinary bladder end at that time, these stitches will open because the walls are loose. Then we are waiting for healing to be completed. After healing, what happens? Fibrosis occurs, and because of this fibrosis, the scar will develop at that area. That fibrosis, that scarring will hold the stitches intact. Otherwise, stitches will slip out. This is why if it is diagnosed after 24 hours, if it is diagnosed after 24 hours, then we wait for healing to be completed. Then we have to repair it after at least 6 weeks. We wait for at least 6 weeks time. We can repair them any time between 6 weeks to 12 weeks. The range is right down 6 weeks to 12 weeks. But we have to wait for at least 6 weeks time. We will repair this after at least 6 weeks. Urethrovaginal fistula. Urethrovaginal. Urethrovaginal fistula, this is very, very rare. Very, very rare. The cause of this fistula, how this fistula may develop. If she is standing, suppose, on a rooftop, छत पे खड़ी है. If she is standing on a rooftop and she falls from a height, if she falls from a height, let me explain you so that you can understand. If she is standing on a rooftop, छत पे खड़ी है, and if she falls from that rooftop on the floor, and suppose on the floor there is a penetrating object here, some penetrating blade, some penetrating stone, or some penetrating knife is there, and she falls from rooftop directly on this penetrating object over urethra. मतलब यूरिथ्रा सीधा किससे टकराया? इस पेनिट्रेटिंग ऑब्जेक्ट से. So urethra will be injured and it may result in formation of urethrovaginal fistula. And sometimes if radiotherapy was given, that radiotherapy can also lead to formation of this fistula. Cause is fall from height on a penetrating object over urethra. Very rare. Another cause may be radiotherapy. Some radiotherapy was given to her. Very, very rare. Management is just a repair. No specific name is given to this repair. Just a repair. No specific name is given to this repair. Fine. Good. Audible. Uretrovaginal fistula. Uretrovaginal. The third one is uretrovaginal. What is the most common cause of uretrovaginal fistula? Vardyne hysterectomy. Why Vardyne hysterectomy is the most common cause of uretrovaginal fistula? Because in Vardyne hysterectomy, we are doing dissection around ureter. So we are dissecting this periuretral fascia. At that time, at that dissection, there can be injury to ureter. So maximum handling of ureter is not in simple hysterectomy. It is in Vardyne hysterectomy because we are handling ureter in this hysterectomy. This is why there is risk of injury to ureter in this hysterectomy. The most common cause of uretrovaginal, Vardyne hysterectomy. Most common cause of vesicovaginal in developed countries like America, simple hysterectomy. And what is the most common site of injury in Verdine hysterectomy? Most common site of injury to ureter. Most common site of injury to ureter in this hysterectomy is the place at which ureter is crossed by uterine artery. You know the anatomy. Ma'am taught you the anatomy. Ma'am taught you the anatomy. Let me draw a ray diagram here. This is uterus and this is cervix. So what is happening? This is the ureter here. This is ureter. This is ureter. This is passing through this place. And what is happening here? This is the uterine artery. The place at which this uterine artery is crossing the ureter. This is approximately 2 centimeter lateral to internal arc. This is the most common site of injury to ureter. This is why this is also called water under bridge. What is the meaning of this word water under bridge? Water means urine. Water means urine. Urine. Ureter contains urine. That is water. So this water is under the bridge, under the uterine artery. So the most common site of injury to ureter is the place at which ureter is crossed by uterine artery. We just have to remember the name of management for uretrovaginal fistula. Name of the management for uretrovaginal fistula is Boari flap repair. We have to remember the name. Boari flap repair. Timing of repair of uretrovaginal fistula, it is done immediately. If you wait for some time, there is risk of renal failure, kidney failure. So repair is done immediately in cases of uretrovagina. There is a word called menuria. Menuria. What is the meaning of this word menuria? Hematuria at the time of menses. Menuria is hematuria at the time of menses. Means she is passing blood. She is passing blood in urine. Not throughout the month, but only at the time of menses. Only during the menses, she is passing blood in urine. Means hematuria at the time of menses only. What can be the causes of this hematuria at the time of menses? Look here. Suppose this is urinary bladder and this is uterus. If there is a connection between urinary bladder and uterus, if there is a connection between urinary bladder and uterus, what will happen? At the time of menstruation, myometrial contractions are there, endometrial peristalsis is there, and uterus is anatomically higher than bladder. So, what will happen due to those myometrial contractions? Due to those myometrial contractions and endometrial peristalsis, these uterine contents means endometrium will be passed to urinary bladder and endometrium is converted to blood by fibrinolysis and she will complain of passage of blood in urine, hematuria, throughout the month or only at the time of menses? Only at the time of menses. So let's write down, this is called uterovesical fistula. So which fistula will cause menuria? Uterovesical fistula. Uterovesical means between uterus and urinary bladder. This is also called vesico-uterine fistula. Uterovesical can also be called as vesico-uterine fistula. There can be another problem which may cause dysmenorrhea, means hematuria at the time of menses. We discussed the disease endometriosis. We discussed this disease endometriosis, where these endometriotic deposits fall in peritoneal cavity. and they are present everywhere on intestine, broad ligament, uterosacral ligament, urinary bladder also. And if there are endometriotic deposits on the surface of urinary bladder, we know these are active endometrial tissue. At the time of menses, they also bleed. So, what will happen? There will be bleeding from these deposits throughout the month or only at the time of menses. Of course, only at the time of menses. So, she will complain of hematuria at what time? Only at the time of menstruation. So, cause of menorrhagia is one fistula between uterus and bladder, utrovesical fistula. And second problem is endometriosis of which place? Urinary bladder. Let's write down. Endometriosis of urinary bladder. So these are the causes of menorrhagia. Fistula will be repaired. No specific name, just a repair. And endometriosis treatment we discussed yesterday. And what is the most common cause of this fistula? Most common cause of this fistula is cesarean section. Which is the most common operation performed on the uterus? Most common operation, most common surgery performed on the uterus is cesarean section. So, most common cause of this utrovesical fistula is cesarean section. Rectovaginal fistula. Rectovaginal. So, what is this rectovaginal fistula? This is between rectum and vagina. This is vagina and this is rectum. And this is rectum. If there is a fistula between rectum and vagina, if there is a fistula between rectum and vagina, there is a connection between rectum and vagina. Rectal contents will be passed to vagina. Rectal contents will be passed to vagina because rectum is anatomically higher. So, if there is a fistula between rectum and vagina, what will be her complaint? What she will tell you? She will tell that talks up, I am passing potty through vagina also. Passage of feces through vagina. Her complaint is passage of feces through vagina in the rectovaginal fistula. What is the most common cause of rectovaginal fistula? Most common cause of rectovaginal fistula is complete perineal tear. Complete perineal tear means fourth degree perineal tear. In complete perineal tear or in fourth degree perineal tear, rectal mucosa is injured. First degree perineal tear, skin fascia, second degree skin fascia muscles, third degree skin fascia muscles and anal sphincter, fourth degree skin fascia muscles, anal sphincter and rectal mucosa also gone. So these are various tears. Rectovaginal fistula will develop if rectal mucosa is involved. So in which tear? Complete perineal tear of fourth degree. Now what is the most common cause of this complete perineal tear? Perineum is the posterior area. So if this is an occipito-posterior position that we will discuss in obstetrics, occipito-posterior position. Suppose this is the pelvis. In this pelvis, suppose this is the pelvis. In this pelvis, mostly occipit is transverse and anteriorly. So when uterus is contracting, this occipit is transverse and it goes anterior. But if occipit is posterior, this is the pelvis, and if occipit is placed posteriorly, posterior side, when uterus is contracting, this wider occipit is striking on perineum, which may result in, that will we'll discuss in obstetrics in a better way with pelvis and gutta and everything. Fine. The most common cause of this complete perineal tear is occipito posterior position. Occipito-posterior position. How we manage this? We have to do colostomy initially. Colostomy means you understand the meaning of colostomy. We are diverting the colon to the anterior abdominal wall and we make a bag there, so the potty is passed in that bag. So what happens? This injured area becomes silent, and because of silence there is better healing. It is followed by repair after 3 months. Here we want to wait till 12 weeks time. Let's solve the questions. This was all about the fistula. And this utrovesical fistula which we discussed, where the uterine contents are passed to urinary bladder, this utrovesical fistula, when this uterine contents are passed to urinary bladder, this is also called a syndrome. Name of this syndrome is Yusuf syndrome. This utrovesical fistula is also called a Yusuf syndrome. Yusuf syndrome. So this Yusuf syndrome is a cause of menorrhagia. So Yusuf syndrome is the name given to this utrovesical fistula, which is causing menorrhagia. Let's solve the questions. And we will discuss telegram questions after the tea break. After tea break, we will discuss telegram questions which I posted yesterday. And we will discuss how and why you could commit the silly mistake. The purpose of discussion is to avoid the silly mistakes. Most important aspect in post-op management of vesico-vaginal fistula is. So question is post-op. Most important aspect in post-op management is continuous catheterization of bladder. Urine culture sensitivity, this is pre-op management. No intercourse for 2 months, yes, this is post-op, but not most important. No pregnancy allowed for 2 years, this was asked in last session, June 22 FMG exam. No pregnancy allowed for 2 years. Continuous catheterization of urinary bladder for 14 days. So this is the most important aspect in post-op management of vesico-vaginal fistula. We got a question from this post-op management in June 2020 exam. And the question was, till how much time we should avoid the pregnancy? 2 years. All of the following are causes of menorrhagia except uterovesical fistula, yes. Endometriosis of bladder, yes. Vesico-vaginal fistula, will it cause menorrhagia? No. Vesico-uterine fistula is another name of utero-vesical fistula. The question is accept, this is the answer. This will not cause menorrhagia. Management of uretrovaginal fistula A. Uretrovaginal. Chaser-Moyer is for vesico-vaginal. Bori flap is for uretrovaginal. Let's go vesico-vaginal. Layer technique, vesico-vaginal fistula. A 32-year-old lady presents with vesico-vaginal fistula. What is the next step? Now, they are tricky MCQ. Examiner clearly writes the name of fistula. If name of fistula is written in the question, means examiner has already performed methylene blue 3 swab test. Means screening test has already been performed. Now we will switch over to definitive test. Then only examiner knows the name of fistula. So what is the next step? Cystoscopy. Gold standard for vesico-vaginal fistula is cystoscopy. Methylene blue 3 swab test. Now methylene blue 3 swab test would have been the answer to this question if the question was a 32-year-old lady presents with continuous dribbling of urine through vagina and she is unable to pass urine voluntarily. What is the next step? If name of fistula was not written in the question, if only complaint was written in the question, then first of all we will do a screening test. If name of fistula is written in the question, Means examiner has already performed the screening test. Now we have to switch over to definitive test. Urine culture sensitivity pre-op. Chesser-Moyer repair is the name of operation. All of the following are correct regarding vesicovaginal fistula except most common cause in developing countries is obstructed labor. Correct. Repaired after 6 months or 6 weeks to 12 weeks. 6 weeks. Management is Chesser-Moyer repair. Post-op management is rule of 2. Good. Next topic. Congenital malformations of uterus. How a uterus develops. Let me revise your embryology, which has been covered by ma'am in embryology class. How a uterus develops. We also discussed development of male and female in the topic amenorrhea. Let's quickly revise that. So uterus, cervix, fallopian tube, upper two-thirds of vagina, they are formed by Mullerian duct. Lower one-third of vagina is formed by urogenital sinus. These two Mullerian ducts start developing in intrauterine life. How many ducts develop? Two. Right Mullerian duct, left Mullerian. And these two Mullerian ducts fuse caudally. They are developing in above-below fashion. From above below, they are developing like this. In above-below fashion. And they fuse caudally like this. And after fusion caudally, they form urogenital sinus. Urogenital sinus gives rise to lower one-third of vagina. How did they develop? Above below. Around 6 to 7 weeks of intrauterine life. Then they fuse in below upward fashion. How they are fusing? From below above, like this. This fashion is very important. How they are fusing? So they are fusing in the below above fashion, like this. And they fuse at 12 weeks of intrauterine life. They fuse at 12. But what does not happen at 12? At 12 weeks, their inner walls, they don't disappear. Although ducts fuse, but their inner walls don't disappear. It happens at 12 weeks of intrauterine life. And after fusion of two Mullerian ducts, a uterus is formed. A uterus is formed after fusion of two Mullerian ducts. Right Mullerian duct will form right side of uterus. Left Mullerian duct will form left side of uterus. So with these right and left Mullerian duct, a uterus is formed. Since inner walls of Mullerian ducts, they don't disappear at 12 weeks. They persist in the form of a physiological septum. Now what happens at 20 weeks of intrauterine life? These inner walls of Mullerian duct, they also disappear in below upward fashion. नीचे से ऊपर की तरफ. Mullerian duct बनना कैसे शुरू हुई? ऊपर से नीचे. वो फ्यूज कैसे हो रही हैं? नीचे से ऊपर. Inner walls disappear कैसे हो रही हैं? नीचे से ऊपर. I will repeat in English. Mullerian ducts start developing in which fashion? Above below. They fuse in which fashion? Below upward. Inner walls disappear in which fashion? Below upward. Inner walls are disappearing at how many weeks? 20 weeks. So this physiological septum will disappear at how many weeks of intrauterine life? 20 weeks of intrauterine life. So 20 weeks, after 20 weeks, we don't have any physiological septum in the uterus. In other words, a normal uterine cavity is formed at how many weeks of intrauterine life? 20 weeks of intrauterine life. So, if there are defects in their fusion like this, if there are defects in their fusion, there can be various types of abnormality due to these lateral fusion defects because they are fusing like this. If there are lateral fusion defects, there can be tidal phase, bicornuate and lot many. There can be some vertical fusion defects also. Vertical fusion defects mean how do they fuse vertically? Two Mullerian ducts develop in which fashion? Above below. And they fuse caudally to form urogenital sinus. And if there is a defect in this fusion, that may result in formation of a transverse vaginal septum or some vaginal atresia or some cervicovaginal atresia. So let's discuss the abnormality. Fine. Let me draw a ray diagram here. Let's utilize the space which is before this topic on page number 96. These are two Mullerian ducts. They are developing in above-below fashion, like this. And these Mullerian ducts fuse caudally to form urogenital sign. Suppose this is one Mullerian duct, this is another Mullerian duct. Although it has been covered in embryology beautifully, this is just a ray diagram. I am not teaching you embryology, just a ray diagram so that we can understand the abnormalities in a better way. Fine. And after fusion, caudally, they form urogenital sinus. Fine. Mullerian duct lead to formation of uterus, cervix, upper two-thirds of vagina and fallopian tube. Urogenital sinus forms lower one-third of vagina. And what happens at 12 weeks? At 12 weeks of intrauterine life, what is the picture of 12 weeks? What is IUL? Intrauterine life. These Mullerian ducts fuse, but their inner walls don't disappear. So we get a physiological septum here in the uterus. Let's label it. This is a physiological septum because inner walls of Mullerian ducts did not disappear. These inner walls of Mullerian duct, they disappear at 20 weeks of intrauterine life. So what is the outcome at 20 weeks of intrauterine life? We don't have any septum in uterus. So normal uterine cavity we get at how many weeks of intrauterine life? 20. There is no septum inside. We get a normal uterine cavity at 20 weeks of intrauterine life. So this is the embryological development here. Now, let's write the notes and then we have to discuss various abnormalities. There can be some lateral fusion defects, there can be some vertical fusion defects. Two Mullerian ducts start developing at 6 to 7 weeks of intrauterine life. In which fashion? Above-below fashion. They fuse in below-upward fashion at 12 weeks, but their inner walls don't disappear. And they persist in the form of a physiological septum. As we have discussed in the ray diagram, they persist in the form of a physiological septum. Inner walls disappear at 20 weeks and they disappear in below upwards fashion. Disappearance of inner walls of Mullerian ducts occur in which fashion? Below upward fashion. So they developed in above below fashion, they fuse in below upward fashion, and inner walls also disappear in below upwards fashion. So a normal uterine cavity is formed at 20 weeks. So normal uterine cavity is formed at 20 weeks of intrauterine life. What develops from Mullerian duct, uterus, cervix, upper part of vagina and fallopian tube, upper two-thirds of vagina and fallopian tube. What develops from urogenital sinus, lower one-third of vagina. Let's discuss the abnormalities. What are the abnormalities here? Abnormality number one. If Mullerian duct don't fuse at all, if Mullerian duct don't fuse at all, they remain separate. Lateral fusion defects. What will be the outcome? Right Mullerian duct will form right side of uterus, left will form left uterus. They don't fuse at all, so the outcome is a double uterus. Right will form a separate uterus, left will form a separate uterus. So the outcome here is a double uterus. This double uterus is also called uterine didelphys. This double uterus is also called uterine didelphys. Two uterus. No fusion at all. This is the only congenital malformation of uterus in which there are two vagina. No fusion at all, so two separate vagina. Second possibility. If Mullerian duct fuse partially. Now what will happen if they are fusing partial? Fusion occurs in which fashion? They developed in above-below fashion. They fuse in which fashion? Below upward fashion. Let me tell you. They are fusing in which fashion? Below upwards fashion. Like this. They developed in which fashion? Above below fashion. They are fusing in which fashion? Below upward. So if they fuse partially, what's happening if they are fusing partially? Which part will be fused? Lower part or upper part? Of course, they will fuse in lower part because fusion occurs in which fashion? Below upward fashion. So lower part will be fused but upper part will remain separate. This is called bicornuate uterus or a heart-shaped uterus. So you will get a bicornuate uterus or heart-shaped uterus if lower part is fused and upper part is separate. Let's write down. This is the outcome here. This is how we get after fusion of lower part. The outcome is bicornuate uterus which is also called heart-shaped uterus. Fine. This is of two types that we will write below. If Mullerian duct, another abnormality. Look here. What may happen if Mullerian ducts fuse? They fuse in below upward fashion. If they fuse, but their inner walls, they don't disappear like that. If they don't disappear, let me explain you. Mullerian ducts fused, they fused. Inner walls ideally disappear at 20 weeks in below upward fashion. Inner walls, these inner walls, they disappear at 20 weeks in below upward fashion. If they don't disappear even after 20 weeks, what is the outcome? Will this physiological septum disappear? No, it will persist because inner walls, they don't disappear. Now, after 20 weeks, we will call this a pathological septum. And this uterus will be called a septate uterus because this uterus contains a septum because inner walls did not disappear. So septate uterus. Another abnormality can be if inner walls disappear partially. These inner walls, if they disappear partially, they disappear in which fashion? They disappear in below of what fashion? So if inner walls disappear partially, they are disappearing in which part? Lower part or upper part? If they disappear partially, they are disappearing in which part? Lower part. Because disappearance also occurs in below of what fashion? So outcome will be a subseptate uterus. So in subseptate uterus, septum is present in which part of uterus? Upper part of uterus or lower part of uterus? Upper part of uterus. Let's write down. Another abnormality. If Mullerian duct fuse but their inner wall don't disappear even after 20 weeks, the outcome would be something like this. There will be a septum in uterus. It's not physiological, it's pathological. This is why this is called septate uterus. Another abnormality. If inner walls disappear partially, inner walls we know they disappear in below of what fashion? If they disappear partially, inner walls will disappear in which part? Lower part. So they will persist in which part? Upper part. So if inner walls disappear partially, outcome is subseptate uterus. And a very important question. Septum in subseptate uterus is present in which part of uterus? Upper part of uterus. Septum is present in upper part of uterus. If only one Mullerian duct develops, if only one Mullerian duct develops, then what will be the outcome? Only one side will be formed, either a right side or a left side. This is called unicornuate uterus, or also called banana shaped uterus, or also called penis shaped uterus, or also called hemi-uterus. Hemi means half. Hemiplegia, you know, hemiplegia, half side. So hemi-uterus. So these are various names for this unicornuate uterus. If only one Mullerian duct develops, this is a unicornuate or banana shaped or penis shaped or a hemi-uterus. Let us have a look at these HSG images. This is the HSG image. Hysterosalpingography. You are done with radio, you know what is the hysterosalpingography. Hysterosalpingography is an investigation in which we instill the radio-opaque dye through vagina. We instill the radio-opaque dye through vagina and this dye is going inside. So this dye is traveling in uterus, vagina, fallopian tube. And a cannula is used to instill this dye. This cannula is Leach-Wilkinson cannula. We will write later. We will write separately. Leach-Wilkinson cannula. I will show you the cannula. Important cannula. And you can take the photograph of that cannula. I will just show you in 1 minute. So with this Leach-Wilkinson cannula, we instill the dye inside and after 1 minute we take an X-ray film. In this X-ray film, this dye can be seen because the dye is a radio-opaque dye. Wherever the dye is traveling inside, that this is the uterus, you know, and this is the fallopian tube. This is the fallopian tube. We can see this tube nicely. The dye is going here, 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 here. This dye is going in fallopian tube, passing through uterus and going in fallopian tube. So we can see. But if I erase this, what I wrote here, can you see anything on other side? You can't see anything on other side. There's no horn of uterus here. There's no fallopian tube here. So if this HSG image, if this hysterosalpingography image is given to you, what is this image? This is a case of unicornuate uterus. Which uterus is this? unicornuate uterus. And if this film is given to you, what investigation is this? The name of this investigation is hysterosalpingography HSG. Last to last session in NEET PG, they gave the image and they just asked, what is this investigation? They didn't ask, what is this abnormality? They just asked the question, what is the name of this investigation? Name of this investigation is HSG, hysterosalpingography. So let's label, this is unicornuate, we will label. And this is the bicornuate uterus. This is the bicornuate. Why this is the bicornuate uterus? This is the Leach-Wilkinson cannula, this one, Leach-Wilkinson cannula. And the dye is going inside, and we can see this is one horn of uterus, this is another horn of uterus. This is bicornuate or a heart-shaped uterus. Let's compare this bicornuate uterus with a septate uterus, which is not an easy game. It's really difficult. Theoretically, things are very easy to say, but things are really very difficult practically if it comes to differentiation of bicornuate and septate uterus. Many are clean bold here. This is a septate uterus. This is septate. We call this septate uterus. This is the radio-opaque dye. This is that Leach-Wilkinson cannula. This is this Leach-Wilkinson cannula, and the radio-opaque dye is going inside. We can see this is the fallopian tube on this side. This is another fallopian tube on other side. And this is a uterus, uterine horn. But there is no dye here. Why there is a filling defect here in between? Why there is a filling defect here in between? It is because of septum in uterus. It is because of septum in uterus. There is a septum in uterus. This is why dye is not filling this area. This is a septate uterus. Let's compare quickly with the septate uterus and the bicornuate uterus. This is a bicornuate uterus and this is a septate. This is a bicornuate, this is a septate. Can you make out few things? Few things which can be made out are the distance between two horns here. Theoretically, it is 4 centimeter or more than 4 centimeter. It is 4 centimeter or more than 4 centimeter. The angle here, it is also 60 to 65 degree or more than 60 to 65 degree. This is the case of bicornuate uterus. Let's compare this with the septate uterus. In the septate uterus, if you see, the distance here between the two horns, this is less than 4 centimeter. And this angle is also less than 65 degree. Means they are close to each other. This is how we can differentiate a bicornuate uterus with a septate uterus. Let's label these images. So this is an image of bicornuate uterus, bicornuate. And this is the image of a septate uterus. These are hysterosalpingography images. Let us label these. So this is the HSG of what? This is the hysterosalpingography of unicornuate uterus. This is the HSG of bicornuate uterus. This is the HSG of a septate uterus. So we saw 3 congenital malformations of uterus in HSG. Theoretically, we can write the difference between bicornuate uterus and septate uterus. Let's compare bicornuate with the septate. Point number 1 in bicornuate, distance between two horns is 4 centimeter or more than 4 centimeter. Here the distance is less than 4 centimeter. Here the distance is less than 4. Point number 2, angle between two horns here is 65 degree or more than 65 degree. while in septate uterus, this angle is less than 65 degree. So this is how we can compare bicornuate or septate. Although this is just a theory, practically it is altogether a different cup of tea. Septate uterus is much, much more common than bicornuate. Sometimes we are mistaken with the HSG image of bicornuate and finally it turned out to be septate. Septate is much more common than a bicornuate uterus. What is the arcuate uterus? Arcuate uterus or flat topped uterus. This arcuate uterus or flat topped uterus, there is no relation with Mullerian abnormality. Mullerian ducts are perfectly fine. There is no relation with any Mullerian abnormality. They are perfectly fine. By chance, dome of uterus does not develop. This is the arcuate uterus. Dome of uterus does not develop by chance, matter of chance. Mullerian ducts are normal. No relation with any Mullerian abnormality. Another abnormality is a T-shaped uterus. Very, very rare these days. Very, very, very rare. A T-shaped uterus. It was common much before, maybe 30 years before, 40 years before. Because the cause of this T-shaped uterus is use of diethylstilbestrol in utero. Diethylstilbestrol is a synthetic estrogen. It has lot of side effect. So this synthetic estrogen is not used now. It was used much before. And if mother has taken this diethylstilbestrol, and if a female fetus is developing inside her uterus, that female fetus is likely to develop the T-shaped uterus. So the cause of T-shaped uterus is use of diethylstilbestrol by the mother in utero. When this female was developing inside the uterus of her mother, this fetus may develop which uterus? T-shaped uterus. Most common congenital malformation of uterus is the septate uterus. Much more common than a bicornuate. Most common congenital malformation is septate uterus. And second in the row, I can write it here only. Second in the sequence is bicornuate uterus. Bicornuate. So most common congenital malformation of uterus is a septate uterus. Second in the row is bicornuate. I told you we will discuss bicornuate. Bicornuate is of two types. Bicornuate uterus is of two types. What are these two types of bicornuate uterus? Bicornis unicollis means single cervix. Bicollis means two cervix. Vagina is one. In bicornuate uterus, be very clear. Vagina is only one. Cervix may be one or two. If cervix is one, uni. Uni means one. Bi means two. Two cervix, bicollis, single cervix, unicollis. Vagina is one. Two vagina are seen only in uterine didal phase. Which one is more common? Unicollis is more common than bicollis. So there are two types of bicornuate uterus, bicornis unicollis and bicornis bicollis. Most common complication of these congenital malformation of uterus is abortion. Most common complication of congenital malformations of uterus is abortion. Most common malformation is septate uterus. And we know, look here once again, let me show you the ray diagram. This is a septate uterus. What has happened to this septate uterus? There is a septum in the midline. And because of this septum in the midline, space in the uterine cavity is reduced to half. जगह कितनी रह गई अंदर? आधी. दीवार खड़ी हो गई यूट्रस के बीच में. There is septum in the midline of uterus. इस दीवार ने जो यूट्रस के बीच में खड़ी है, जगह को आधा कर दिया. आधी जगह रह गई. I have to balance it out, Hindi or English, you know. I'm receiving many messages. Many students are sending messages. A lot of Tamilian students are in the group. So please speak in English only. Lot of Hindi speaking students are sending messages. Sir, explain in Hindi because it's difficult to understand. So I am speaking what I have decided because many students said that there are many English speaking students, and I know there are many English speaking students in the group. So what I have decided, I have balanced it out. I am speaking a very simple English. Very simple English which can be understood by everyone. So we have to balance it out, because there are many students from many states, Kashmir to Kanyakumari, in this batch. I know. So this is why most common complication is abortion because the space is reduced to half. Now the question arises: which congenital malformation is responsible for maximum abortion? Septate uterus. Most common malformation is septate uterus. And which congenital malformation is mostly responsible for abortion? Septate uterus. Because in septate, the space is reduced to exact almost half. Let's write down. Most common malformation responsible for abortion. In other words, the malformation which has the worst reproductive outcome. What is the meaning of worst reproductive outcome? Pregnancy will not continue. Pregnancy will not continue. That is the worst reproductive outcome. This is with the septate uterus. And second worst is with the unicornuate uterus or a hemiuterus or a penis or banana shaped uterus. Worst reproductive outcome. Most common malformations, septate. Most common complication of malformations, abortion. Most common malformation responsible for abortion or worst reproductive outcome is with which malformation? Septate. Second worst with unicornuate. Best reproductive outcome. What is the meaning of this word? Best reproductive outcome means pregnancy can continue for a longer time. Pregnancy can continue for a longer time. Bicornuate uterus, arcuate uterus. How they are diagnosed? Most of the times we don't even diagnose the arcuate uterus or a bicornuate uterus. Suppose she has 3 children and now she is trying for the fourth one and she finds some difficulty in conceiving for the fourth time or the fifth time. Now she comes to us. Doctor, I want a baby, I have 3, I want a 4th. And then we start investigating her. And during investigation, we find, oh my God, she is having a arcuate uterus or a bicornuate uterus. Because she might have delivered the children and she didn't have any problem because they have good reproductive outcome. Sometimes when we are doing cesarean section, then we are doing operating, then we can see, oh, this is the case of arcuate or bicornuate. But it didn't trouble the fetus because it had good reproductive outcome because space was not much reduced in bicornuate and not at all reduced in arcuate uterus. So the best reproductive outcome is with arcuate uterus. And second best is with bicornuate uterus. Diagnosis. How do we diagnose congenital malformations of uterus? You can get 2 types of questions here. These are tricky questions, We have to read the questions very carefully to crack the best option here. MCQ number 1 may be, what is the most commonly used investigation to diagnose congenital malformations of uterus? Most commonly used one is an ultrasound. Most commonly used is ultrasound. It is cheaper, less expensive, easily available. At every 3 or 4 kilometers, we have ultrasound these days. Now, the question arises, which ultrasound is better? You are done with radio also. Transvaginal sonography, which is popularly known as TVS. Transvaginal sonography is known as TVS, is better than TAS. What is TAS? Transabdominal sonography. So, of course, this is better. Transvaginal sonography. This is better. But write down here, TVS is not done in unmarried girl. TVS is not done in unmarried girl. Pervaginal examination is also not done in unmarried girl. Transvaginal sonography is also not done in unmarried girl. They can harm. Okay? Gold standard. Gold standard diagnosis to diagnose congenital malformations of uterus. What would be the best? Let's understand what would be the best to diagnose congenital malformation. Suppose you are doing a laparoscopy. We know laparoscope is put in which cavity? Laparoscope is put in abdominal cavity. Here in the abdominal cavity. So if laparoscope is put here in the abdominal cavity, this laparoscope will see exterior of uterus or interior of uterus. Exterior, outer part of uterus. And this is uterus. And this is the hysteroscope. Hysteroscope is put in uterine cavity. So hysteroscope will see which part of uterus? Internal part or external part? Internal part. While laparoscope is put in abdominal cavity. So laparoscope will see outer part of uterus. So can laparoscope see a septum inside uterus? No. Can a hysteroscope see a dimple in bicornuate uterus? No. So what is the best investigation to diagnose congenital malformations of uterus? Obviously, it has to be a combination of both laparoscopy and hysteroscopy. Hysteroscope will see internal part of uterus, laparoscope will see outer part of uterus. So hysteroscopy alone, no. Laparoscopy alone, no. If this combination is not given in option, the combination of laparoscopy and hysteroscopy, if this is not given in option, then second best choice would be MRI, magnetic resonance imaging, MRI. Let's write down. The gold standard is a combination of laparoscopy plus hysteroscopy. The second best is MRI. What is the indication of management? Indication of management. When we go for repair of these congenital malformations of uterus, indication of management is if there is history of recurrent abortion. Important MCQ. And what is the recurrent abortion? If there is history of 3 or more than 3 abortion. This is called recurrent abortion. Recurrent abortion is also called habitual abortion. Recurrent abortion is also called habitual abortion. It has become a habit to get aborted. Now it has become a habit to get aborted. This is the indication of management if there is history of recurrent abortion or habitual abortion. Then we go for repair of these congenital malformations of uterus. What repair is done? Last session question, it was asked in June 22 to exam. What is the management of septate uterus? Very simple. If there is a septum inside uterus, we can use the camera of uterus hysteroscope, and with the help of camera of uterus, we can resect the septum. Very simple. This is called hysteroscopic resection of septum. This is called hysteroscopic resection of septum. If it is the case of uterine didelphys or a bicornuate uterus, repair of double uterus, uterine didelphys or bicornuate uterus, this repair is called metroplasty. Metroplasty. In metroplasty, we do unification. Bicornuate, there are two horns, so we have to unite them. We have to unite them. And didelphys also, we have to unite them. This is called unification repair. Another name for this unification is metroplasty. This metroplasty was originally started by Strassman. It was originally started by Strassman. So popularly known as Strassman metroplasty. But when Strassman repaired this bicornuate uterus, camera of uterus was not available. So Strassman repaired it via abdominal route. Means Strassman did a laparotomy. Strassman opened the abdomen. Strassman opened the abdomen. A laparotomy was done because hysteroscope was not invented at that time. But nowadays, we have the camera of uterus. Why to open her abdomen? Why to do a big surgery? We can do a less invasive surgery with the help of camera of uterus. This is called hysteroscopic metroplasty. Put a tick. Nowadays, which metroplasty is preferred? Hysteroscopic metroplasty is preferred nowadays. It was originally started by Strassman. So these were all lateral fusion defects. There can be some vertical fusion defects also. We can write vertical fusion defects. Vertical fusion defects like when we discuss these Mullerian ducts, they fuse caudally, and after fusing caudally, they form a urogenital sinus. And if there is a defect in this vertical fusion, what can happen? There can be formation of a transverse vaginal septum. There can be some vaginal atresia. There can be some cervicovaginal atresia. They're less important. They will not be asked in our exam, just for remembrance. Transverse vaginal septum, vaginal atresia, cervicovaginal atresia, they can cause anatomical obstruction, and they may result in what? Cryptomenoria. They can finally complicate into what? Cryptomenoria. Do you remember cryptomenoria? Hidden menses. What is the most common cause of cryptomenoria? Imperforate hymen. But transverse vaginal septum and vaginal atresia can also cause cryptomenoria. So these are various malformations of uterus, various malformations. Many students, many students messaged me, many students, just few words. Many students message, sir, we did not score optimum marks in anatomy as we were expecting. We were expecting very good marks in anatomy. We prepared anatomy very well. But somehow, sir, we committed many silly mistakes. So we didn't score that much. The take home message should be, the test. Suppose that was the anatomy test yesterday. What is the purpose of this test? This test was not your 4th December examination. The purpose of the test was to prepare you, to acclimatize you as if you are taking an exam on 4th of the December. That was the purpose, and this is the purpose of all the tests. So if you committed silly mistakes in yesterday's test, if you didn't score the expected marks in yesterday's test, what is the take home message right now? We have to take action now. We should not feel depressed with the things which are happening to us. हमको निराश नहीं होना चाहिए, हिम्मत नहीं हारनी चाहिए. कुछ होता है ना लाइफ में, सबकी लाइफ में कुछ ना कुछ हो जाता है, लेकिन उसके बाद सब क्या करते हैं? बाउंस बैक. वी हैव टू बाउंस बैक. वी हैव टू टेक सम एक्शन. Don't feel depressed. Don't feel disheartened. Take action. Just bounce back. And what is the action? Now we have to revise with more concentration. We have less time. We can say that we have less time. Less time, sir. Only some time is left. We have to revise all 19 subjects. And then we have to appear on 4th of December. So everyone has this same time frame. We don't consider that this is a less time. Use more concentration in this time. You have one thing, that is the concentration, and you can elevate your concentration. You can scale your concentration to a higher level. You cannot increase the time span, that is for sure. Let's be very practical. The time frame is same for everyone. But what is different for everyone, which will change the game on 4th of December, is our concentration. The concentration with which we are studying, we can scale the level of that concentration. And how to change, how to scale the level of that concentration, I give you one tip. Just for 10 minutes in a day, try to bring yourself, your awareness, your attention on your breathing. Just try to have a look that, oh my God, this is the inspiration, this is expiration. Breath is going inside, breath is going outside. This is hot here, this is cold here. It is touching right nostril, it is touching left nostril. And like this, for 10 minutes, millions of thoughts will come in this 10 minutes. Look at the game of this 10 minutes. Millions of thoughts will come in these 10 minutes. What you are doing every time, whenever a thought is coming, you are bringing your attention back to the breathing again. So, what is happening? You are developing a habit of bringing back your attention to your breathing again. This habit of bringing back your attention is going to help you when you are studying and revising and we are distracted, maybe by a Facebook post, maybe by an Insta flag. Then we will develop a habit of bringing back our attention to the study, to the revision. And this bringing back of attention will be the game changer in these 2 months time frame. We have to increase our concentration. That is the only game changer, believe me. And have some healthy diet, fruits, salads, few almonds, few walnuts every day. Smoking, alcohol, we have to stop it if we are using this. We have to taper it off. I will not say completely stop if by chance someone is addicted to it. Taper it off. Because smoking and alcohol impair memory like anything. Bad things happen to many in this world. As I told you, when Rama was about to go to the forest for 14 years next day, he went to his father. Father said, I am very sad because you are going to the forest for 14 years. Rama said, Bas itni si baat. This only. Rama said, only this thing and you are sad. Bas itni si baat. कुछ भी हमारे साथ हुआ ना, एनाटॉमी में नंबर कम आए ना कल, बस इतनी सी बात. एनाटॉमी टेस्ट में कल नंबर थोड़े कम आए, बस इतनी सी बात. एक्शन. ऐसा नहीं है कि बस इतनी सी बात बोल के ओहो अमित सर ने कह दिया बस इतनी सी बात, ओहो हम तो जा रहे हैं पिक्चर भी देखेंगे सब. ना ना ना, अमित सर ने बोला बस इतनी सी बात, मतलब दुखी नहीं होना, लेकिन क्या करना है, बाउंस बैक, अटेंशन इंक्रीज करना है, कंसंट्रेशन इंप्रूव करना है. और आज की पढ़ाई को टुडे वी विल स्टडी विद मोर कंसंट्रेशन, विद मोर एनर्जी, एंड वी हैव टू रिवाइज द स्टफ्स क्विकली. पढ़ना नहीं है कुरान, रामायण, बाइबल, सत्यनारायण की कथा की तरह वर्कबुक को खोल के नहीं बैठ जाना. जल्दी जल्दी पेज को टर्न करना है. डू इट क्विकली. लेट्स सॉल्व द क्वेश्चंस एंड देन वी विल हैव टी, एंड आफ्टर द ब्रेक, टी ब्रेक, वी विल सॉल्व yesterday's telegram questions and we will focus on the silly mistakes we committed in yesterday's question. Fine. Let's solve the question. Identify above image. Identify above image. Now, let's have a look here. Let's have a look. What is this image? This is the image of uterine didelphys. How do you identify that this is not bicornuate uterus, this is uterine didelphys? We can see two Leach-Wilkinson cannula here. This is one Leach-Wilkinson cannula, this is another Leach-Wilkinson cannula. So how many Leach-Wilkinson cannula are there? Two Leach-Wilkinson cannula. Because there are two vagina. Because there are two vagina, we use two Leach-Wilkinson cannula, and we can see this radio-opaque dye is passing via these two Leach-Wilkinson cannula. This is one side of uterus, this is another side of another uterus. So right Mullerian duct formed right uterus, left Mullerian duct formed left uterus. So there are two separate uteri. How do you identify that this is not bicornuate? This is uterine didelphys by two Leach-Wilkinson cannula because there are two vagina. Two vagina are seen only in one malformation, that is uterine didelphys or double uterus. Let's again compare this image with bicornuate uterus. Let's have a look. This was bicornuate uterus. In bicornuate uterus, how many Leach-Wilkinson cannula? There was only one Leach-Wilkinson cannula in bicornuate uterus. While there are how many Leach-Wilkinson cannula in uterine didelphys? Two Leach-Wilkinson cannula in uterine didelphys. Let's have a look at this image once again. This is uterine didelphys or double uterus. Let me show you an image of Leach-Wilkinson cannula, and you can take the photograph of this Leach-Wilkinson cannula. This is the Leach-Wilkinson cannula. Let me label the image and then you can take a pic of this. This is Leach-Wilkinson cannula. Important image question for our exam. This Leach-Wilkinson cannula, important image question for our exam. Through this Leach-Wilkinson cannula, we instill the radio-opaque dye in the uterus. And this is this Leach-Wilkinson cannula which we are seeing in the hysterosalpingography images, HSG image. This is Leach-Wilkinson cannula. Now, I will give you these images. I will give you these images separately also. We will discuss on Telegram also. I will give you as a poll question also with this image. Don't worry. So identify above image. Is it an ultrasound image or a HSG image? HSG image. This is hysterosalpingography. Bicornuate or didelphys? This is didelphys. This is not ultrasound. This is a hysterosalpingography uterine didelphys. Let's label this image here as well. This is didelphys, uterine didelphys or double uterus. Two Leach-Wilkinson cannula, two vagina. Most common uterine malformation associated with infertility is septic. Most common complication is abortion, but they can cause infertility also. Infertility is not the most common complication. If you want to write, you can write where we wrote the complication. Most common complication is abortion. Other complication may be infertility. But answer to the MCQ will remain abortion. Indication of repair is also if there is history of recurrent abortion or habitual abortion. All of the following are correct regarding bicornuate uterus except fusion of upper part of Mullerian duct. No, there occur fusion of lower part of Mullerian duct in bicornuate. Unicollis is more common than bicollis, correct. Can cause abortion, correct. Best treatment is hysteroscopic metroplasty, correct. So fusion of lower part of Mullerian duct occurs in bicornuate. A female had miscarriage for 3 times. What investigation is shown in above image? This is the NEET PG question, and the question was what investigation is shown in the above image. The investigation is hysterosalpingography. But tell me the name of the abnormality. What is the name of this abnormality? Name of this abnormality is unicornuate uterus. This is a unicornuate uterus. Only on one side, other side, everything is absent. So NEET PG question was just identify the investigation. This is the X-ray film and we can see the radio opaque dye instilled inside. So this is a hysterosalpingography. A 23-year-old lady with history of two stillbirth abortions, USG is suggestive of uterine anomaly, which test is done to confirm diagnosis. In other words, examiner is asking what is the best investigation for diagnosis of congenital malformations of uterus, hysteroscopy plus laparoscopy. If combination of hystero and lepro is not given in option, second best answer would be MRI. So this combination has to be given. Hysteroscopy alone is not superior to MRI. Laparoscopy alone is not superior to MRI. Where we wrote laparoscopy and hysteroscopy, we have clearly written MRI. If combination is not given, then answer will be MRI. So let's take a 20 minutes break and see you at 12:20 and we will solve telegram questions after the break. Infertility. What is the meaning of infertility? Infertility means a couple is trying to conceive, to have a baby, and they're not able to have a baby. This is called infertility. So, what is the time frame for infertility? When we say that this is an infertile couple, they're trying for baby, but they're not able to conceive. So the time frame is 1 year. Why we have chosen this time frame as 1 year? Because it's not 100% probability of getting a child in one act of intercourse, even if intercourse happens on day 14 of a regular cycle, where the ovulation occurs. Ovulation occurs on, suppose, on the day of ovulation. On the day of ovulation, a couple is trying to have intercourse. So, very less chances of having a child with one intercourse. Less chances. This is why we have given a time frame for 1 year that they have tried their level best, they are staying together. It's not like this that male partner is living in London and a female is living in New York, and after 1 year they are landing at New Delhi airport and going to clinic of doctor and saying, Doctor Saab, we are married for 1 year and we didn't have a baby. So they have to live together, having intercourse around day of ovulation also, at least 3 or 4 times in a month around ovulation. And they tried for 1 year, then we label it infertility. So failure to conceive even after 1 year of unprotected and regular intercourse. So intercourse has to be unprotected and regular. This is infertility. This is the definition of infertility. Infertility can be primary infertility or secondary infertility. Primary infertility means she never conceived before. Never conceived. Fertilization did not occur. She never conceived before. This is primary infertility. Secondary infertility, she conceived before, fertilization occurred before. This is secondary infertility. But now she's trying. She's trying now, but now she is facing difficulty. But facing difficulty now. This is secondary infertility. So we are very clear with the definition of infertility. Failure to conceive even after how much time? 1 year. That's the MCQ catch. Of which intercourse? Unprotected and regular. Then infertility can be of two types, primary and secondary. Primary, she never conceived before. Secondary, she conceived before. Fertilization occurred before, but now she is facing difficulty. There is another term called sterility. What is this sterility? Sterility, it is due to permanent damage to gametes. So, sterility is absolute inability to conceive. Sterility means absolute inability to conceive. Absolute inability means fertilization cannot occur. Absolute inability to conceive, and this is due to permanent damage to gametes. Absolute inability to conceive due to permanent damage to gametes. This is sterility. Infertility, statistics, these statistics will not be asked in our exam, just to understand which factors are more responsible for infertility. That's all. just to understand that. Females are little more responsible than males because they have many factors, We want oocyte from the ovary, then fertilization occurs in the tube, then sperms are traveling via cervix, vagina, and uterus. And male has to give the sperm. So, of course, female factors are more responsible. They have multiple things to do. Combined means both male and female. If a couple comes to you and you find the problem both in male and female, that is approximately 10%, and 10% cases remain unexplained. We are not able to find any cause. So, overall, most common cause is female. They are little more responsible than male because of multiple factors. Female factors. Approximate statistic. Most common cause of infertility overall is ovarian disorder. Ovarian. What we want from the ovary. Secondary oocyte is released at the time of ovulation, and this oocyte is picked up by the fimbria of fallopian tube. You know the basic anatomy. Fimbria picks up the oocyte, and this fimbria, after picking up the oocyte, propel it to the ampulla of fallopian tube, and ampulla of fallopian tube is most common site of fertilization. The ovarian disorder, 45%. Tubal disorder. Tube has to be patent, Suppose, just for understanding, this is the ray diagram. This is ovary. What is released out of ovary at the time of ovulation? What is released out of ovary at the time of ovulation? Secondary oocyte. This secondary oocyte is released from the ovary. And suppose this is the fimbria. Let me draw the fimbria properly now. This is the fimbria. And the largest fimbria picks up the oocyte from this ovary. This is the oocyte here. Oocyte is released from the ovary, which is picked up by the largest fimbria, which is fimbria ovarica, and this reaches ampulla, and sperm is traveling from this side. So this end of the tube should also be open, and this end of tube should also be open. Means proximal end or cornual end, distal end or fimbrial end. Both the ends should be open. From one end of fallopian tube, oocyte will enter fallopian tube. From other end of fallopian tube, sperm will enter. So this proximal end, this has to be open. This distal end or fimbrial end, this should also be open. So what we want, tubes should be patent. They should be open. Uterine and cervical factors. Sperms will be passing through this cervix and uterus. So there should not be any problem here in the cervix. There should not be any problem in the uterus. Unexplained infertility, 10%. So overall, if we look at this statistic, nobody will ask you the percentage. Just remember one MCQ from this. We have ticked it. What is the most common cause of infertility? Female factor. In female factor, the most common is ovarian disorder. And what you want from ovary, secondary oocyte, which is released after ovulation. So ovulation should happen normally, and this is the most common cause, that is anovulation. If there is no ovulation, we will not get any oocyte from the ovary. Fertilization will not occur. Ovarian disorder is the most common, so most common cause of infertility is anovulation. Overall, one word answer. What is the most common cause of infertility? Anovulation. Anovulation is the MCQ factory. What is the most common cause of anovulation in the world? PCOS, we know. Most common cause of anovulation we have written in the topic PCOS. PCOS, polycystic ovary, is the most common cause of anovulation. Polycystic ovary is the most common cause of hirsutism. Which was the most common fibroid? Intramural. Which was the most common prolapse? Cystocele. Which was the most common fistula? Vesico-vaginal fistula. This anovulation is the most common cause of infertility. Anovulation is not only most common cause, This is most easily diagnosed cause of infertility. Most easily diagnosed cause of infertility, not only most easily diagnosed cause, this anovulation is most easily treatable cause of infertility. Most easily treatable cause of infertility. Most easily diagnosed cause, most easily treatable cause. So, in other words, anovulation is most reversible form of infertility. So, anovulation is the MCQ factory. Most common cause of infertility, anovulation. Most easily diagnosed cause of infertility, anovulation. Most easily treatable cause of infertility, anovulation. So, most reversible form of infertility, anovulation. Causes of anovulation. What are the causes of anovulation? WHO has classified the causes of anovulation. This classification has been given by World Health Organization WHO. Causes of anovulation are categorized as HPO axis failure. There is failure of hypothalamo pituitary ovarian axis. The failure occurs in which syndrome? We know Kalaman syndrome. Kalaman syndrome was due to mutation in KAL1 gene. There occurred defective migration of neurons from olfactory placode, which are required for synthesis of GnRH. So this was HPO axis failure, Kalaman syndrome. The most common is HPO axis dysfunction. Most common is the dysfunction. It is not the failure of the HPO axis. It is the dysfunction of HPO axis which is most common cause of anovulation. And dysfunction accounts for approximately 85%. And which dysfunction is most common? Polycystic ovarian syndrome, PCOS. So one is PCOS, other one is hyperprolactinemia. Prolactin levels are high, and we know prolactin gives negative feedback to GnRH. And if there is negative feedback to GnRH, pituitary will not be stimulated, FSH will not be secreted, ovary will not be stimulated, estrogen will not be secreted. There will not be LH surge. Which hormone is required for LH surge? Estrogen, estradiol. In between these two, which one is most common? We know very well. PCOS. We have written most common. So overall most common cause of anovulation is PCOS. Third one is premature ovarian failure, which is a rare cause of anovulation. It accounts only for 5%. Rare cause. We can write the rare cause of anovulation. By chance, she is a young lady, around 35 years of age, 30 years of age, whatever it is, less than 40 is premature ovarian failure. What is premature ovarian failure? If ovaries fail before the age of 40 years. This is called premature ovarian failure. Rare cause of anovulation. But the most common cause of anovulation is HPO axis dysfunction. So this classification was given by WHO to categorize the causes of anovulation: HPO axis failure, HPO axis dysfunction, premature ovarian failure. Out of these three, the most common is HPO axis dysfunction. And which dysfunction is most common? Polycystic ovarian syndrome. How to diagnose anovulation? Diagnosis. We know anovulation is the most easily diagnosed cause of infertility. How to diagnose? So we can diagnose anovulation in vagina, in cervix, in uterus, and from ovary also. How? What we look in vagina? Maturation index. What is maturation index? This is ratio of superficial cells intermediate cells, basal and parabasal cells. If we are counting total 100 cells, maturation index, vaginal epithelium, these three types of cells are present in vaginal epithelium. Which three types? Superficial cells, which are also called cornified cells or eosinophilic cells. Other cells were intermediate cells. Third were basal or parabasal cells. Do you remember? For maturation index, superficial cells are always written towards right side. Basal, parabasal towards left side. Intermediate cells in between. After ovulation, maturation index shifts from right to left. First half 0, 40, 60. Second half 0, 70, 30. Pregnancy 0, 95, 5. Before puberty 100, 0, 0. So it is shifting from right to left after ovulation. Means after ovulation, maturation index become 0, 70, 30. Means number of which cells increase after ovulation? Intermediate cell. This is what we have to see if we are calculating maturation index. Okay, fine. What is the ideal day to see maturation index in a lady? The ideal day should be 8 days after ovulation. Because what happens 8 days after ovulation, activity of corpus luteum is maximum. Because activity of corpus luteum is maximum 8 days after ovulation, maximum amount of progesterone will also be on 8 days after ovulation. So all the changes which are due to progesterone will also be maximum on how many days after ovulation? 8 days after ovulation. So number of intermediate cells will also be maximum on how many days after ovulation? 8 days after ovulation. So all the tests, most of the tests to diagnose whether ovulation has occurred in this cycle or not should be done ideally 8 days after ovulation. First of all, we can calculate the day of ovulation by subtracting 14 from the cycle length. Then we can add 8 days. Suppose we take an example of a regular cycle which is of 28 days. So in 28-day cycle, ovulation is supposed to occur on day 14. So activity of corpus luteum will be maximum on 14 plus 8, that is 22nd day. Somewhere between 21st to 22nd day. So we can check maturation index on this day. What can we see in cervix on this day only? Day 21 to 22. Cervical mucus. Under influence of estrogen, this is thin, watery, profuse, alkaline, elastic, can be stretched up to 10 centimeter and it does not break. This phenomena is called spin-Barrett phenomena. And after ovulation, when progesterone is high, under influence of progesterone, it will become thick, scanty, non-elastic. If you try to stretch it, it will break. This is called tack phenomena. So if you check cervical mucus 8 days after ovulation, if you can stretch it, it is thin, watery, profuse, alkaline. Has ovulation occurred in this lady? No. And if it breaks, it is not elastic, it is thick, scanty, ovulation occurred. Very simple, logical thing. No rocket science. You can do an endometrial biopsy also. In endometrial biopsy, suppose you are doing endometrial biopsy on 8 days after ovulation. If ovulation has occurred, we know under influence of progesterone, glycogen and lipids are stored in endometrium in tiny numerous vacuoles in liquid form. So if we take some endometrial tissue on 8 days after ovulation, we can see the vacuoles in endometrium. If we don't see the vacuoles, we see only the glands, means ovulation didn't occur. Proliferation of glands occur under influence of which hormone? Estrogen. If you see vacuoles or corkscrew or sawtooth glands, ovulation has occurred. We can do her blood test also on 8 days after ovulation. If ovulation has occurred, levels of progesterone should be at least how much? 3 nanogram per ml. So if you check her blood for progesterone, levels of progesterone should be at least how much? 3 nanogram per ml. If they are less than this, ovulation didn't happen. If they are 3 or more than 3, ovulation has occurred in this lady. Very simple, logical thing. Best test to diagnose an ovulation is the serum progesterone estimation. But most commonly done test to diagnose ovulation is serial ultrasonography. Serial ultrasound means multiple settings of ultrasound. We are calling her for ultrasound multiple times. This is also called ovulation study. This is also called follicular monitoring because we are monitoring the growth of follicle, follicular monitoring. This is called ovulation study. We are checking for whether ovulation occurs or not. So we start doing it from day 9 or day 10 of the cycle. What is the pattern of follicular growth? Follicles grow at the rate of 2 millimeter per day. Suppose you called her on day 9 of the cycle or day 10 of the cycle. A size of the follicle is somewhere around 8 mm suppose or 9 mm suppose. How much it is expected tomorrow? It is growing at what rate? 2 millimeter per day. So if it is 8 millimeter today, tomorrow it should be 10, day after it should be 12 and so on. So we start monitoring the growth of this follicle and we monitor it daily or with a gap of 1 or 2 days depending on the size of follicle. And we see that this follicle is growing. Suppose yesterday I measured the size of follicle, it was somewhere around 16 or 18 mm. And I will call her next day. I will not give a gap now because anytime it may rupture. Because follicles rupture between 18 to 22 mm. So if I have called her today and today if I don't see any follicle, yesterday there was a follicle, today there is no follicle. So what has happened to the follicle? Follicle has collapsed, it has ruptured, means ovulation has occurred. Yesterday I saw the follicle, today I don't see the follicle, means follicle has ruptured. And once follicle has ruptured, it has collapsed. Follicle contains fluid, which is called liquor folliculi. It contains fluid. It is full of fluid. This is why on ultrasound they appear black. Once follicle ruptures, where this fluid will go? If follicle is rupturing here in abdomen, where this fluid will go? This fluid will go in the most dependent part of peritoneal cavity, that is pouch of Tekla. So what will be the evidence of ovulation? Ruptured follicle and free fluid in pouch of Tekla. So that's how we can diagnose an ovulation. We can predict ovulation also, that when ovulation will occur. This prediction of ovulation is done by LH kits. This prediction of ovulation is done by LH kits. What these LH kits detect? These LH kits detect LH surge. These LH kits detect LH surge. What these detect? LH surge. LH surge, which occurs approximately 24 to 36 hours before ovulation. So if LH kits are positive, we can tell her, oh, ovulation may occur anytime between 24 to 36 hours from now. So you should stay together, you and your husband, you should live together, stay together, and you should have intercourse for at least 4 or 5 times in next 24 to 36 hours. So this is how we can predict ovulation also. Let's write the notes. Maturation index, all these tests for ovulation, they will be done on day 22 of regular cycle. Regular cycle. And if ovulation has occurred, we are writing everything if ovulation occurred. If ovulation occurred, maturation index should be 0, 70, 30. We have written this already. This is written. If ovulation occurred, intermediate cells are maximum. What will you see in the cervix? cervical mucus. Again, on day 22 of the regular cycle, if ovulation has occurred, cervical mucus should be thick, scanty, non-elastic. Will break on stretching, means TEC phenomena. We can do endometrial biopsy. Again, on day 22 of regular cycle, if ovulation occurred, we can see vacuolation. Earliest is vacuolation. Later on, we have already written the notes. When they become heavy and tortuous, these are called corkscrew glands or sawtooth glands. If these are not seen, ovulation has not occurred. Best test to diagnose ovulation or anovulation is serum progesterone. Means we are doing a blood test. We are doing a blood test again on day 22 of regular cycle. And we all know if ovulation has occurred, levels of progesterone should be at least how much? 3 nanogram per ml. They should be at least 3 nanogram per ml. Another MCQ, the most commonly used investigation to diagnose an ovulation. Best test to diagnose an ovulation is serum progesterone estimation. Most commonly used is serial ultrasonography. Please don't commit a mistake. This is not ultrasonography. This is serial ultrasonography, which is also called follicle monitoring or follicular monitoring or ovulation studies. This is called follicle monitoring or ovulation study. This is the most commonly used investigation to diagnose whether ovulation occurred in her or not. And what is the evidence of ovulation? Evidence of ovulation in ultrasound would be remove this arrow from here. Let's put another arrow here. Evidence of ovulation would be ruptured follicle. This follicle has ruptured. This has collapsed. Ruptured follicle plus free fluid in pouch of Douglas. Where the fluid will go? It will go in pouch of Douglas, which is the most dependent part of peritoneal cavity. There's another word called prediction of ovulation. Predictor. Prediction of ovulation is done with the help of LH kits. And if the test is positive, prediction is done with the help of LH kits. And if it is positive, ovulation may occur. These LH kits detect LH surge. Ovulation may occur within the wide range 24 to 36 hours. We don't pinpoint. The best number is 36. But we don't pinpoint that you should have intercourse after 36 hours from now. We give a wide range. She will beat us. Doctor, I just followed you moment by moment. So we are giving her a wide range. Management of anovulation. Management of anovulation. We have diagnosed whether ovulation occurred in her or not. What is the management of anovulation? Let's discuss the causes of anovulation, and according to the cause, we will manage anovulation. WHO gave us 3 causes of anovulation: HPO axis failure, HPO axis dysfunction, and premature ovarian failure. If it is a case of HPO axis failure, which is Kelemen syndrome, what is given for management? We already wrote in the Kelemen syndrome. What is the treatment of Kelemen syndrome? Pulsatile GnRH. Pulsatile GnRH is given whenever we want to stimulate the activity of HPO axis. Continuous GnRH is given whenever we want to suppress the activity of HPO axis. This is why for treatment of Kelemen, pulsatile GnRH, for treatment of delayed puberty, pulsatile GnRH, third line management of infertility in PCOS, pulsatile GnRH. We wanted ovulation. In PCOS, it was anovulation. Treatment of precocious puberty and precocious menarche, continuous GnRH. Treatment of endometriosis, continuous GnRH. Treatment of fibroid, continuous GnRH. We want to suppress the axis to reduce the estrogen. If it is a case of HPO axis dysfunction, and if the dysfunction is due to PCOS, what is the drug of choice to treat infertility due to PCOS? Letrozole. And if letrozole is not given in option, then second best answer is clomiphene citrate. Second best answer is clomiphene citrate. And if the cause of this dysfunction is hyperprolactinemia, if it was PCOS, letrozole. If the cause is hyperprolactinemia, which drug is given? Bromocriptine. Antiprolactin drug cabergoline was used to treat tumors, pituitary tumor, because the half-life was longer. They were required only 2 times in a week. But bromocriptine is more effective. So in infertility management, bromocriptine is preferred. Treatment is not for years. What is the side effect of all these drugs which we are using? Side effect of these ovulation-inducing drugs we have already written in PCOS topic. These ovulation-inducing drugs may cause hyperstimulation syndrome. And this hyperstimulation syndrome means more than one follicle become mature in a cycle, in a month. Ideally, what happens? Normally, one follicle becomes a mature follicle because initially many follicles start growing. As soon as one follicle attains size of 14 millimeter, other follicles start regressing. This we have written in our notes in first topic, menstrual cycle. More than one follicles become mature. Sperms are already in millions. Many will be fertilized, which will result in multifetal pregnancy. Multifetal pregnancy. Look here, this is the image question which was asked in our exam. This is our exam question 2 sessions before. This image was given and they asked identify the image. Identify this image. This is the image of hyperstimulation syndrome. More than one follicles become mature. Normally only one follicle becomes mature. Now the differential diagnosis is, this picture can be confused with polycystic ovarian syndrome, PCOS. Can you make out the difference in polycystic ovary picture and a hyperstimulation syndrome picture? The difference is, in polycystic ovarian syndrome, there was thecal hyperplasia in the center. There was thick stroma in the center, which was displacing all the follicles towards periphery and giving it a necklace sign or a string of pearls sign. Here there is no thick stroma in the center. Let me show you a pic of PCOS once again. Let's compare with that pic of PCOS right now. So we can easily differentially diagnose. Look here. This was PCOS. This was polycystic ovary. Let's compare. This is the polycystic ovary. There are many follicles, but all the follicles are small. They are between 2 to 9 millimeter. And all of them have been displaced towards periphery because of this central thecal hyperplasia. Central thecal hyperplasia. They are all displaced towards periphery. Necklace sign or a string of pearl sign. This was polycystic ovary. Let's compare this again with the picture of hyperstimulation syndrome. So there is no thecal hyperplasia in the center. Let's label. This is the image of hyperstimulation syndrome. Our exam question last to last session. Hyperstimulation syndrome. Let's compare it with the third image. This is the normal image. What happens normally in a month in a lady? What happens normally in a month in a lady? How many follicles become mature in a lady in a month? Just one follicle becomes mature. You can see. Other follicles have regressed. Only one follicle become mature. This is why most common type of pregnancy is single pregnancy. Let's label this image. This is normal. Normal image. And this is the peak of a mature follicle. 18 to 22 sized mature follicle. So how many follicles become mature in a lady in 1 month? One follicle. So this is a normal mature follicle. That was hyperstimulation syndrome, and PCO we know. We can easily compare these three images. So normal image, hyperstimulation syndrome, and no confusion, no silly mistake with polycystic ovarian syndrome image. Now, we have discussed these two causes. If HPO axis failure, pulsatile GnRH. If HPO axis dysfunction, if it is due to PCOS, best drug is letrozole. Letrozole not an option, clomiphene citrate. Hyperprolactinemia, bromocriptine. The third cause was premature ovarian failure. If the cause of an ovulation is premature ovarian failure, if the cause of an ovulation is premature ovarian failure, although this is rare, we know, although this is rare, 5% only, and she wants a baby, we diagnose that ovaries have failed in her. How we diagnose the ovarian failure, that we will discuss in the next topic, menopause. How ovarian failure is diagnosed. We will discuss. If we have diagnosed that ovaries have failed, what is premature ovarian failure? If ovaries fail before the age of 40 years. And she wants a baby, her ovaries have failed. Now the only option is we can have donor oocyte. She cannot have her own biological baby. So management of infertility in this case would be, we cannot try any drug here. We cannot try. Ovaries have failed already. The only option, if she wants a baby, she is infertile, that she has to hire or she has to purchase egg from some of the family members or from the market. And then we will do in vitro fertilization. So management here would be in vitro fertilization. In vitro fertilization, full form is IVF, and this will be done with her oocytes or donor oocytes. This will be done with donor oocytes. Her ovaries have failed. We cannot try any drug now. No drug treatment. So if she wants a baby, the only option she has here, we will do an in vitro fertilization, but not with her oocyte, with donor oocyte. Tubal disorder. After an ovulation, after ovarian disorder, let's discuss the tubal disorder. What's wrong in the fallopian tubes? Most common is tubal block. Tubal block. Most common cause of tubal block is PID. Other is endometriosis. We discussed these diseases yesterday. In PID, pus was formed. In endometriosis, this was blood. Pus was causing formation of fibrous band. In endometriosis, blood was causing formation of fibrous band. The cause of tubal block in both PID and endometriosis was fibrous band formation. And if fibrous bands are formed, what happens? Cornual end or fimbrial end of fallopian tube will be blocked. Another cause here is a syndrome which is Carter-Jenner syndrome. You know Carter-Jenner syndrome better than me. It is ciliary dysfunction. Ciliary dysfunction. So in tubes, tubal block is the disorder because we want the open tubes, patent tubes. We discussed why we want patent tubes. And tubal block, most common cause of tubal block is PID. Another cause endometriosis. Rare cause is Carter-Jenner syndrome. How do we diagnose tubal patency? This tube can be blocked either at fimbrial end or at cornual end. We discussed with the ray diagram. This is fallopian tube. This is ovary. What enters from fimbrial end, this is secondary oocyte, which enters from this place. And secondary oocyte is picked up by the largest fimbria, fimbria ovarica, reaches ampulla. And what is entering through the cornual end of fallopian tube is sperm. And then fertilization mostly occurs in ampulla. So we want both cornual end and fimbrial ends of tubes to be open. This is the cornual end of tube. You are done with anatomy. This is cornual end of the tube, and this is the fimbrial end of the tube. Towards fimbria is the fimbrial end of the tube. We can write two MCQs here. Most common cause of cornual block means proximal block. Cornual block or proximal block is TB, tuberculosis. Yesterday we discussed genital TB. In genital TB from ampulla of fallopian tube, in 80% cases, mycobacterium were traveling towards endometrium. So which side was blocked by TB? Cornual side mostly. While most common cause of fimbrial block, these are chlamydia and gonorrhea. We discussed in the PID topic. Chlamydia and gonorrhea. Chlamydia and gonorrhea mostly cause fimbrial block, while TB mostly cause cornual block, proximal block. How to diagnose whether tubes are blocked or patent? Whether there is a tubal block or tube is open. What should be the principle of test? Let's discuss. What should be the principle of this test? Principle of this test should be, look here. Principle of this test should be, suppose this is uterus, this is vagina, and this is fallopian tube. What we can try here, we can push some fluid here from vagina. We can push some fluid from vagina, from here. And then we can see whether this fluid is passing out of fimbrial end of fallopian tube or not. We can push some fluid from vagina and then we can watch whether this fluid is coming out of fimbrial end of fallopian tube or not. If this is coming out of fimbrial end of fallopian tube, of course tube is open, then only it can come out. And if it is not coming out of fallopian tube, of course tube is blocked. Very simple. This is the principle of tubal patency test. Now various machines can be used. If we want to check the tubal patency with the help of an X-ray machine, then which fluid should be instilled? Of course a radio-opaque dye. Only a radio-opaque dye can be visible in an X-ray film. So if you are checking tubal patency with the X-ray machine, we have to use a radio-opaque dye. If you are using an ultrasound machine, no need for a radio-opaque dye, you can instill any fluid. And if you are doing it via laparoscopy, laparoscope is put in abdominal cavity, then we use a blue colored dye. Then we inject this blue colored dye through here, through vagina, and then we can see whether this blue colored dye is coming out of fimbrial end of fallopian tube or not. If it is coming out of fimbrial end of fallopian tube, tube is open. So this is the principle of these tests. So if you are using an X-ray machine, procedure is called HSG. Full form of HSG is hysterosalpingography. If you are using ultrasound machine, the procedure is called sonosalpingography. Sono means ultrasound. Salpingo means fallopian tube and graphy means imaging. Sono means ultrasound, salpingo means fallopian tube, graphy means imaging. Let's write it here. If we are using a X-ray machine, then the procedure is called HSG. Full form of HSG is hysterosalpingography. Hysterosalpingography. Overall best test, best out of the three, X-ray, ultrasound or laparoscopy, the best test to diagnose tubal patency is laparoscopic chromopertubation. Laparoscopic chromopertubation. Chroma means color. Chromo means color. So which dye is used? Methylene blue. Our exam question 2 sessions before. The simple question was which dye is used in the procedure laparoscopy, chromopertubation, methylene blue. Answer is methylene blue. Chroma means color and we have to see whether this is coming out or not. How this laparoscopic chromopertubation is done? This is the laparoscope everyone knows. This is the laparoscope. And this laparoscope is put in which cavity? Abdominal cavity. Now we have to see whether this blue colored dye is coming out of fallopian tube or not. We can see with the camera of laparoscope. And this is the laparoscopy image. This is the image of a blocked fallopian tube. We instilled the blue colored dye and you can see, let me outline the fallopian tube. This is the swollen fallopian tube. Dye is collected inside, it is not coming out of fallopian tube. Now this dye is filled with blue colored dye. So this is the laparoscopy image. Let's label the image. This is laparoscopy image. So the best test to diagnose tubal patency is laparoscopic chromopertubation. What we have to see here, just write down one common thing here. Instill fluid via vagina. First step. Just write one more point. If fluid comes out of fimbrial ends of fallopian tube. If fluid comes out of fimbrial end of fallopian tube, tubes are patent or that particular tube is patent. If it doesn't come out, tube is blocked. This is the principle of these tubal patency tests. We are instilling the fluid via vagina and it should come out. In hysterosalpingography, we used a cannula, Leach-Wilkinson cannula. Tests for tubal patency, they are done on day 10. Tests for tubal patency, they are done on day 10. Why they are done on day 10? This is a thumb rule. Whenever we are instilling some fluid, it should not be after ovulation. She has come to you for a baby. And if by chance fertilization occurred in this cycle, you instill a fluid and this fluid is going to dislodge the fertilized ovum out of fallopian tube. So they have to be done before ovulation. Now before ovulation, normal duration of blood flow during menses is 2 to 7 days. So if you push the fluid within first 7 days, and suppose there is some fluid in uterine cavity, and you are pushing the fluid from outside. So what you are doing? You are pushing that menstrual fluid back. So you are creating an artificial endometriosis. So they are done before ovulation, not during first 7 days. Average is day 10. Most commonly used test to diagnose an ovulation, that is serial ultrasound was also started on which day? Serial ultrasound was also started on day 10, 9 to 10. Started on day 10. We started this ultrasound from day 10 and then we are doing multiple settings of ultrasound. We are calling her next day or day after tomorrow depending on the size of follicle. Now, management of tubal block. It depends on site of block, where the tube is blocked. Suppose there is a cornual block. Cornual block like means you instilled the fluid. And this fluid, you instilled the fluid from here, and this fluid doesn't go beyond this point. This fluid does not go beyond the cornual end. These are the cornual ends or proximal. In an X-ray film, you are not able to see fluid beyond this cornual end. This is bilateral cornual block. So, what is the most common cause of bilateral cornual block? If you don't see fluid is passing beyond cornual end. Most common cause of bilateral cornual block is physiological spasm. Most common cause of bilateral cornual block is physiological spasm. Means because of anxiety, because of some apprehension, she became nervous, anxious, anxiety. Tube went into spasm, contracted. This is why fluid didn't pass beyond this. This is the most common cause of bilateral cornual block. So if you see a bilateral cornual block in an X-ray film, what should be done? We think, oh my God, this could be because of her anxiety also. Tubes went into spasm. It is a physiological spasm. And this is why we cannot see any fluid beyond the cornual end of tube. So what has to be done immediately after this? We try to pass a cannula from this place. We try to pass a cannula from this place. Like this. We try to pass a cannula from here. It is a thin wire. It is a thin wire. Under camera guidance, we look with the hysteroscope, and while looking with the hysteroscope, we are passing this cannula into the cornual end. If it was a physiological spasm, we will be able to pass the cannula beyond the cornual end. If you are able to pass the cannula beyond the cornual end, what comes to your mind? What comes to your mind that it was only a physiological spasm. It was not a pathological block. So hysteroscopic tubal cannulation is done. And if you are able to pass the cannula, what comes to your mind? It was a physiological spasm. It was not a pathological block. If able to pass the cannula beyond this cornual end, it was a physiological spasm, we will confirm it by, it is followed by laparoscopic chromoperturbation. Now we will do the best test for tubal patency. We will instill the methylene blue and we will see that this methylene blue is coming out of fimbrial end of fallopian tube. Means tube is patent. So most common cause of bilateral cornual block, physiological spasm. If you see physiological spasm, what is the next step? Pass a cannula from cornual ends of tube. If you are able to pass the cannula, we are almost sure it was a physiological spasm, then we will confirm it with laparoscopic chromoperturbation. Most common pathological cause. If you are not able to pass the cannula, beyond this, means it is which block? Pathological block. Not able to pass the cannula. Most common pathological cause of bilateral cornual block is tuberculosis, tubercular infection, genital TB. And the management for this is in vitro fertilization. If tube is blocked, If fallopian tube is blocked, what will not happen? Fertilization will not occur. Can any fertilization occur if it is a pathological block? Can sperm pass from this place? No. Sperm cannot enter the fallopian tube. So what we can do, we can stimulate her ovaries with the drugs, and then we will do ultrasound guided aspiration of the follicle. We will put these follicles in the petri dish, we will drop the sperms, and a zygote will be formed outside the body. So management for tubal block is IVF. Bilateral fimbrial block, most common cause is chlamydia or gonorrhea. If it is a mild block, we can repair fimbrial end. This is called fimbrioplasty. If it is a severe block, or the best management for fimbrial block is IVF, in vitro fertilization. I tell you one line answer, best management for tubal block is in vitro fertilization. Single line, if the examiner asks us a very simple question, what is the best management for tubal block? IVF. We will write this line. If it is a mid-segmental block means the block is here at this place, not at the cornual end, not at the fimbrial end, but in between. Block in the middle of tube. Most common cause of this block is history of tubectomy or tubal ligation surgery. So we had put a suture here, and because of this, what has happened? Tube was blocked. But she came to us for this sterilization surgery few years before. Doctor साहब, I don't want a baby. बच्चे बंद करने का ऑपरेशन कराना है. Do a sterilization operation. We did the operation. Now something unfortunate happened to her. And now she is coming to us again, Doctor साहब, मुझे बच्चा खोलने का ऑपरेशन कराना. I want a baby now because something unfortunate happened to her. And if she wants a baby, we have to recanalize the tube. We have to create the patency in the tube. This is called recanalization. Just one line answer, best management for tubal block is IVF. Put a tick. If examiner of all the three, whether it is mid-segmental block or fimbrial block or cornual block, overall best management for tubal block is IVF. Full form of IVF is in vitro fertilization. I will tell you few things about IVF and then we will write 4-5 points in IVF. How we do? First of all, we stimulate the ovaries with GnRH. When ovaries are stimulated, then we aspirate oocytes from these ovarian follicles under ultrasound guidance. We will write 3-4 points. Just understand this first. What we are doing, we have given her GnRH, then follicles are mature, then we go inside and this is the needle you can see. This is the needle and this needle is passed in a follicle. We aspirate the oocyte. This is called ovum pickup. After aspirating the oocyte, what we are doing? We keep this oocyte in a petri dish and in this petri dish we drop sperm. This is the katori, this is the petri dish. In petri dish we drop sperms. We have already kept the oocyte. This is the oocyte, oocyte, oocyte. So we aspirate 4-5 oocytes, then we drop sperm. Approximately 50,000 to 1.5 lakh sperms are dropped for one oocyte. Only one sperm is enough to fertilize the oocyte, but with your embryology knowledge you know, at least 1 lakh sperms have to cover the oocyte. And then what happens, this acrosomal cap is released and acrosomal cap comes out of a sperm and acrocin is released. And because of this, now one sperm is able to penetrate the oocyte. Although one sperm fertilizes the oocyte, but at least 1 lakh sperms have to cover the oocyte. Then only one sperm will be able to fertilize the oocyte. So 50,000 to 1.5 lakh sperm are dropped per oocyte. Fertilization occurs, zygote is formed, and this zygote is kept in an incubator, in a refrigerator incubator. And from this incubator, we can remove this zygote either on day 3 or on day 5 after fertilization. With your embryology knowledge, you know on day 3 we have morula, on day 5 we have blastocyst. Now we have so high quality incubator that we can keep this up to the day 5 post fertilization. And then we take out blastocyst from the incubator. And then we transfer this blastocyst into the uterus. This is called embryo transfer. If we do blastocyst transfer, success rate is high. So if we are transferring the blastocyst, there is no need to put 4 or 5 embryos in the uterus. We can just keep 1, 2, or 3. This is in vitro fertilization. Let's write few things about IVF. Point number 1. IVF, follicular aspiration, is done under USG guidance. USG guidance means ultrasonography guidance. We aspirate the follicle. Number 2, keep oocytes in petri dish. Point number 3, drop sperms in petri dish. Drop sperms in petri dish. 50,000 to 1.5 lakh sperms are dropped per oocyte. Then this zygote is kept in incubator. Zygote is kept in incubator. Then embryo transfer is done on day 5 post fertilization. Previously we were doing on day 3 at morula stage. Now we are doing on day 5 at blastocyst stage. Means blastocyst transfer at the stage of blastocyst. So we can transfer 1 or 2 or 3. This is in vitro fertilization. What uterine factors may be responsible? It can be a septate uterus. It can be a cornual fibroid. It can be a submucous fibroid. We know septate uterus, there is a septum in the midline. Although mostly it causes abortion, but it can cause infertility also. This midline septum may not allow sperms to enter. Suppose there are cornual fibroid. Cornual fibroid means there are fibroids here at the cornual end, these fibroids. Cornual end means right at the mouth of fallopian tube. Do you remember one MCQ we saw and the answer was laparoscopic myomectomy? This is not the intrinsic pathology of tube. These fibroids, they are preventing entry of sperms in the tube. Cornual fibroid, right at the cornual end. And submucous fibroid, we have already discussed and we wrote this also. What are the specific complications of submucous fibroid? Infertility and abortion. If it is large enough, it will not allow sperms to enter inside. So uterine factors, septate uterus, cornual fibroid and submucous fibroid will cause infertility. We discussed septate uterus also, we discussed fibroids also. Cornual fibroid is taken by laparoscopic myomectomy, submucous by hysteroscopic myomectomy. We have written in our notes in fibroid. Cervical factor. What is the problem in cervix? What is the problem in cervix? Poor cervical mucus. Poor cervical mucus means this is cervix here and this mucus is bad here. This is the poor cervical mucus. So this poor cervical mucus creates a problem that sperms are not able to pass through this mucus. Sperms are not able to pass through this mucus. This poor cervical mucus, this is impermeable for sperm. Sperms are not able to pass through this poor mucus. How do we diagnose this? Diagnosis of cervical mucus is done by a score. Name of this score is insular score. Normal insular score or a good score is 10. If it is less than 10, this is a poor cervical mucus. There is a scoring system for cervical mucus. Name of the scoring system is insular score. Another problem in cervix can be anti-sperm antibody. So these are the antibodies here in the cervix. Here, suppose if there are antibodies in the cervix, what these antibodies do, they repel sperms. When sperms try to enter inside, these antibodies, they repel sperm. They reject sperm. They don't allow sperms to enter inside. They repel or they reject sperm. So sperms are not able to enter inside. The problem is these antibodies are not seen by naked eye and they are not seen by ultrasound. So how to diagnose the presence of these antibodies? How to diagnose the presence of these antibodies in the survey? So diagnosis is done by a test. Name of this test is postcoital test. Name of this test is postcoital test, which is also called Sims test or Hodder test. We have a Sims speculum also. This time we will keep a 45 minutes instrument session also separately. In that instrument session, we will see the basic instrument like a curate, like a Leach-Wilkinson cannula, all the forceps and vacuum, Sims speculum, Cascode speculum, anterior vaginal wall retractor, Carmen's cannula, Hagar dilator, and few others, Valsalem, postcoital test or Sims or Honus test. What is this test? Why this is called a postcoital test? Because we are performing this test after intercourse. We call her 2 hours after intercourse. We advise couple to have the intercourse and we call the couple 2 hours after intercourse. And 2 slides are made. And this is performed usually between day 10 to 12. We want to perform this test before ovulation. Because if we find the presence of anti-sperm antibody, we will not say couple that you have to stay together for next 3 to 4 days and you have to have intercourse at least 4 or 5 times during those days. No. If we find anti-sperm antibody, they cannot have normal intercourse. They can have, but that will not be fruitful as far as conception is concerned. So, instead of advising them for a normal intercourse, we will do something. What is this something? Let's discuss. How this postcoital test is done. We ask the couple to have intercourse and then we prepare 2 slides. One slide is prepared. Let me draw this diagram here, this image diagram. Let me draw it here. These are anti-sperm antibodies here. And after intercourse, semen is present here in the cervix also and behind the cervix also. Because during intercourse, some semen, most of the semen goes inside the cervical canal, but some semen goes behind the cervix due to gravity in posterior fornix. This is the cervix here, and this is the area of posterior fornix. behind the cervix. Now we are preparing two slides. One slide is prepared from posterior fornix. Other slide is prepared from cervical canal. Like this, two slides. So one slide is prepared from posterior fornix while other slide is prepared from cervical canal. What is present in cervical canal? Semen is present, most of the semen is present there. And if antibodies are present, they are also present in cervical canal. What is present behind the cervix? In posterior fornix? Only sperms. If antibodies are present, they are inside the cervix. So, if we do a microscopic examination, of these two slides, then we have to see the movement of sperm. The slide which is prepared from behind the cervix, that is from posterior fornix, will have normal forward straight movement of sperm. Normal forward straight movement of sperm. While the slide which is prepared from cervical canal, this has antibodies also. This is why sperms, these antibodies are rejecting sperm, repelling sperm. This is why sperms are running here and there. So movement of sperms in this slide will be rotatory or shaky or jerky. Let's write down the slide which is prepared from cervical canal shows rotatory or shaky or jerky movement of sperms or jerky movement of sperms. While the slide which is prepared from posterior fornix, it has only semen, so it shows straight movement of sperms as if they are very brave. They are not afraid of any antibody. So this is how we can diagnose presence of anti-sperm antibodies in cervical canal. Now you can ask me, sir, why you prepared two slides? We were done at one slide only. What was the need of preparing another slide? The slide which is prepared from posterior fornix is confirming sperms are normal. These are the antibodies which are making them abnormal. In fact, sperms themselves are normal. This is why they show normal movement from posterior fornix. But if antibodies are present, in their presence, their movement becomes shaky or jerky or rotatory. So we proved two things, that sperms are normal. These are the antibodies which are making them abnormal. Now, what should be the management of this condition? Management of poor cervical mucus and management of anti-sperm antibody. The problem is in cervix, so it can be managed by intrauterine insemination. Name of the procedure is intrauterine insemination. This is popularly known as IUI. What we are doing in this IUI or intrauterine insemination, because the problem is in cervix, we are bypassing the cervical area. We ask the male to give us semen after masturbation, and then we wash the semen to remove the prostaglandin. And this washed semen is loaded in the IUI catheter or IUI cannula. And via this IUI catheter or IUI cannula, you can see this is the IUI catheter or IUI cannula. I will erase this. You can see once again. This is the IUI catheter. And via this IUI catheter, we drop sperms here. And these sperms will enter fallopian tube. So we have bypassed the cervical area. This is called intrauterine insemination or IUI? Let's write down. Intrauterine insemination or IUI. Which semen is used? Washed semen. 0.5 ml. How much semen is used? 0.5 ml. Washed or unwashed? Washed. Is inseminated in uterine cavity. Inseminated means it is put in uterine cavity. Insemination. Inseminated means it is put in uterine cavity near tubal opening. Near tubal ostia means tubal opening, so that it can be picked up directly into the fallopian tube. This is intrauterine insemination or IUI. Let me show you one more image of IUI so that you can understand where it is put inside the uterine cavity so that it is directly picked up into the fallopian tube. Let's have a look at this image also. Look here. This is how we are doing IUI. This is the IUI catheter, and with the help of IUI catheter, we inseminated near tubal opening. So these sperms you can see, they directly go inside the fallopian tube. So what is the place of insemination? Place of insemination is near tubal ostia. How much semen is used? 0.5 ml. Clear? Washed or unwashed? Washed semen. This is IUI. Now, before switching over to male factors, let's solve the telegram questions. Fine. Let's solve the telegram questions. Fine. Let's see. Let me. Wow. Yesterday's telegram question. Day before yesterday's telegram questions we discussed in yesterday's class. Yesterday's question number 1. All of the following statements are correct regarding estrogen except increased number of cells in myometrium, correct statement. We have to see where we committed the silly mistake. I tried to put the googly balls in the question. That's what we have to check. Spin barket phenomena is seen in which mucus? Cervical mucus. Burning in cervical mucus. That's correct. Option number 4, decreased uterine contractility. Estrogen increase uterine contractility or decrease uterine contractility? Increase. The question is accept, so answer is 4. Estrogen increase uterine contractility, they don't decrease. Question number 2. All of the following are causes of primary amenorrhea except Swyer syndrome, primary amenorrhea. Steen-Leventhal syndrome, secondary amenorrhea. Steen-Leventhal syndrome is another name of PCOS. MRKH syndrome, Mayer-Rokitansky-Kuster-Hauser syndrome, Mullerian agenesis, primary amenorrhea. Androgen insensitivity syndrome, primary amenorrhea. So what is the accept? Steen-Leventhal. Steen-Leventhal syndrome causes secondary amenorrhea. It is another name of polycystic ovarian syndrome. Question number 3. All of the following statements are correct except itching is absent in bacterial vaginosis. Correct statement. Gold standard diagnostic for candidal vaginitis is seborrheic media. Correct statement. Colpitis macularis is feature of trichomonal vaginitis. Correct statement. Maximum itching is seen in chlamydial vaginitis. Wrong statement. Maximum itching is seen in which vaginitis? Candidal vaginitis due to fermentation. Intense itching. Maximum itching is in candidal vaginitis. Next question. All of the following statements are correct regarding pelvic inflammatory disease except gold standard diagnostic is laparoscopy. Correct. Most common complication if fallopian tube is partially blocked is ectopic pregnancy. Correct. Ultrasound feature is violin string adhesion. Oh my god. Violin string adhesion, which we discussed yesterday, that was ultrasound feature or laparoscopy feature. That was laparoscopy feature. Fitz-Curtis syndrome is a feature of chronic PID. Correct. So answer is ultrasound feature. It is laparoscopy feature. The question is accept. So we have to choose the incorrect statement. Next question. All of the following are increased in polycystic ovarian syndrome except. We discussed the pathophysiology to see whether what are increased in PCOS, what are decreased in PCOS. Free androgen increased. Estradiol, oh my god. Which estrogen increases in PCOS? Is it estradiol or estron? Estron. This is why there is change of E1 E2 ratio in PCOS. Estron increase, not the estradiol. Insulin increase, luteinizing hormone increase. So answer is estradiol. Estradiol does not increase. All of the following statements are correct regarding PCOS except drug of choice to treat infertility letrozole, correct. Drug of choice to treat hirsutism, oral combined pill, correct. Endometrial cancer may be a long-term complication, correct. Osteoporosis may be a long-term complication, no. Osteoporosis cannot develop in PCOS because in PCOS there is excessive estrogen and osteoporosis develops due to decreased estrogen. PCOS is a hyperestrogenic condition. So that's the wrong answer. Because the question is accept, option D is the answer. Next question. All of the following statements are correct regarding genital tuberculosis except can occur in virgin girl. Yes, because this is a descending infection. It does not require intercourse for it to happen. So obviously it can occur in virgin girl. Usually bilateral, yes, because the most common route of spread is hematogenous via blood vessel. So both fallopian tubes will be involved with Mycobacterium tuberculosis. So genital TB is almost invariably bilateral. Most common symptom is infertility, correct. And most common menstrual symptom is hypomenorrhea. It is the ascending infection, that's wrong. Descending infection. PID by chlamydia and gonorrhea is the ascending infection. All of the following statements are correct regarding endometriosis except gene mutation is CYP21. Gene mutation in endometriosis is KRAS gene mutation. CYP21 gene mutation is in PCOS. And in fibroid, which gene mutation? Translocation between chromosome 12 and 40. Allen-Master syndrome may be a complication here. If there is tear of the ligament, that is called which syndrome? Allen-Master syndrome. Management of ovarian cyst measuring 2.3 centimeter is cyst aspiration. This question was asked in last exam, June 22 exam also. But the question was 5.5 centimeter and the cutoff is 3 centimeter. What is the management of endometriotic cyst? If size of ovarian cyst is less than 3 centimeter, cyst aspiration. If size is 3 or more than 3 centimeter, cystectomy. So management of ovarian cyst measuring 2.3 centimeter is cyst aspiration, correct statement. Clinical triad is dysmenorrhea, dyspareunia, infertility, correct. So the answer is gene mutation CYP21, which is the incorrect statement. All of the following statements are correct regarding submucous fibroid except may cause abortion, yes. Can be diagnosed by hysteroscopy, yes. Most common fibroid, no. Most common fibroid is intramural. Type 012, according to FIGO classification, they are submucous fibroid. Correct. So the answer is most common fibroid because it is the incorrect statement. All of the following statements are correct regarding adenomyosis except symmetrically enlarged tender uterus, which sign? Halban sign. Most common symptom is menorrhagia, yes. MRI shows decreased endomyometrial junctional zone thickness or increased endomyometrial junctional zone thickness, increased 12 millimeter or more. Histopathology of hysteroscopic curettage sample is gold standard diagnosis, correct. So option C, MRI shows increased endomyometrial junctional zone thickness, not the decrease. So let's take a lunch break here. Let's see at 2:30. Meet at 2:30 after the lunch break. Let's see at 2:30 p.m. 45 minutes lunch break. Welcome back. Let's begin with male factors of infertility. Male has to give semen. There's only one factor. This is why females are held little more responsible for infertility than males. So we discussed female factors. Let's begin with male factor. The first investigation advised in an infertile couple. Whenever an infertile couple comes to us, what do we say the couple? The first investigation is seminogram. Important MCQ also. Why the first investigation is seminogram? Because it is easy to get done. Man has to give only semen sample. For female, we may have to do laparoscopy, hysteroscopy, ovarian factor, tubal factor, uterine factor, cervical factor. Just by getting done a seminogram and few hormones, we can conclude what is the issue. So first investigation advised in an infertile couple is seminogram. And for seminogram, there is a prerequisite. We ask the couple when they had intercourse last, because there should be abstinence for at least 3 days before a seminogram. Otherwise, semen will be diluted. Abstinence from intercourse. So let's write down what is the first investigation advised in an infertile couple. Seminogram. We discussed this because let me seminogram. Male factors. Let's begin with male factors of infertility. First investigation, important MCQ. First investigation advised in infertile couple is seminogram. What is the prerequisite? Before seminogram, there should be abstinence from intercourse and of course from masturbation, abstinence for 3 days. Couple didn't have intercourse in last 3 days. That is the basic prerequisite before seminogram. And the first investigation advised in infertile couple is seminogram. According to World Health Organization, according to WHO, what is the normal seminogram? Normal seminogram, according to WHO, this is based on lower reference range. Normal seminogram, according to WHO, is based on lower reference range of various parameters. Lower reference range means like for example, amount of semen, it should be at least 1.5 ml. So what reference range is taken into consideration? Upper reference range or lower reference range? Lower reference range. Amount of normal semen should be at least 1.5 ml. Sperm count, they should be at least 15 million per ml. This is the normal seminogram, normal parameters in seminogram. So they are based on lower reference range, at least this much, at least minimum this much. Total sperm count should be at least 39 million. So be very clear, this is total sperm count. This is not per ml. It should be 15 million per ml and total count should be at least 39 million. Morphologically normal sperms. Normal sperms, even if only 4% sperms are normal in the seminogram, we are happy. We consider them the normal criteria. Even if only 4% sperms are normal, we are happy. So morphologically normal sperms, they should be at least 4%. We are happy with this. Progressively motile sperms, they should be at least 32%. Total motility, it should be at least 40%. Viable forms, they should be, alive forms, they should be at least 58%. Leukocytes, they should be less than 1 million per ml. Round cells should be less than 5 million per ml. pH of semen is approximately 7.2. So semen is alkaline, blood is alkaline, semen is alkaline, urine is acidic, amniotic fluid is also alkaline, that we will discuss in obstetrics. So these are various normal parameters in seminogram. Normal parameters. Abnormalities. What are the abnormalities? Let's discuss. If amount of semen is less than 1.5 ml, amount of semen should be at least 1.5. It should be at least 1.5 ml. And if it is less than 1.5 ml, this is hypospermia. If semen is less than 1.5 ml, this is hypospermia. If semen is more than 5.5 ml, this upper limit is not described by WHO. This upper limit is not given by WHO. We have taken it into consideration. If it is more than 5.5, we call it hyperspermia. If semen is absent, man says that he is not able to ejaculate anything. This is aspermia. Man says he is not able to ejaculate anything, he is not able to give any liquid. This is called aspermia. If semen is present but sperms are absent, if semen is present but sperms are absent, this is called azoospermia. Azo. So semen present but sperms are absent in semen, this is azoospermia. If semen is absent, this is called aspermia. If sperm count is less than 15 million per ml, they should be at least 15 million per ml. If sperm count is less than 15 million per ml, this is called oligospermia. Oligo. Then we categorize oligospermia into three varieties: mild, moderate, and severe. Between 10 and 15 million per ml, mild oligospermia. Between 5 and 10 million per ml, moderate oligospermia, and less than 5 million per ml, severe oligospermia. Teratovoid is used for abnormal morphology. Morphologically normal sperm should be at least 4%. If morphologically normal, sperms are less than 4%, teratovoid is used for abnormal morphology. Even if 4% are normal, we are happy. But if they are less than 4%, for abnormal morphology, teratovoid is used. Asthenovoid is used, asthenospermia, for abnormal motility. Progressive motility is a better indicator of motility. if progressively motile sperms are less than 32%. If progressively motile sperms are less than 32%, this is asthenospermia. If viable forms, if viable sperms are less than 58%, this is necrozoospermia. And if acrosomal cap is absent in sperm, if acrosomal cap is absent, means this is a round-headed sperm. Round-headed sperm, this is called globozoospermia. So these are various abnormalities we can find in a seminogram when we are doing the semen analysis, which is the first investigation advised to an infertile couple. What care we have to take, what thing we have to remember, that word astheno is used for abnormal motility. Word tereto is used for abnormal morphology. Necro means dead. So if viable forms are less, obviously the word necro is used. Necro means dead. Oligo word is used if the count is decreased. WHO says the count should be at least 15 million per ml. And if it is less than 15 million per ml, oligo word is used. Now, we can differentiate male factors into three parts: pre-testicular, testicular, and post-testicular. Pre-testicular problems, testicular problems, or testicular causes, and third one is post-testicular. Post-testicular problem. So problems in male can be categorized into three parts: pre-testicular problem, testicular problem, and post-testicular problem. How do we differentiate these three? Pre-testicular, testicular, and post-testicular. Similar to females, there is an axis in males which is called hypothalamo-pituitary testicular axis. Hypothalamus secretes GnRH, which acts on pituitary. Pituitary secrete FSH, which acts on testis. And then Leydig cells are secreting testosterone. Spermatogenesis occurs. So if there is a problem in hypothalamus and pituitary, that is a pre-testicular problem. If there is a defect in hypothalamus and pituitary, this is a pre-testicular problem. If there is a defect in testis, like he met an accident, he was driving a bike, met an accident which led to damage of testis. He received some radiotherapy which damaged the testis. There is Klinefelter syndrome or Ruffenstein syndrome. If there is history of mumps in childhood, complication of mumps is orchitis. These are testicular problems which damaged his testis. Post-testicular problem means hypothalamus, pituitary, and testis are normal, but there is obstruction in vas deferens. So post-testicular problems are obstructive. Which obstruction? This is an obstruction in vas deferens. Obstruction in the transportation system in the vas deferens. And the diagnosis of these three problems, differential diagnosis of these three problems can be done by estimation of these three hormones. Differential diagnosis of these three problems can be done by estimation of FSH, LH, and testosterone. These three hormones. And out of these three, the best differentiating marker is FSH. So put a tick on FSH. Out of these three, the best differentiating marker is FSH. How we will decide whether the problem is pre-testicular or testicular or post-testicular? If there is a defect in hypothalamus or pituitary, what will happen if hypothalamus is defective? GnRH will be lack. Pituitary will not be stimulated. FSH and LH will be lack. And if FSH and LH are less, testis is not stimulated. So in cases of, if the problem is pre-testicular, what is happening? All three will be reduced. FSH, LH and testosterone, all three will be reduced if the problem is pre-testicular, if it is a pre-testicular problem. Now, if it is a testicular problem, if it is a testicular problem, what will happen if it is a testicular problem? What is secreted from testis? Testosterone. So if it is a testicular problem, testosterone will reduce. And if testosterone is reduced, what will happen to FSH and LH? Due to positive feedback, FSH and LH will increase. Now, if it is a post-testicular problem, if it is a post-testicular problem, means hypothalamus, pituitary and testis are normal, then all three will be normal. Because it is not a functional problem, it is not a physiological problem. The problem is there is obstruction in vas deferens. There is a problem in vas deferens. The problem is in transportation system. This is why the problem is in transportation system. This is the reason. This is the problem. So by just estimation of FSH, LH and testosterone, we can easily conclude whether the defect is pre-testicular or testicular or post-testicular. And best marker out of these three is FSH. Just give me a moment. Now, what is the management for these problems? If it is a pre-testicular problem, means there is a defect in hypothalamus and pituitary. We can give either GnRH or FSH. If it is a testicular problem, management will be done according to the cause, because causes are vague. No MCQ will be asked from testicular problem because causes are non-specific. He was driving a bike or was driving a car, met an accident, scrotal injury. So how much damage has occurred to testis, whether the damage is reversible or irreversible, and how much damage has occurred due to radiotherapy and all. No MCQ will be asked. The problem is non-specific, will depend on the amount of damage. The most important MCQ zone here is post-testicular problem. Put a tick here. Important. The most important MCQ zone, if it is a post-testicular problem, means there is obstruction in vas deferens. Let's discuss this defect with a question. Question number 1. A male presents with azoospermia with normal FSH, LH and testosterone. If you read this line in the question, what is coming to your mind? A male is presenting with azoospermia and FSH, LH and testosterone are normal. Means this is which defect? First of all, let us decide whether this is pre-testicular problem or testicular problem or post-testicular problem. Of course, the post-testicular problem. So all the three hormones are normal. Means there is an obstruction in the vas deferens. Then first variant of the question will be, what is the next step? A male presents with azoospermia with normal FSH-LH testosterone. What is the next step now? Next step now, what is coming to our mind? Although this is azoospermia, but it is an obstructive problem. Means spermatogenesis is normal. Sperms are being formed and they are in the testes. So if we put in a needle in the testes and try to aspirate the sperms, we can aspirate the sperm. So with the needle, we will aspirate the sperm in a syringe, and then this sperm will be injected directly into the cytoplasm of the oocyte, which is called intracytoplasmic sperm injection. So we have to do ICSI after this, intracytoplasmic sperm injection. We will aspirate the sperm from the testis, and then we will put this sperm into the cytoplasm of oocyte. So next step is testicular sperm aspiration. Testicular sperm aspiration, which is popularly known as TESA. Testicular sperm aspiration is popularly known as TESA. So this is a testis, suppose this is testis. We will just introduce a needle in the testis and we will aspirate the sperm from the testis. This is called testicular sperm aspiration. Why this is the next step? Because it can be done in local anesthesia. This is the OPD procedure. This is the OPD procedure. Next variant of the MCQ is a male presents with azoospermia with normal FSH/LH testosterone. What is the best management for him? First variant was next step. Next variant of the same question is what is the best management for him? Answer to this question, best management for him is microsurgical epididymal sperm aspiration. This is popularly known as MISA. Why this MISA is best? Because we are retrieving sperms from epididymis. Sperms attain maturity in epididymis. Sperms attain maturity in epididymis. Sperms attain motility in epididymis. Sperms are in maximum concentration in epididymis. So we are retrieving good quality and good number of sperm. Why it is not the next step? Because this is done in general anesthesia. We have to admit the patient. This is the IPD procedure. Why this is the best? Because we are retrieving sperms from epididymis. In epididymis, we know these physiologic questions. Maximum concentration of sperms is in epididymis, and they attain maturity or motility in epididymis. So we retrieve the good quality sperm. So next step is testicular sperm aspiration. Best management is microsurgical epididymal sperm aspiration. And we can correct defect in same sitting simultaneously at the same time. When we are retrieving the defect, because this is a microsurgical procedure, we can correct the obstruction at the same time. This is why this is best. MCQ number 2. A male presents with azoospermia, normal FSH/LH testosterone and failed MESA. A male presents with azoospermia, normal FSH/LH and testosterone and failed MESA. MESA means the best procedure has failed. The best procedure has failed. Now what is the next step? This is the MCQ. And answer to this question is therapeutic donor insemination. If MESA has failed, the best procedure to retrieve the sperms have failed, then we have to purchase the semen. We have to hire the semen. This is called TDI, therapeutic donor insemination, or IUID. IUID means intrauterine insemination from donor. Donor. We have to take the donor semen. That's the only option. If we have taken the donor semen, we can do. What are the other indications of IUI? We discussed the indications of IUI. IUI-H means husband. D means donor. If we don't try anything, it means with the husband. Indications of IUI, we did IUI in anti-sperm antibody, and if the cervical mucus was poor, we bypassed the cervix. What are other indications? If partner is impotent, not able to perform intercourse, then we can take semen from the partner and then we can put this semen in the uterine cavity by IUI. If female is having a problem called vaginismus, what is vaginismus? What happens at the time of intercourse in few females? They are fearful of intercourse. They are afraid of intercourse. So at the time of intercourse, their vaginal muscles go in involuntary contraction. And because of contraction of vaginal muscles, intercourse is not possible. Then what can we do? We can do intrauterine insemination. Vaginismus is involuntary contraction of vagina at the time of intercourse due to anxiety. IUI can be helpful in mild oligospermia also. How it is helpful? Because we are using the washed semen, and after washing, sperm concentration is improved to some extent. So it is helpful in mild oligospermia. If the openings are faulty, like epispadias, hypospadias, or retrograde ejaculation, means it's not forward ejaculation. Semen is not going forward. These are surgical problems, have been discussed in the surgery, epispadias and hypospadia. So then we can perform the IUI. And other problem, let's write that also, immunological problem. What was the immunological problem? This is the problem for which we discussed intrauterine insemination. Name was anti-sperm antibodies. One more we can write down, we did for poor cervical mucus also. We did intrauterine insemination for poor cervical mucus also. So all these are indications of intrauterine insemination. We can use the donor semen and can do the IUI with donor semen if we can't use the semen of the husband. Suppose there is risk of transferring some disease from the husband. Then we don't want the semen from husband. Then we can take the donor semen. That's not an issue. What is the ICSI? ICSI is intracytoplasmic sperm injection. ICSI is intracytoplasmic sperm injection. So what we are doing in the ICSI, intracytoplasmic sperm injection. Single sperm is injected, write down, single sperm is injected into the cytoplasm of oocyte. Single sperm is injected into the cytoplasm of oocyte. This is called intracytoplasmic sperm injection. Let's see this image and label this image of our workbook. This is the image of ICSI. What is this ICSI? As you can see in this image, we are injecting single sperm into the cytoplasm of oocyte. This is the oocyte and we are injecting this sperm into the cytoplasm of oocyte. So how many sperms are injected into the cytoplasm of oocyte? Single sperm. And the procedure is called intracytoplasmic sperm injection. The same thing we discussed we do after TESA and MISA when we were doing testicular sperm aspiration or microsurgical sperm aspiration, epididymal sperm aspiration. Then we take out the sperm from the testis or epididymis. Then we have to do ICSI to transfer this sperm into the cytoplasm of the oocyte. This is called ICSI. What is this? This is ICSI, intracytoplasmic sperm injection. Indications of ICSI are severe oligospermia, severe. Severe oligospermia means if sperm concentration is less than 5 million per annum. Asthenospermia. Asthenospermia means sperms are not motile. If they are not motile, how will they move on their own? So we have to load them in the syringe and transfer directly into the cytoplasm of the oocyte. For IVF, sperms have to be motile. You remember? We dropped sperms in the petri dish and they moved on their own and fertilized the oocyte. For in vitro fertilization, motility was essential. For ICSI, motility is not essential. And obstructive azoospermia. Obstructive azoospermia, what we are doing after TESA and MESA. After testicular sperm aspiration and MISA, what we do, ICSI, we retrieve those sperms and then we have to transfer the sperm into the cytoplasm of the oocyte. That is obstructive azoospermia. ART. What is just give me a moment. What is the meaning of word ART? ART, full form of ART is assisted reproductive technique. Assisted reproductive technique. What is the assisted reproductive technique? Meaning of this word assisted reproductive technique is technique involving direct handling of gametes. Technique involving direct handling of gametes is called assisted reproductive technique or ART. Direct handling of gametes means there is direct handling of sperms or ova. We are directly handling sperm or ova. And your question is, all of the following are assisted reproductive techniques except. So IVF is ART, ICSI is ART, GIFT and GIFT, these are assisted reproductive technique. In vitro fertilization, we put sperms in the petri dish and there are oocytes in the petri dish. ICSI, we directly inject sperm into the cytoplasm of oocyte. GIFT and GIFT are not done now. What was GIFT? GIFT was zygote intrafallopian transfer. Zygote intrafallopian transfer. This was GIFT. What was GIFT? Gamete intrafallopian transfer. GIFT is gamete intrafallopian transfer. So zygote intrafallopian transfer or gamete intrafallopian transfer. They were old techniques. Now we do IVF and ICSI. Our question is this, that intrauterine insemination, IUI, is not ART. Why intrauterine insemination is not ART? Because in intrauterine insemination, We are inseminating semen. It's not direct handling of sperm. It is direct handling of semen. This is why IUI is not ART. Let's solve the questions. Best management of tubal block. Important question, simple question. Last line in the tubal block we wrote, best management for tubal block is in vitro fertilization. What is the best management for tubal block? In vitro fertilization. All of the following are indications of ICSI except azoospermia with normal FSH/LH testosterone. Obstructive azoospermia. Yes, we do TESA and MESA and then we do ICSI. Asthenospermia. Yes. Sperm count less than 3 million per ml. Yes, severe oligospermia. Sperm count 17 million per ml. This is normal sperm count. The cutoff is 15 million per ml. But if it's normal, why to do ICSI? Which is not true about lower reference range for semen analysis according to WHO recommendation. Progressive motility 32%, correct. Semen volume 1.5 ml, correct. Sperm concentration 20 million per ml or 15 million per ml. Sperm concentration is 15 million per ml. Morphology, how much is normal? 4%. So sperm concentration 20 million per ml. Most easily diagnosed cause of infertility is anovulation. Most easily diagnosed, most easily treatable, so most reversible form of infertility. Ideal day to detect ovulation by endometrial biopsy in a 32-day cycle is, we do 8 days after ovulation and cycle length is given 32 days. First of all, we will calculate day of ovulation in 32-day cycle. 12 minus 4, 8, 2 minus 1, 1. So day of ovulation in a 32-day cycle is 18. Then when activity of corpus luteum is maximum in her, then we have to add 8 here. So answer is 26, pure mathematics. What is the menopause? Menopause is cessation of menses for at least 1 year. Definition of infertility was also 1 year. Inability to conceive even after 1 year of unprotected and regular intercourse. Similarly, definition of menopause is also cessation of menses for at least how much time? 1 year. This is menopause. How much is the menopausal age? 51 years. 51. In developing countries like India, if especially it is mentioned, then it is 47 years. Otherwise, answer will remain 51 years, unless specifically mentioned developing countries or India. What is the perimenopausal period? Around menopause. This is 39 years to 51 years. Another name of perimenopausal period is climacteric period. Perimenopausal period is also called climacteric period, 39 to 51 years. What is a premature menopause? Premature menopause if menopause occurs before the age of 40 years. This is premature menopause. What is a delayed menopause? Delayed menopause if not even till 55 years. This is called delayed. So premature menopause if menopause occurs before 40 years. Delayed menopause if it doesn't occur even by 55 years. Definition is sedation for menses for at least how much time? 1 year. How much is the menopausal age? 51 years. If mentioned India, then 47. And what is the perimenopausal period? Around menopause, 39 to 51 years. 39 to 51. What happens at menopause? Event at menopause. What is happening? There occurred decline in activity, ultimately leading to sedation of hypothalamo-pituitary ovarian axis. So there occurred decline in the activity of hypothalamo-pituitary ovarian axis. At puberty, there was activation or stimulation of HPO axis. HPO means hypothalamo-pituitary ovarian axis. And what is happening at the time of menopause? Now all the follicles, there was follicular pool, all the follicles in female, they are recruited every month. Every month they are recruited, and out of those only one become mature and rest are exhausted. So all the follicles almost they are utilized throughout the reproductive period. Now the stores are gone, reserves are gone. So there occur decline in the activity of this axis, ultimately leading to decrease in the activity of ovary. Ovarian activity sedation. Finally, what is happening? HPO, hypothalamo pituitary ovarian. Finally, which activity sedation? Ovarian activity sedation. Hypothalamo pituitary ovarian. And if there is sedation of ovarian activity, what will happen? Which hormones are secreted from ovary? Estrogen and progesterone. So, what will happen to estrogen and progesterone after menopause? They will decrease. Very important biochemical question of our exam. What is the hormonal status at menopause? Because there is decrease in the activity of ovary, hormones secreted from ovary will decrease. So, estrogen and progesterone will decrease. And we know very well this physiology or this feedback mechanism. Whenever there is decrease in estrogen, it gives positive feedback to FSH. Whenever there is decrease in progesterone, it gives positive feedback to LH. So what will happen to FSH and LH? They will increase. Important question, what is the hormonal status in a menopausal lady? And examiner twist the option. Estrogen decrease, progesterone increase, FSH decrease, LH increase, and like this. But the concept is clear. Because of decrease in ovarian activity, estrogen and progesterone are decreased. So obviously, FSH and LH are increased. Very simple. What will happen to uterine size? Estrogen is responsible for increase in number of cells in myometrium, and progesterone helps estrogen in increase in number of cells in myometrium. So what will happen to uterine size? Decrease, because both estrogen and progesterone are decreased after menopause. What will happen to endometrial thickness? Estrogen is responsible for proliferation of endometrial glands. After menopause, estrogen is decreasing. So what will happen to endometrial thickness? It will decrease. According to American College of Gynaecology, after menopause, endometrial thickness should not be more than 4 millimeter. According to FIGO, International Federation of Gynecologists and Obstetricians, it should not be more than 5 mm. But put a tick on 4 mm, put a tick on ACOG. If examiner gives you a simple question, how much is the cutoff thickness of endometrium in a menopausal female? Answer is 4 mm. We will go with America. The whole world is following America. So we will follow American College of Gynecology guidelines and not the International Federation of Gynecologists and Obstetricians guidelines. So these are the events at menopause. So at menopause, there occur decrease in activity of HPO axis, which lead to all these changes. Now, what are the symptoms at menopause? Most common symptom, earliest symptom, most characteristic symptom, or symptom for which maximum treatment is required in a menopausal lady. Symptom for which maximum treatment is required. means a menopausal lady mostly presenting to a gynecologist or to a menopausal clinic mainly for which symptom? This is the symptom, and this symptom is hot flushes. Hot flushes. So, hot flushes is the answer to 4 MCQ. Most common symptom of menopause, hot flushes. Earliest symptom of menopause, hot flushes. Most characteristic symptom of menopause, hot flushes. Symptom for which maximum treatment is required in a menopausal lady, hot flushes. These hot flushes are due to vasodilatation. She is feeling heat. She is feeling warm. Because of vasodilatation, they are sweating. Generalized sweating. उसको पसीना आ रहा है बहुत. गर्मी लग रही है उसको बहुत ज़्यादा. And the reason for this vasodilatation is, one reason is decreased estrogen. Estrogen is responsible for maintenance of tone of muscles and ligaments. So tone of tunica media now will not be maintained. Vessels will be dilated. And the second reason is because estrogen is decreasing and progesterone is decreasing, FSH and LH are increasing. So whenever this brain releases these LH, it's in a pulsatile fashion. So whenever there is a release of LH in pulsatile fashion, it causes vasodilatation. So many times it is coinciding with LH release also. But just remember these 4 MCQs, the answer is hot flushes. What is the management? Drug of choice for this is Tibolol. What is the drug of choice for this condition? Tibolol. Ultimately, what we want to give in this lady, because the main deficiency is the deficiency of estrogen. We want to give her estrogen. This is our primary goal. But we discussed before as well. Whenever we are giving estrogen to a lady, we always add progesterone if uterus is intact in her. If the lady is having uterus, we always add progesterone along with estrogen. Why? If you give estrogen alone, what it will do? There will be unopposed action now, which will result in unopposed endometrial hyperplasia, which may convert to endometrial cancer. This is why, if a lady is having a uterus, we always add progesterone with the estrogen. Always. This is the thumb rule of this therapy. We are replacing the hormone because the hormone is reduced. This is why name of the treatment is hormone replacement therapy. And hormone replacement therapy is popularly known as HRT. Hormone replacement therapy. Hormones are reduced, now we are replacing hormone. So we are clear with the rule of HRT. If by chance hysterectomy has been done in this lady, she is not having a uterus, then we can give only estrogen. Because now we are not worried. We are not worried because there is no endometrium. So we are not worried for any endometrial hyperplasia or endometrial cancer. So this is the thumb rule of HRT. We have to give estrogen. So if she is having uterus, we will add up progesterone. What is this Tibolol? Tibolol is a wonderful drug. This is why this is drug of choice here. Tibolol contains estrogen as well as progesterone as well as androgen. Because you know what is happening in a menopausal lady. Not only estrogen and progesterone are reduced, ovarian source of estrogen, androgen is also reduced. And androgen in females is responsible for sexual desire, libido. So her libido is decreased, so Tibolol will improve her libido also to some extent. So wonderful drug of choice for hot flushes is Tibolol. Tibolol is a combination of estrogen, progesterone, and androgens. This is Tibolol. Clear? Other drugs which can be tried are, usually it is given 2.5 milligram daily. Dose will not be asked here, I doubt. 2.5 milligram, commercially available with the name Livial, tablet Livial. Other drugs which can be used are, we start Tibolon, but it will take some time for action. May take 20 days, 25 days, 30 days. It's not like that you have started Tibolon and the hot flushes will disappear tomorrow or day after. So we have to tell her that it will take some time and you have to bear with the hot flushes. If she says, no, 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 Doctor, I have lot of kitty parties, and I have to move in that party, this party, and so on. So then for acute suppression of symptoms, for acute symptoms, for acute relief, we can give clonidine. Clonidine, you know the drug, it relieves the vasomotor symptom for acute relief. Other drugs which can be tried are fluoxetine, selective serotonin receptor inhibitor, selective serotonin reuptake inhibitor is also useful here. Then we can give phytoestrogens, plant estrogens. Phytoestrogens, plant estrogens, isoflavones. Soya bean is a good source of natural estrogen. So you should advise all the menopausal females in your family to eat more and more soya food, because soya bean contains natural estrogen which is devoid of any side effect. There are no side effects with soya bean, isoflavone. These can be tried. Some try gabapentin or pregabalin also for these symptoms, some psychiatric symptoms, but no. Some can prescribe alprazolam also for relief of all these nervousness, because what is happening mainly in hot flushes. In hot flushes, she is having feeling of warmth, feeling of warmth. She is feeling heat. She is complaining of sweating. And because of all this, which is happening at night also, she wakes up quite often at night. This is why her sleep remains incomplete. Insomnia, irritability. She is having irritability throughout the day. And because of all this, she experiences anxiety and palpitation. This is the hot flushes syndrome. All this is a hot flushes syndrome, which is the earliest symptom, most common symptom, most characteristic symptom, symptom for maximum treatment is required in a menopausal lady, hot flushes. Another symptom is osteoporosis. Symptom number one, hot flushes. Symptom number two is osteoporosis. We know that estrogen is responsible for maturation of long bones. And what is happening after menopause? Estrogen is reduced. Because of reduced estrogen, what will happen? Osteoporosis will develop. Today also I will post questions on Telegram at 9 p.m. Solve the questions and try to catch the googly ball in the question, swing in the question. You are developing a habit of avoiding silly mistakes in exam. That's the purpose, so that we can discuss them in the next class. Osteoporosis. What is the drug of choice for osteoporosis? In osteoporosis, we know it is an orthopedic topic. Most common fractures are vertebral compression fractures. Vertebral compression fracture. Most common fractures in osteoporosis due to osteoporosis are vertebral compression fracture. There can be fracture of wrist also, femur also, but mostly vertebral compression fracture. And how it is diagnosed? This is diagnosed by DEXA scan. Which scan is done? Orthopedics, not the gynae. DEXA scan. Dual energy X-ray absorptiometry. DEXA scan. This is osteoporosis is diagnosed by which scan? DEXA scan. There are T scores, Z scores. You know that. Orthopedics, not the gynae. What is the drug of choice to treat osteoporosis? A very important MCQ, bisphosphonates. bisphosphonates, drug of choice to treat osteoporosis. And please be very clear, this is not only postmenopausal osteoporosis, drug of choice to treat any type of osteoporosis. So it's an overlap with pharmacology also, not only for postmenopausal osteoporosis, but for any type of osteoporosis is bisphosphonate. What are the drugs here? The drugs are alendronate, ibandronate, risedronate, have been discussed in pharma. Alendronate is given daily, ibandronate is given weekly, risedronate is given monthly. That mode of administration, no one will ask. Your MCQ will finish at the one word. And what is this one word? Bisphosphonates. There's a side effect, severe side effect, and this is also a MCQ. Overlap with pharmacology. These bisphosphonates cause severe gastritis and esophagitis. Severe gastritis and esophagitis. So, what precaution is taken whenever we are advising or prescribing bisphosphonate? Whenever she eats this bisphosphonate, she should not lie down on the bed. She should sit upright. She should sit upright. मतलब दवाई खाने के बाद आधा घंटे बैठ जाना है. दवाई खा के आधा घंटे बैठना है, बिल्कुल ऐसे जिससे दवाई जल्दी से नीचे चली जाए. You have to sit upright. I will speak in English now. We have to sit upright after taking the medicine so the drug is cleared faster. Write down what is the precaution taken after taking bisphosphonates. Sit upright for 30 minutes. Sit upright for 30 minutes. Don't lie down. So our MCQ will finish at the word bisphosphonate. Here the MCQ should finish at the word tibolone. At the most they can ask for acute relief clonidine. Other drugs which are used especially for prevention of osteoporosis. Especially for prevention of osteoporosis, we use calcium and vitamin D. Almost these are available at everyone's place, everyone's home. Calcium and vitamin D. They are not for treatment of osteoporosis. They are for prevention of osteoporosis. For treatment of osteoporosis, other drugs which can be used are, there is a drug called bazedoxifene. This bazedoxifene is also approved for treatment of osteoporosis by FDA now. This is a selective estrogen receptor modulator, a SERM drug, pharma, bazedoxifene. We can use a synthetic parathormone, teriparatide. This is a synthetic parathormone extract. It stimulates osteoblastic activity. Teriparatide, pharma, orthopedics, this is not gynae, but it stimulates osteoblastic activity. Calcitonin, which is released from thyroid, it reduces osteoclastic activity. Calcitonin reduces osteoclastic activity. Teriparatide, which is a synthetic parathormone extract, it improves osteoblastic activity. So all these drugs, denosumab can also be used. All these drugs can be used for treatment. They can be used for treatment of osteoporosis. Another symptom here is vaginitis. Why vaginitis occurs in a menopausal lady? Doderlin bacilli, lactobacillus acidophilus, they grow, they increase in number under influence of estrogen hormone. And after menopause, estrogen is decreased. So number of Doderlin bacilli is also decreased. So pH of vagina become alkaline. Acidic pH is a good pH which prevents entry of microorganism. If pH become alkaline, more microorganisms will enter. So vaginitis will occur. Moreover, what is happening after menopause? Estrogen is reduced, so what is happening? What else is happening? Cervical mucus now is not thin, watery, profuse, alkaline. Under influence of estrogen, cervical mucus becomes thin, watery, profuse, alkaline. It is no more thin, watery, profuse, alkaline, which results in dryness in vagina. So, dual effect dryness of vagina, she complains of itching. This is considered as senile vaginitis. So, infections can also occur, dryness can also occur. This is called senile vaginitis due to vaginal dryness and more infections. And because of this, she is complaining of itching. Itching can be due to infection, can be due to dryness of vagina. This is called senile vaginitis. And management for this senile vaginitis, you can treat the infection, but mainly they respond to local estrogen cream. They respond mainly to local estrogen cream. What else can happen? As we discussed, ovarian source of androgens is reduced. So there is decrease in sexual desire, decrease in libido. What is the management for this? Libido in females is governed by androgens. We discussed in testicular feminization syndrome, do you remember? Two things in females, they are governed by androgen. Development of axillary and pubic hair and sexual desire, that is libido. So these two things in females, they are governed by androgen. So we can give her androgens. What else may happen? Other symptoms may be other symptoms of menopause. What can be her other complaint? There is risk of cardiac disease, risk of cardiac disease. Estrogen is cardioprotective. Estrogen increases high density lipoprotein. Estrogen decreases low density lipoprotein. So there is risk of cardiac disease. There is sagging of skin or wrinkling of skin. Sagging of skin or wrinkling of skin, because estrogen is responsible for maintenance of tone of muscles and ligament. If estrogen is reduced, the tone of this muscle and ligament, tone of the skin is also not maintained. So skin starts sagging, wrinkling of skin. Obviously, there are a lot of mood swings because of these hormonal changes, which we included in the hot flushes syndrome. So all these are symptoms, and there is risk of uterine prolapse. We discussed in the topic of prolapse. Prolapse can occur in a menopausal lady. Menopause was one of the risk factors for uterine prolapse because of reduced estrogen. Reduced estrogen is responsible for maintenance of tone of muscles and ligament. So all these are risk factors. All these changes can occur after menopause. But the most common and earliest symptom is hot flushes. Hormone replacement therapy principle. What is the principle of hormone replacement therapy? If uterus is intact, we have to give progesterone along with estrogen. We have to add progesterone along with estrogen. And if hysterectomy has been done, then isolated estrogen or only estrogen can be given. There is no need to add progesterone along with estrogen if the lady is not having a uterus. This is the hormone replacement therapy principle, HRT principle. Absolute contraindication of HRT. If there is any history of thrombosis or thromboembolic episodes, we never give hormone replacement therapy. If there is any history of thrombosis, this is absolute contraindication, put it. Other contraindications, among other contraindications, if there is any undiagnosed vaginal bleeding, then also we avoid hormone replacement therapy because hormone replacement therapy mainly contains estrogen. And this undiagnosed vaginal bleeding we never know. Maybe it may be due to some endometrial hyperplasia or cancer. So this will flare up the condition. So if there is any undiagnosed vaginal bleeding, or if she is having a cardiac disease, because there is risk of heart disease, there is risk of heart disease. And all this estrogen and all, they are metabolized in liver. If liver functions are deranged, if there are altered liver functions, deranged liver function, then also we avoid HRT. But the absolute contraindication of hormone replacement therapy is history of thrombosis. What is a premature menopause? Premature menopause if menopause is attained before the age of 40 years. This is premature menopause. What is the most common cause of premature menopause? This is genetic. Put a tick on this. Most common cause of premature menopause is genetic. This is a tendency which runs in family. Grandmother also attained menopause earlier. Mother also attained menopause earlier, and the daughter may also attain menopause earlier. Other causes, if there is any history of radiotherapy, and this radiotherapy support damages her ovary. Accidental removal of ovary. You are doing some laparotomy, and in this laparotomy, by mistake, you have removed the ovary. How to diagnose the ovarian activity? Best diagnosis of ovarian activity is by, put a tick, important MCQ. What is the best diagnostic marker for ovarian activity? It is anti-Mullerian hormone. This is anti-Mullerian hormone. The best diagnostic marker for ovarian activity is anti-Mullerian hormone. This is popularly known as AMH. Anti-Mullerian hormone is popularly known as AMH. Why this is best marker? Because it can be done on any day, any day. Normal values of AMH usually they range between 2 to 4.6 nanogram per hour. If it is less than zero point 0.5 nanogram per ml, it indicates ovarian failure. If anti-Mullerian hormone is less than zero point 0.5 nanogram per ml, it indicates ovarian failure. Anti-Mullerian hormone is secreted from Sertoli cells during embryological development. But at the time of puberty, this is secreted from small pre-antral follicles also. Just remember a very complex story. The best diagnosis whether ovary is having some reserve or not, ovary is active or not, or whether ovary is failing, it is done by anti-Mullerian hormone. Beyond this, everything is ionized CET or Ames level story. If you remember the name anti-Mullerian hormone, this is enough. Others are serum FSH. What will happen to FSH? If ovary is failing, what is secreted from ovary? Estrogen or FSH? Estrogen. If ovary is failing, estrogen levels will reduce and it will give positive feedback to FSH. So FSH will increase. So serum FSH If it is more than 40 international units per liter, it is indicative of ovarian failure. Normally, it is between 2 to 6 or 2 to 10 international units per liter. Normal. We can write what is the normal value. Usually ranges 2 to 6, some say 2 to 10 international units per liter, but put a tick on 2 to 6. Normal value of FSI. If ovary is failing, what will happen to FSI? It will increase, obviously. If ovary is failing, what will happen? If ovary is failing, best was anti-Mullerian hormone. Number 2, serum FSH. Number 3, if ovary is failing, suppose this is the ovary and these are the follicles in the ovary. What will happen to number of follicles in the ovary if ovary is failing? They will reduce, of course. This is called antral follicular count, popularly known as AFC, antral follicular count. So if ovary is failing, number of these follicles will reduce in the ovary. If it is less than 6 in one ovary, and if it is less than 10 in both ovary, it is indicative of ovarian failure. If number of follicles, they are less than 6 in one ovary, less than 10 in both ovaries, two ovaries, this is indicative of ovarian failure. You tell me, if ovary is failing, what will happen to inhibin B level? Inhibin B is secreted from ovary. Estradiol is secreted from ovary. Inhibin B is secreted from ovary. So obviously, if ovary is failing, inhibin B will reduce. And if it is less than 45 nanogram per ml, it is indicative of ovarian failure. Now, clear. This is how we diagnose whether there is any ovarian activity or ovary has failed. And we know very well, if by chance her ovary has failed, we discussed in premature ovarian failure, and if this lady want to conceive, can she use her own oocytes or she have to have donor oocytes for IVF? She has to have donor oocytes for IVF because her ovary has failed. So if she wants a baby, the lady whose ovaries have failed, she can have a baby by in vitro fertilization with donor oocytes and not with her own oocytes. Let's solve the MCQs. Drug of choice for postmenopausal osteoporosis is bisphosphonates is the answer. The drug is alendronate. Vitamin D is used for prevention, not for treatment. Teriparatide is a synthetic parathormone which improves osteoblastic activity. Salcalcitonin is a calcitonin which reduces osteoclastic activity. Best test for ovarian activity assessment is AMH, anti-Mullerian hormone. If it is less than 0.5 nanogram per ml, ovarian failure. FSH, it is done only on third day. If it is more than 40 international units. Inhibin B if less than 45. Antral follicular count AFC, less than 6 in one ovary, less than 10 in both ovary, ovarian failure. All of the following are correct regarding menopause except most characteristic symptom is hot flushes, correct. Drug of choice for hot flushes is Tibolone. This is not fluoxetine. Drug of choice for osteoporosis is bisphosphonate. HRT is not given to reduce risk of cardiac disorders. Never. There is risk of cardiac disorder. We refer the patient to a heart specialist, cardiologist. We don't give HRT. This is the incorrect statement. Management of premature ovarian failure for a lady who want to conceive. IVF is done with donor oocytes if she wants to have a baby. All of the following are indications of HRT except history of thrombosis is contraindication, absolute contraindication. Hot flushes indication, vaginal itching indication, osteoporosis indication. Clear. Now, the next topic is endometrial cancer. Endometrial cancer. How this endometrial cancer develops. How this endometrial cancer develops. Endometrial cancer means which hormone is responsible for proliferation of endometrial gland? Estrogen. So endometrial cancer will develop in which lady? Endometrial cancer will develop in the lady in whom levels of estrogen are excessive. She is having excessive estrogen, and this excessive estrogen will cause endometrial hyperplasia and endometrial cancer. So, excessive estrogen will result in endometrial cancer. All the conditions in which there is excessive exposure to estrogen will lead to this cancer. Let's discuss the risk factors first. Come to the page number 124 in this work. 124. What are the risk factors for endometrial cancer? High estrogen exposure, because estrogen is responsible for proliferation of endometrial glands. So high estrogen exposure. Which female is exposed to more estrogen? Obese female or thin female? Of course, obese female, because of more aromatization in her. Because of more aromatization in her. She is exposed to more estrogen. Which female is exposed to more estrogen? The female in whom menses started early or late? Early. Where menses are continued for a longer time or they stop early? If they continue for a longer time, so early menarche and late menopause. Early menarche and late menopause. Which female is exposed to more estrogen? A low socioeconomic status female or a high socioeconomic status female? Low socio or high? High. High socioeconomic status female. They remain nulliparous for a longer time. They get married at a later age, and even after marriage, they have few kids. So they are menstruating for more time. Which parity? Nulliparity. History of infertility, and we have used various drugs to activate the hypothalamo-pituitary ovarian axis. And finally, ovary is stimulated, which is secreting more estrogen. If there is history of treatment with the drug tamoxifen, tamoxifen is selective estrogen receptor modulator drug. You know with your pharma knowledge, some drug, selective estrogen receptor modulator. It has estrogen agonistic action on endometrium and estrogen antagonistic action on breast. This is why it treats breast cancer. But the side effect is it can cause endometrial cancer. It can treat which cancer? Breast cancer. But it can cause which cancer? Endometrial cancer. Atypical endometrial hyperplasia. Atypical. If atypical cells are present, which we will discuss after 1 minute. There is a combo of diabetes, hypertension, obesity, and cancer endometrium. This is called corpus cancer syndrome. Corpus cancer syndrome means it is involving body of uterus also. Corpus means body. Corpus cancer syndrome. Genetics is responsible. We will discuss after 10 minutes which genetics is responsible. HNPCC syndrome, what is the full form? Hereditary non-polyposis colorectal cancer, also called as Lynch syndrome. We'll discuss HNPCC in 1 minute. If she had polycystic ovarian syndrome, Do you remember? We wrote in long-term complications of PCOS, endometrial hyperplasia, endometrial cancer, breast cancer, because polycystic ovarian syndrome is a hyperestrogenic condition. Excessive estrogen in PCOS. Because of excessive estrogen, there is risk of endometrial cancer. Another one, estrogen secreting ovarian cancer. Estrogen secreting ovarian tumor. For example, granulosa cell tumor and theca cell tumor. Granulosa cell tumor and theca cell tumor. These are estrogen secreting ovarian tumor. Because these tumors secrete estrogen, there is risk of endometrial cancer with granulosa cell ovarian tumor and theca cell ovarian tumor. HNPCC syndrome we will discuss after 1 minute. What are protective factors for endometrial cancer? Physical exercise. Can you tell me, can you think how physical exercise? Whatever questions I am asking you, and I told you, whatever questions I asked you, I told you to speak out in your room, to shout in your room. And those students who are answering correctly, those who are answering correctly, their chocolates is due with me. I will give chocolates to all those students who are answering correct answers in our class, or all your chocolates are due with me. Whenever we will meet, I will give your chocolate. Those chocolates are due. So please let me know once the class is over that, sir, I answered correctly, so my chocolate is due. But you can write your name so that I remember that your chocolate is due. Physical exercise. How physical exercise is protective for endometrial cancer? If she is doing lot of physical activity, what will happen to adipose tissue, fatty tissue? Fatty tissue is reduced. So what is reduced if adipose tissue is reduced? Aromatization is reduced. And if aromatization is reduced, conversion of androgen to estrogen is also reduced. So physical exercise is protective. Smoking is also protective. Smoking inhibits which enzyme? Shout in the room, speak out in the room. Smoking inhibits which enzyme? Smoking inhibits aromatase enzyme. And if aromatase is inhibited, conversion of androgen to estrogen is inhibited. That's how it is protective for endometrial cancer. Oral combined pill. Oral combined pill we discussed, it limits endometrial proliferation. So finally, what happens to endometrial thickness? It is reduced. Oral combined pill. And I hope it is very clear. Risk factors and protective factors, they are almost same in endometriosis, fibroid, and endometrial cancer. We didn't use OCP to treat fibroid. We didn't write OCP in protective factor for fibroid because fibroids depend both on estrogen and progesterone, and oral combined pills contain both estrogen and progesterone. Although these oral combined pills contain estrogen in a very less amount, these are called low dose pills. There is least risk, but still the risk is there. Prevention of endometrial cancer, it is done in HNPCC syndrome. Prevention is done in HNPCC syndrome. What is the meaning of this word prevention? Means if we know that she is having this syndrome, HNPCC syndrome or Rich syndrome, we can do something to avoid endometrial cancer. I repeat, if we know that she is having this syndrome, HNPCC syndrome or Lynch syndrome, we can do something to avoid endometrial cancer. So prevention is done in HNPCC syndrome. What is this HNPCC syndrome? I hope all of you know this syndrome. This syndrome is a combination of if she is having CA endometrium, there is risk of cancer of ovary, there is risk of cancer of colon, there is risk of cancer of breast. This is HNPCC syndrome. So these four cancers are associated. Means if you have diagnosed endometrial cancer, you should advise her a colonoscopy also. You should examine her breast also, get done an ultrasound of breast, get done a mammography. Rule out the ovarian cancers also because they are interconnected. This is called HNPCC syndrome. The full form is hereditary non-polyposis colorectal cancer. Full form of HNPCC syndrome is hereditary non-polyposis colorectal cancer. So prevention is done in this syndrome. And how do we do prevention? We advise her to get done total abdominal hysterectomy, we advise her to get done total abdominal hysterectomy along with bilateral salpingo oophorectomy. What does it mean? We will do the hysterectomy. We will remove her uterus along with both fallopian tubes. Salpingo means fallopian tubes. Oophorectomy means removal of ovary. So we will remove her uterus along with both fallopian tubes and both ovaries by 35 years of age. At the most, we can wait till 40 years, but put a tick on 35. So by the age of 35 years, we will remove her uterus, both fallopian tubes and ovary. So we request her to complete her family as early as possible. Whatever children she wants, she should complete her family before the age of 35 years. So this is how we can avoid endometrial cancer because endometrial cancer develops late in life. So these were all risk factors, protective factors, and this is how we can do prevention in cases of endometrial cancer. And prevention is required in which syndrome? HNPCC syndrome. The full form of HNPCC is hereditary non-polyposis colorectal cancer. Let's come back to the first page. Most common age group for endometrial cancer is usually 5th to 6th decade. So it is usually 55 to 65 years. 5th to 7th decade. And mostly she will complain of because endometrial cancer occurs after menopause. She will complain of postmenopausal bleeding. Postmenopausal bleeding per vagina after the menopause. What is the definition of postmenopausal bleeding? Postmenopausal bleeding is bleeding per vaginum after 1 year of menopause. Bleeding per vaginum after 1 year of menopause. This is postmenopausal bleeding. What is the menopause? Cessation of menses for how much time? 1 year. Definition of menopause is cessation of menses for 1 year in a menopausal lady. So obviously postmenopausal bleeding is bleeding PV after 1 year of menopause. Now there are various questions related to this postmenopausal bleeding. Postmenopausal bleeding is the MCQ factory. MCQ number 1. Most common cause of postmenopausal bleeding. The answer is endometrial atrophy. Endometrial atrophy. What is the atrophied endometrium? If the endometrial thickness is less than 1 millimeter. This is the atrophied endometrium. How bleeding can occur in an atrophied endometrium? If the thickness is less than 1 millimeter, means hardly any endometrial thickness, hardly any endometrium. What happens in this? Infections can occur and avascular necrosis can occur. Because of this, some ulcers may develop here, and from these ulcers, he may have some spotting or bleeding. This is never a massive bleeding. This is mild bleeding. This is spotting. We have to just remember one thing. What is the most common cause of postmenopausal bleeding? This is endometrial atrophy. The dicey situation here is we are very much confused with cancer cervix. Cancer cervix is very common in India. Very common in India. So be very clear. If India word is mentioned, then of course answer will be cancer cervix. But sometimes, we have started debating that cancer cervix is becoming so common now because human papilloma virus is the cause of cancer cervix and human papilloma virus is transmitted sexually. We know that cancer cervix is common in India, but now the incidence of cancer cervix is increasing throughout the world because HPV is transmitted sexually and because of sexual intercourse. So sometimes we are in a dilemma, we are under a trap that what should be the answer to this question, most common cause of postmenopausal bleeding, whether it should be endometrial atrophy or cancer cervix. Really, it is a confusional situation, but I have to give you one vote. This is why I have designed these 4 MCQ like this. So my vote would be, if most common cause of postmenopausal bleeding is A, if endometrial atrophy is given in option, you should choose that answer. If endometrial atrophy is not given, then go with cancer cervix and put a tick on endometrial atrophy. If endometrial atrophy is not given in options, then go with cancer cervix. Question number 2. Most common cancer responsible for postmenopausal bleeding? If the word cancer is asked, then endometrial cancer. Endometrial cancer. It is more common in Western world because Western population remain nulliparous for a longer time. They are exposed to more estrogen, and endometrial cancer is due to excessive estrogen. Number 3 and number 4. Answer to both the questions is say. We have to read this word very carefully in the question. If the word developing countries is mentioned, like India is mentioned, most common cause or most common cancer responsible for postmenopausal bleeding in developing countries, then this is cervical cancer. Although, let me make this very clear, I am very well aware, we all are very well aware that cervical cancer is much more common than endometrial cancer. We all know that. We all know that. But if you go through the global statistics, endometrial atrophy is a condition which will happen in almost all menopausal females. Endometrial atrophy is a condition which will happen almost invariably in all menopausal females. So, of course, what should be the most common answer? Does cancer cervix occur in all menopausal females? No. Fine. Clear. And we are discussing which bleeding here. This is postmenopausal bleeding. Cancer cervix has bimodal age incidence. It occurs before menopause as well as after menopause. 35 to 39 years and 55 to 65 years. Still, I say, it is a 51-49 story. Finally, it is in the head of Almighty the Great. Just pray and mark the answer. Fine. Now, if she comes with irregular bleeding per vagina, most common symptom here would be bleeding PV, irregular bleeding. This is just a gross image just to show you that this is an endometrial cancer here at display. This is endometrial cancer, just a gross exam, gross image. No MCQ will be asked, I'm sure. So this cancer is here in the endometrium. This is our uterus, this is our cervix, this is our vagina, this is our fallopian tube, and these are our ovary. And this is the place where the endometrial cancer is situated. Now, whenever, if a patient, write this is a MCQ, if a female presents with, if a female presents with history of irregular bleeding per vagina, if a female presents with irregular bleeding per vagina, irregular bleeding PV, what is the next step? Next step is ultrasonography. If a female presents with irregular bleeding per vagina, what is the next step? Next step is ultrasonography. And this ultrasonography may show increased endometrial thickness. Very important question. If a female presents with irregular bleeding per vagina, what is the next step? Next step is ultrasound. Do you remember we solved a similar kind of question? I think you are not able to listen. You are not able to listen. I think since when it happened, can you tell me from which place? I just saw. Yeah, yeah. Now it's all right. Now it's all right. I will tell you what I did. I think actually there's an audio input capture. By mistake, when I was switching the camera, so I just closed that audio input capture. This is why you were not able to listen to me. But can you tell me, can you just WhatsApp me? It happened how many minutes before? It happened how many? The time when you switched screen to full. Oh, okay, for last 5 minutes. Don't worry. Don't worry. So I will repeat the last 5 minutes class. Don't worry. Don't worry. Those 5 minutes were very important. I asked you a lot of chocolate questions and I gave you many chocolates. So you missed all the chocolate. I gave many chocolates for those questions. Let me repeat. Oh, so God was saving my chocolates, but I don't want to save my chocolate. I want to give you the chocolate. So let's start that. I'm again switching over to the camera, but I will focus on the audio input capture now. So it's fine. I can see it's not closed. I asked you one question. Here, we have written if a female presents with irregular bleeding per vagina. I repeat the question. If a female presents with, I hope everything is fine now. If a female presents with irregular bleeding per vagina, if a female presents with irregular bleeding per vagina, what is the next step? Ultrasound. I am asking you, the chocolate questions were where I gave, I think, almost 1,000 or 1,500 chocolates I distributed with that question. The question was if an 18 or 19-year-old girl presents with primary amenorrhea, full stop. Second line of the question was breasts are normally visualized in her, full stop. Third line of the question is what is the next step? The answer is this is the chocolate question. 18-year-old girl presents with primary amenorrhea, full stop. Breasts are normally visualized in her, full stop. What is the next step? Answer was, anyway, you can text me all this after the class, not right now. Otherwise, this mobile will be flooded with these messages and I will miss your query. I'm answering 80 to 85% queries every day, still 10 to 15% are missed. But I will be able to answer all the queries, maybe in 1 or 2 days. When we are not having classes, then it's easy for me to answer all the queries. During the class day, the mobile is flooded. So I cannot answer 100% of the query. So don't just post me the answer that I answered correctly. I answered correctly. The day when there is no class, you can text me, sir, I gave the answer correctly. My chocolate is due with you. But write your name so that I can remember that whose chocolates are due. Fine. So we'll be discussing lot of chocolate questions in the class. Don't worry. So 2 questions, same answer. If a 20-year-old girl presents with primary amenorrhea, secondary sexual characters are normal in her, what is the next step? Ultrasound. Question number 2. These two are very, 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 very important questions. A female presents with irregular bleeding per vagina. What is the next step? Ultrasound. Let's write down. Fine. So if she's presenting with irregular bleeding, we are doing ultrasound and suppose, oh my God, this is the thickened endometrium. This is the thick endometrium, this one. And if endometrial thickness is more than how much we consider thickened endometrium in a menopausal lady, if endometrial thickness is more than 4 millimeter, if endometrial thickness is more than 4 millimeter, it is considered thickened endometrium. Let's write down. Increased endometrial thickness means if it is more than 4 mm. That is a thickened endometrium in a menopausal lady. Important chocolate question, important single liner question. Then what is the next step? If ultrasound shows increased endometrial thickness, what is the next step? Next step here is a screening test. What is this screening test? We have few aspirators like Wibble aspirator, Vabra aspirator, Pippel aspirator. By these Wibble, Vabra, Pippel aspirator, we take endometrial aspiration biopsy. Let me show you that Pippel aspirator. By this Pippel aspirator, we can take this endometrial biopsy. Have a look here. This is a Vabra and a Pippel aspirator. These are the aspirators, and with the help of these aspirators, we can take the endometrial aspiration biopsy with these places. We take out the tissue. So she came to us with irregular bleeding per vagina. We did an ultrasound, and if ultrasound showed thickened endometrium, What is the thickened endometrium in a menopausal female if endometrial thickness is more than 4 millimeter? It is a thickened endometrium. And if endometrium is thickened in a menopausal female, what is the next step? We do a screening test. What is the name of a screening test? Endometrial aspiration biopsy. By what we do endometrial aspiration biopsy? By these aspirator. These are disposable set for endometrial biopsy. These are disposable sets for endometrial biopsy. We take the biopsy and we throw this device. Let's write down. A screening test is endometrial aspiration biopsy. Endometrial aspiration biopsy. We'll take the biopsy and we will send the sample to the pathologist. Then pathologist will examine it in microscope and will send the report. There is a possibility that pathologist may say, "Oh, doctor, you didn't take the sample correctly, or I am not able to conclude much with this sample. I need a better sample, because this sample is inconclusive." This is also possible. Let me tell you, the possibility here is what is possible here. What is possible? Audio input capture fine. What is possible here? You have taken an endometrial biopsy, maybe from one wall of endometrium, maybe from anterior side of endometrium, and a malignancy was on posterior wall of endometrium. This is why you are saying she is having a problem, and my report I am not able to conclude anything. Send me another sample. Then we will do a definitive test. A definitive test now is a fractional curettage. What is the meaning of word fractional curettage? Fractional curettage means from each and every fraction of endometrium. We take how many samples? 7. 7 samples are taken in fractional curettage. 7 samples are taken in fractional from anterior wall, from posterior wall, from fundus, from isthmus, from each and every place. Now there is no chance of missing out the malignant area. This is why this is called fractional curettage, because we take the sample from each and every fraction of endometrium. Total, how many samples are taken in fractional curettage? 7 samples. Now you tell me, how you can be sure that you have taken out from anterior wall, you have taken out from posterior wall, you have taken out from all the places. If you are doing the procedure blindly or under camera guidance. Of course, if you are doing the procedure under camera guidance. This is why this is called hysteroscopic fractional curettage. Let's write down. Fine. So definitive test would be hysteroscopic fractional curettage. Total 7 samples are taken in fractional curettage. Hysteroscopic biopsy can also be done. We can use the hysteroscope and we can take the biopsy if lesion is localized. If lesion is localized, it is a focal lesion. Suppose endometrium is thickened at one particular place. It is thickened at one particular place. So we are sure the pathology has to be here, because endometrium is thickened only at this particular area. So we are expecting pathology here only. So we can take out biopsy from that thickened area. But fractional curettage would be a high yielding because you are taking total 7 samples. Theoretically, if you want to debate hysteroscopic biopsy, we are using hysteroscope with fractional curettage also. But the problem is endometrium is focally thickened at one particular place. Could be due to some other reason also. and malignancy is at a different place. Debatable story. Anyway, screening test endometrial aspiration biopsy, definitive test hysteroscopic fractional curettage, and hysteroscopic biopsy. Just write down aspiration biopsy can be done by Vabra and Pipel aspirator. By Vabra and Pipel aspirator. That's all. So we have taken the biopsy. She came to us with irregular bleeding per vagina. We did an ultrasound. Ultrasound shows increased endometrial thickness. We did a screening test, endometrial aspiration biopsy. Then we did a definitive test. Now pathologist will send the report and she will come to us with the report. She is coming to our OPD and she is saying, Doctor Sahab, this is the report. You said that get done a ultrasound. I got it done. You said I will do an endometrial aspiration biopsy. I got it done. You said I will do a hysteroscopic fractional curettage because pathologist is calling me. I got it done. Now at least tell me what's wrong with me. This is the report and pathologist has written it is simple hyperplasia without atypical cells. Pathologist could not see the frank endometrial cancer. If pathologists could see the frank endometrial cancer, pathologists would have written clearly adenocarcinoma because the epithelium is columnar. Because the epithelium is columnar, so obviously it has to be which carcinoma? Obviously it has to be adenocarcinoma. Adeno, everything is fine. Scared now. Looking at it. Fine, don't worry. So pathologists would have clearly written adenocarcinoma because the epithelium, let me put it here. Otherwise, I am in a habit of keeping the mobile in prone position whenever I am doing anything important, whether it is clinical or whether this is teaching in offline class. But in online class, now I have developed a habit to keep the mobile in supine position to get the feedback. That's important. Why I keep the mobile in prone position? It is silent, but the advantage which I tell in all my classes, keep the mobile not only on silent mode but in prone position. Why? In prone. Even if there is a message, there is a flashlight on the mobile and you are distracted. So you should keep the mobile in prone position. I will keep mobile in supine in an online class, not otherwise. Simple hyperplasia without atypical cells. Pathologists could see only endometrial hyperplasia, not the frank cancer. And this is what examiner is also interested in us. Examiner gives us MCQ. If the endometrial hyperplasia is simple and atypical cells are absent, how much is the risk of transformation to frank malignancy later on in life? This is 1%. This is 1%. And we will tell the patient same thing, that you are at 1% risk of developing endometrial cancer. Complex hyperplasia. If the hyperplasia is complex without atypical cells, risk of endometrial cancer is 3%. Report number 3 may be hyperplasia is simple, but now it is with atypical cells. Risk of malignant transformation is 8%. Report number 4 may be complex hyperplasia with atypical cell. Risk of malignant transformation here is 29 to 30%. So these are 4 reports and these are 4 MCQ. This is what we are telling the patient and this is what examiner is interested in us. If the report is this, how much is the risk of development of frank malignancy later on in life? So maximum risk of development of frank malignancy later on in life is if endometrial hyperplasia is complex and atypical cells are present. And least risk is if hyperplasia is simple and atypical cells are absent. So we are very clear with these four MCQs. What is the management of endometrial hyperplasia? It was not endometrial cancer, be clear. It was just endometrial hyperplasia. If it was endometrial cancer, pathologists would have clearly written in the report adenocarcinoma because epithelium of endometrium is columnar. So obviously it would be adenocarcinoma. Those concepts have been cleared in the pathology in the topic neoplasia. Management of endometrial hyperplasia. If atypical cells are absent, then we don't do surgery. Then we can give her progesterone. We have written if progesterone is given continuously, it downregulates estrogen receptor. We have written this concept. So we can give her progesterone. And the best progesterone is medroxyprogesterone acetate because it is devoid of any estrogenic activity. Zero estrogenic activity in medroxyprogesterone acetate. So, which progesterone is preferred? Medroxyprogesterone acetate. But if atypical cells are present, then we'd have to do the surgery. We don't take any risk because risk of progression to frank malignancy later on in life is more. Which surgery has to be done? If age is less than 45 years, we can remove uterus only and we can leave ovaries. She is a young lady. Ovary will give her estrogen. Estrogen will maintain her femininity, her secondary sexual characteristic. But if the age is either 45 or more than 45 years, we remove not only uterus but BSO. What is this BSO? Bilateral salpingo oophorectomy. Bilateral salpingo oophorectomy. What we can do here, it's been 2 hours and in an online class, you are focusing continuously on your mobile or on iPad. So as usual, we will take a short break here for 15 minutes and we will resume our class. This is 4:27. So we will resume our class at 4:43. A 15 minutes break. Just after 15 minutes, we will resume our class here. So we discussed that if a lady presents with irregular bleeding per vagina, let me quickly summarize. So we'll move. If a lady presents with irregular bleeding per vagina, what is the next step? Ultrasound. If ultrasound shows increased endometrial thickness after menopause 4 mm, more than 4 millimeter, then we do endometrial aspiration biopsy, screening test, definitive test, hysteroscopic fractional curettage. And if pathologist says endometrial hyperplasia, then we have to see which type of hyperplasia is this. If atypical cells are present, we do surgery. If atypical cells are absent, we give medroxyprogesterone acetate. Because if we give progesterone for a longer time, it downregulates estrogen receptor. So finally, endometrium will thin out. If atypical cells are present, surgery. Then we saw which surgery. If age is less than 45 years, we remove only uterus. Total abdominal hysterectomy. If age is 45 or more than 45 years, we not only remove uterus, along with uterus we remove both fallopian tubes and ovaries, which is called total abdominal hysterectomy with bilateral salpingo-oophorectomy, means pan-hysterectomy. Now, we are done with endometrial hyperplasia. Let's look other way around. If pathologist says adenocarcinoma, what can be the possibilities? What are the most common symptoms here? We discussed the risk factors. Most common symptom of endometrial cancer is irregular bleeding per vagina. Irregular bleeding PV. Irregular bleeding per vagina. Read the MCQ very carefully. Question number 1, what is the most common symptom of endometrial cancer? Question number 2, what is the most specific symptom of endometrial cancer? This is post-menopausal bleeding. So read the MCQ very carefully. Whether examiner is asking most common symptom of endometrial cancer or most specific symptom of endometrial cancer. The most common is irregular bleeding PV, most specific postmenopausal bleeding because endometrial cancer occurs only after menopause. Fine. Other symptoms of endometrial cancer. What can be other symptoms in endometrial cancer? Other symptoms. Other symptoms in endometrial cancer. She may complain of pain in hypogastrium. Hypogastrium means suprapubic region. Why she may complain of pain in this suprapubic region? Suppose there is a cancer here. This is the endometrial cancer. This is uterus. Outermost layer of uterus is serosa. Middle part of uterus is myometrium. And this is endometrium. And suppose this is a cancer here, endometrial cancer. And if this endometrial cancer occlude the passage, this is large enough, and it has blocked the passage of secretions, no fluid can go out of endometrial cavity. Serous fluid, normal fluid is also not going out. It is collected inside. And if it gets infected, pus develops here in endometrial cavity. And this is called pyometra. So pyometra can develop in Asherman syndrome, in genital TB we discussed. It can develop in endometrial cancer also. And because of this pus, there is inflammation. She may complain of some pain in hypogastric region, and this pain is called Simpson pain. Name of this pain is Simpson pain. So if you get a MCQ, Simpson pain is seen in which condition? Endometrial cancer. And because of this only, there can be this watery, purulent discharge from vagina. This is called hydrorrhea. And finally, pyometra may develop. So these are all various other associated findings in endometrial cancer. But most common symptom of endometrial cancer, irregular bleeding per vaginum. Most specific symptom, postmenopausal bleeding. Those two questions are very, very important. Let's put a tick there. Very important two questions. Most common symptom, irregular bleeding PV. Most specific symptom, postmenopausal bleeding. Now, we discussed pathologist sent the report endometrial hyperplasia. Now, if pathologist is confident enough to report adenocarcinoma, pathologist has no doubt. Pathologist has seen the frank cancer. Then let us discuss what are the most common histopathological findings across the globe. Throughout the globe, pathologists are reporting endometrial cancer. What they are reporting the most common histopathological finding in endometrial cancer. What do they find most commonly when they are doing a microscopic examination of this endometrial tissue? The most common histopathological finding is type 1 endometrial cancer. And type 1 endometrial cancer is also called endometrioid adenocarcinoma. Endometrioid adenocarcinoma. Type 1 endometrial cancer means endometrioid adenocarcinoma. Rarely, some rare histopathological findings which are more dangerous. They are type 2 endometrial cancers. So type 2 endometrial cancers are rare but more dangerous. These are non-endometrioid endometrial cancer, non-endometrioid adenocarcinoma. Non-endometrioid adenocarcinoma, these are usually these variety. The most common non-endometrioid being clear cell carcinoma, the second most common being papillary serous carcinoma or papillary carcinoma. So overall, most dangerous endometrial cancer is clear cell carcinoma. Most dangerous variety of endometrial cancer is clear cell carcinoma. Most common histopathological finding is endometrioid adenocarcinoma or type 1 endometrial cancer. So we are very clear. And we can easily understand the basic pathological concept. What comes to your mind when you read the word endometrioid adenocarcinoma? Let me explain. The very important pathological concept, endometrioid adenocarcinoma. What comes to your mind when you hear this word? Endometrioid means it still resembles endometrium. Non-endometrioid, it does not resemble endometrium at all. Means the original endometrial pattern is totally lost. It does not resemble endometrium. Means it has moved miles away from its original texture. So obviously which will be more dangerous? Which has changed a lot. जो बिल्कुल बदल गया वो ज्यादा खतरनाक हो गया. So non-endometrioid does not resemble endometrium at all. So obviously it will be more dangerous. Endometrioid, it is still resemble endometrium. अभी भी यार endometrium के जैसा ही तो है, ज्यादा थोड़ी पतला है. So endometrioid less dangerous, non-endometrioid more dangerous. Fine. Let's compare type 1 and type 2. Type 1 endometrial cancer or endometrioid adenocarcinoma, they are associated with increased estrogen. They are due to increased estrogen. So obviously they will be more in obese female, they will be more in western, white, nulliparous female. White females means western females, they remain nulliparous for a longer time. Gene mutation here is P10 and KRAS. Gene mutation responsible for type 1 endometrial cancer is P10 and KRAS. While type 2, which are more dangerous variety, they have no relation with estrogen. They have no relation with obesity, obviously. No relation with white nulliparous female. They can occur in black females also. And the gene mutation here is P53. So gene mutation responsible for type 1 is P10 and KRAS. Gene mutation responsible for type 2 is P53. Here write down the gatekeeper of endometrial cancer is. What is the gatekeeper of endometrial cancer? This is P10 gene. Means the main protection for endometrial cancer is by P10 gene. If these genes get mutated, they lose their protective power. So this is mutation in genes which is responsible for cancer. Genes are protective, they protect the cancer, they prevent the cancer. लेकिन अगर वो जीन खुद ही खराब हो गए, if mutation occurs in genes, they lose their protective power. So which one of these three is considered as gatekeeper of endometrial cancer? P10 gene. Most common route of spread is direct spread. Direct spread. They spread directly. Most common site of recurrence when we have done a hysterectomy is still what we do when do hysterectomy, we leave a small vaginal stump that is called vaginal wall. You remember the topic prolapse? We discussed in the topic prolapse vault prolapse. What is the vault? Vaginal stump which is left after hysterectomy. That vaginal stump is the most common site of recurrence in endometrial cancer. So most common site of recurrence is vagina. Of course, we have done a hysterectomy. So in the bracket, you can write down vaginal vault. Of course, we have done a hysterectomy because staging in endometrial cancer is surgical. We do a surgical staging in endometrial cancer. We do the surgery. We do the hysterectomy. Staging. Staging, write down, staging is surgical and staging is the most important. Prognostic factor for endometrial cancer. There are various words, staging, grading, but staging is the most important prognostic factor for endometrial cancer. Stage 1 is subdivided in 1A and 1B. 1A if endometrium is involved or less than 50% or less than half of myometrium is involved. This is 1A. What is 1B? Either 50% or more than 50% of myometrium is involved. This is 1B. So staging means how much cancer has metastasized, how much it has spread. ये कैंसर कितना दूर चला गया, उसको कहते हैं staging. This is the most important prognostic factor. Stage 2 is if cervix is involved. If cervix is involved, this is stage 2 of endometrial cancer. Stage 3A, involvement of serosa, adnexa, peritoneum. 3B, if vagina is involved. 3C1, if pelvic lymph nodes are involved. 3C2, if para-aortic lymph nodes are involved. This is C2. Stage 4 is a stage of metastasis. In 4A, there are regional metastases either to anterior region or to posterior region. Urinary bladder or rectum is involved. 4B, if there are distant metastases. So these are various stages of endometrial cancer. Now, let me show you. These are various stages of endometrial cancer. Have a look here. Have a look at this image. Let me show you it here. This is endometrial cancer. Stage 1A. What was stage 1A? Endometrium is involved or less than 50% of myometrium is involved. What was 1B? Either 50% or more than 50% of myometrium is involved. What is stage 2 in endometrial cancer? What is involved here? Cervix is involved. If cervix is involved in endometrial cancer, this is stage 2. What is 3A? Serosa, adnexa, or peritoneum. Look here. This cancer is reaching here. Serosa means outermost layer of uterus. Adnexa means tubo-ovarian region. This is fallopian tube and this is ovary. So if cancer is spreading to adnexal region or tubo-ovarian region and peritoneum, this is 3A. What is 3B? If vagina is involved in endometrial cancer, this is 3B. This is the involvement of vagina. Very important MCQ. This question has been asked multiple times in various exams. If vagina is involved in endometrial cancer, what is the stage? 3B. Maybe because they are asking this MCQ multiple times because most common site of recurrence in endometrial cancer is vagina. Then we have 4A and 4B. 4A, regional metastasis, either to anterior region or to posterior region. Anterior region either to bladder or to bowel. And 4B is the distant metastasis. You can see the metastasis even in the liver. So these are various stages. Meaning of the word stage is how much cancer has spread, how much cancer has metastasized. Staging is the most important prognostic factor. Now, this was staging. There is a word called grading of endometrial cancer. What we mean by grade of endometrial cancer? Grade. Let me discuss you this pathological concept. Grade. Staging means cancer कितना दूर चला गया. Most important prognostic factor. How much it has metastasized. Grade means power of the cancer. How much powerful is the cancer? Grade 1, grade 2, grade 3. Grade 1 is well differentiated. Grade 2 is moderately differentiated. Grade 3 is poorly differentiated. Well differentiated grade 1. Well differentiated means still you can see endometrium here. Endometrium can be seen very well here. Endometrium is well differentiated. Grade 3 poorly differentiated. You cannot see any endometrium here. And grade 2 is between. Theoretically, grade 1 if less than 5% malignant tissue seen. Grade 2 5 to 50%. Grade 3 more than 50%. Let's write down. So staging means how much cancer has reached. Grade means how powerful is the tumor. And power of tumor is denoted by number of malignant, amount of malignant tissue in the tumor. Let's write down. Great. Let me write the mean. Let's use this space and I can write the meaning of word grade here. Grade 1 means well differentiated. Malignant tissue or solid tissue here is less than 5%. This is grade 1. What is the grade 2? Grade 2 is moderately differentiated. Moderately differentiated. Malignant tissue here in grade 2 is between 5 to 50%. Grade 3 is poorly differentiated. Amount of malignant tissue in grade 3 is amount of malignant tissue in grade 3 is more than 50%. So this is how we have three grades of tumor: grade 1, grade 2, grade 3. Grade 1 is also called well differentiated, grade 2 moderately, grade 3 is poorly differentiated, and it depends on amount of malignant tissue, and malignant tissue decides the power of a tumor. So grade means how powerful is the tumor. Let's go back to our staging. Management. Management, if it is 1A grade 1 2. 1A grade 1 2. 1A means either tumor is in endometrium or occupying less than 50% of myometrium. Grade 1 2 means well differentiated or moderately differentiated. Management here is total abdominal hysterectomy plus bilateral salpingo-oophorectomy. Very important MCQ zone has been asked in our exam 3 years before. What is the management of endometrial cancer? 1A grade 1 and size given was somewhere 1.5 or 1.6 centimeter. So we do total abdominal hysterectomy with bilateral salpingo-oophorectomy in 1A grade 1 2. And if tumor size is less than 2 centimeter, important MCQ zone, no lymph node is dissected. In 1A grade 1 2, lymph node dissection is done if tumor size is 2 centimeter or more than 2 centimeter. And which lymph node dissection is done? Only pelvic lymph node dissection. Important MCQ of our exam. They asked this question in our exam. So 1A grade 1 2, size less than 2 centimeter, no lymph node dissection is done. If size is 2 or more than 2 centimeter, which lymph node dissection? Only pelvic lymph node. If it is 1A grade 3 or 1B, TAH plus BSO, total abdominal hysterectomy plus bilateral salpingo-oophorectomy. Now onwards, we do both pelvic and para-aortic lymph node dissection. Just in the first case, we are doing only pelvic lymph node dissection, and that too if the size is 2 or more than 2 centimeter. After this, both pelvic and para-aortic lymph node dissection followed by post-op radiotherapy. So very important MCQ zone, adjuvant post-op therapy is not required in which stage of endometrial cancer? 1A grade 1 2. Another very important question for our exam. Post-op radiotherapy is not required in which stage? 1A grade 1 2. Even pelvic lymph node dissection is done if tumor size is 2 centimeter or more than 2 centimeter. Then stage 2, Vardaim hysterectomy. What is involved in stage 2? Cervix is involved. Whenever cervix is involved, Vardaim hysterectomy is done. And obviously pelvic and para-aortic lymph node dissection followed by post-op radiotherapy. Followed by post-op radiotherapy. For stage 3 and 4, we do the debulking surgery. Debulking surgery is we take out almost everything from pelvis with of course pelvic and para-aortic lymph node dissection. In 3 and 4, it is followed by post-op not only radiotherapy but chemoradiation. Not only radiotherapy but chemoradiation. Combination of chemo and radiotherapy. And cisplatin is the chemotherapeutic drug which is used. And this cisplatin acts as radiosensitizer. This cisplatin acts as radiosensitizer. What is the meaning of word radiosensitizer? Radiosensitizer drug means it increases efficacy of radiotherapy. It increases efficacy of radiotherapy. Now, our last topic today is cervical cancer. But before cervical cancer, let's solve the questions of endometrial cancer. If superficial inguinal lymph nodes are involved in endometrial cancer, what is the stage? If superficial inguinal lymph nodes are involved, it is 4P. Because inguinal lymph nodes are not pelvic nodes, they are extra pelvic nodes. So they will be considered in the category of distant metastasis. Another MCQ I ask you here in the staging of endometrial cancer. Everything is clear cut. I am asking you one question. If ascites develops in endometrial cancer, what is the earliest stage? Rest all the questions are straightforward. If vagina is involved, 3B. If pelvic lymph nodes involved, 3C1. If para-aortic lymph nodes involved, 3C2. Indirect question, if ascites is involved, chocolate question, then you can text me later on after 2 3 days. Yes, I deserve the chocolate. Yes, I will feel happy to share the chocolate. If ascites develops in endometrial cancer, the earliest stage is 3A. 3. And don't forget to solve questions on Telegram at 9 p.m. I will again make good questions and will put at 9 p.m. We'll make the questions after the class. We'll design the questions, we'll put the googly ball and try to answer those questions. Anyone who has not answered the questions of yesterday or day before yesterday, please do solve the question and let me know how much you scored. Ascites, if ascites develops, peritoneum is involved, means 3A. All of the following are correct regarding endometrial cancer except P10 gene mutation correct, corpus cancer syndrome correct, postmenopausal bleeding correct, most common site of recurrence is ovaries or vagina. Most common site of recurrence is vagina. Post-op management of endometrial cancer 1A grade 1A. In 1A grade 1, no post-op treatment is required, not given. This is the only stage in which no post-op treatment is given. All of the following are protective factors for endometrial cancer except smoking is protective, physical exercise is protective, nulliparity is not protective, it is a risk factor. Oral combined pill is protective. All of the following statements are correct regarding histopathology of endometrial carcinoma type 2 except endometrioid, no. Type 2 are non-endometrioid. Clear cell, yes. Papillary serous, yes. Gene mutation is P53. That's true. Last topic, cervical cancer. Cervical cancer, before going through cervical cancer, let us draw a ray diagram. This is uterus, this is cervix, and this is vagina. This is endocervix and this is ectocervix. Endocervix and ectocervix. What is ectocervix? Ectocervix means part of cervix which is in vagina. This is ectocervix. And epithelium of ectocervix is squamous epithelium, while epithelium of endocervix is columnar epithelium. Ectocervix or portio vaginalis, part of cervix which is in vagina. So this is the ectocervix here. And ectocervical epithelium is squamous epithelium. It is squamous epithelium. While endocervical epithelium is columnar epithelium. This is endocervix, which has columnar epithelium. And what happens normally in a female? This columnar epithelium of endocervix converts to squamous epithelium of ectocervix. This happens normally in all females. And the place at which it happens, this place is called squamocolumnar junction. What is the name of this place where endocervical columnar epithelium converts to ectocervical squamous epithelium? This is called squamocolumnar junction. This is also called transformation zone. Why this is called transformation zone? Because here occurs transformation of endocervical columnar epithelium to ectocervical squamous epithelium. This is why this place is called squamocolumnar junction or transformation zone. This happens normally in a female and name of the process is metaplasia. This is called metaplasia. If abnormal cells are formed instead of formation of normal cells, the process will be called dysplasia. And what should be the most common site of formation of abnormal cells or most common site of dysplasia is this squamocolumnar junction or transformation zone. Let's write the notes. Transformation of endocervical. Transformation of endocervical columnar to ectocervical squamous epithelium occurs at squamocolumnar junction. This is also called TZ. What is full form of TZ? Transformation zone. And this is a normal process and name of this normal process is metaplasia. This is called metaplasia. If abnormal cells are formed instead of formation of normal cells, this process is called dysplasia. If abnormal cells are formed instead of formation of normal cells, this process is called dysplasia. Most common site of dysplasia or most common site of cancer cervix is squamocolumnar junction or transformation zone. This squamocolumnar junction is also called transformation zone. So most common site of dysplasia is squamocolumnar junction or transformation zone. Clear. Just a gross specimen of cervical cancer, not a MCQ. We are just seeing where is the cancer. This is the place of cancer here. Cervical cancer. This is the place. Causes of dysplasia. Most common site is squamocolumnar junction. Most common cause of dysplasia or cancer cervix is human papilloma virus. Most common cause, just remove this, just write down human papilloma virus. Most common cause of dysplasia or most common cause of cancer cervix is human papilloma virus. This is HPV, human papilloma virus. Most common cause of cancer cervix and most sensitive for cancer cervix is HPV-16. Most common cause of cancer cervix and most sensitive for cancer cervix is HPV-16. It attacks on ectocervix mainly and causes squamous cell carcinoma because epithelium of ectocervix is squamous epithelium. So HPV-16 causes squamous cell carcinoma. While most specific for cervical cancer is HPV-18. Most sensitive for cervical cancer is HPV-16. Most specific for cervical cancer is HPV-18. It attacks endocervix mainly and the epithelium is columnar. So HPV-18 causes adenocarcinoma. HPV-16 causes squamous cell carcinoma. HPV-18 causes adenocarcinoma. Cofactor in cervical cancer is HIV. If she is HIV positive, risk of cervical cancer is more in her. Other risk factors: low socioeconomic class, poor hygiene. Because it is the infection. Cancer cervix occurs due to infection, and infections are more common in low socioeconomic class. They are not using barrier contraceptives, and human papillomavirus is transmitted sexually. Multiparity. Why cancer cervix is more in multipara? Because pregnancy is a risk factor for cancer cervix. Endometrial cancer was more in nullipara. Cervical cancer is more in multipara. Because pregnancy itself is a risk factor for cancer cervix. So if she delivers 10 children, 10 times she passed through risk zone. Why pregnancy is a risk factor for cancer cervix? Because in pregnancy, basal metabolic rate increases, BMR increases. Because basal metabolic rate increase in pregnancy, speed of conversion of endocervical columnar cells to ectocervical squamous cells increase. Anemia and smoking, they are risk factor because in anemia and smoking, there is hypoxic environment in blood. Oxygen carrying capacity is reduced. So cervix also becomes hypoxic. So it is not able to fight against human papilloma virus. Multiple sexual partner because it is a STD, because HPV is a sexually transmitted disease. So intercourse with multiple partners carries risk of cervical cancer. OCP use, exact explanation is not available. If she has used OCP for at least 5 years, then there is risk of cervical cancer, and in OCP users this is mostly adenocarcinoma. Columnar epithelium is involved. Some glandular changes occur. Higher level story. Just write down. OCP is protective for endometrial cancer, protective for endometriosis, but it is a risk factor for cervical cancer. And which vaginitis can occur even in OCP user? Candidal vaginitis. There is a word called cervical intraepithelial neoplasia. Cervical intraepithelial neoplasia means neoplasia is inside cervical epithelium only. It is not coming out of epithelium. This is why it is called cervical intraepithelial. Intraepithelial means inside the epithelium. Let's have a look at our ray diagram. This was our ray diagram. Means this cervical cancer, this is confined to this epithelium. It is not coming out of the epithelium. It is inside epithelium. This is why we call cervical intra. Intra means inside. Intraepithelial. It is not here in the cervical stroma. It is not here. It is only in the epithelium. How do we categorize CIN? CIN1 if less than 1/3 of epithelium is involved. Less than 1/3, not of whole cervix, only of epithelium. CIN2 if 1/3 or more than 1/3, but less than 2/3 of epithelium is involved. CIN3 if 2/3 or more than 2/3, but less than whole thickness of epithelium is involved. Carcinoma in situ if whole thickness of epithelium is involved. And when we start saying this invasive cancer, if basement membrane of epithelium is broken, if basement membrane of epithelium is broken, if basement membrane of epithelium is broken and dysplasia invade out of epithelium. The basement membrane is broken and dysplasia comes out of epithelium. This is called invasive cancer. So this is how these are all single liner questions. What is the CIN1? How much epithelium is involved? And basement membrane is broken only in invasive cancer. Till carcinoma in situ, basement membrane is intact. Depending on the how much epithelium is involved, we call it CIN1, 2, 3 or carcinoma in situ. Bethesda gave a new classification to categorize these CINs carcinoma in situ. Bethesda used two words. One is LSIL, low-grade squamous intraepithelial lesion, and HSIL, high-grade squamous intraepithelial lesion. LSIL and HSIL. CIN1 is categorized as LSIL, while CIN2, CIN3 and carcinoma in situ, these are categorized as HSIL. And invasive cancer as invasive cancer, it cannot be part of HSIL. HSIL means high-grade squamous intraepithelial, and invasive cancer means coming out of epithelium. So LSIL, HSIL and invasive cancer. Age incidence for CIN 1, 2 and 3. CINs start from 20 years. This is from 20 to 29 years. Carcinoma in situ 30 to 35 years. Invasive cervical cancer, it has bimodal age incidence. Bimodal means it can occur before menopause as well as after menopause, like 35 to 39 years and 55 to 65 years. So cervical cancer can occur before menopause as well as after menopause, while endometrial cancer occurs only after menopause. This is why most specific symptom in endometrial cancer was postmenopausal bleeding. But cervical cancer can cause premenopausal bleeding as well as postmenopausal bleeding because it can occur before menopause as well as after menopause. Most common symptom in cervical cancer is irregular bleeding per vagina. Irregular bleeding per vagina. Most specific symptom. Look here. This is the cervical cancer. This is uterus and this is cervix. This is the cancer here. This cancer is beginning. When the malignant focus is small, it will bleed after intercourse. she will have contact with her male partner, she will have intercourse, and it will bleed because of friction of intercourse. So, most specific symptom or earliest symptom of cervical cancer. Answer to these two questions. What is the earliest symptom of cervical cancer, or what is the most specific symptom of cervical cancer? This is postcoital bleeding. She is complaining of bleeding per vaginum after intercourse. This postcoital bleeding is also called contact bleeding. She had bleeding after contact with her male partner. So read the MCQ very carefully. If the most common symptom is asked in endometrial cancer as well as in cervical cancer, irregular bleeding baby. Most specific symptom in endometrial cancer, postmenopausal bleeding. While most specific symptom in cervical cancer is postcoital bleeding or contact bleeding. And this is the answer to another MCQ. What is the earliest symptom in cervical cancer? Postcoital bleeding. And when this cervical malignancy becomes large enough, it will not require intercourse for it to bleed. It will bleed on its own as well. So most common symptom will become irregular bleeding per vagina. Screening test for cervical cancer. In rural area, cost-effective tests. They are less expensive, they are cheaper and easily available. In rural area, we do two screening tests. One is Willy, other is Wire. What is this Willy? Visual inspection with Lugol's iodine. Visual inspection with Lugol's iodine, 3 to 5% Lugol's iodine. So visual inspection with this Lugol's iodine. So if we apply this iodine on the cervix, normal areas become brown. If we apply this Lugol's iodine on the cervix, 3 to 5% Lugol's iodine on the cervix, normal area become brown. Why normal area become brown? Due to glycogen content in them. Normal cervical cells, they contain glycogen. And because of glycogen, they will become brown. While malignant areas, abnormal areas will not become brown because abnormal cells utilize glycogen due to exhaustive metabolism. And glycogen is finished in abnormal cells. Because glycogen is finished in abnormal cells, malignant cells eat up all the glycogen. So malignant areas don't become brown, normal areas become brown, mahogany brown due to glycogen. Another test is VIA. What is full form of VIA? Visual inspection with 3 to 5% acetic acid. Visual inspection with 3 to 5% acetic acid. If we apply acetic acid on the cervix, now abnormal areas become white. Abnormal areas means dysplastic area, malignant area. They become white due to coagulation of malignant proteins. Acetic acid causes coagulation of malignant proteins. This is why, due to coagulation of malignant proteins, abnormal areas become white if we apply acetic acid. And these areas are called aceto-white areas because they have become white after application of acetic acid. This is why these areas are called aceto-white areas. So these were two cost-effective Screening tests for cervical cancer mostly done in rural area because they are cheaper, they are less expensive, they are easily available. So if the cost effective word is given in MCQ was asked in our exam 2 years before. So what are the cost effective screening tests? Willy and Via. But the best screening test for cervical cancer is Pap smear. Best screening test for cervical cancer is Pap smear. It was invented by George Pepaniculo. George Pepaniculo. Fixative used in this Pap smear is 95% ethyl alcohol. Although this is the old Pap smear kit, old fixative. Now we do a different Pap smear. Let me show you the Pap smear kit. This is the old Pap smear kit. Old Pap smear kit. In this old Pap smear kit, we have this IR spatula. This is IR spatula. This is a wooden spatula. It has a concavity on one side. This is a endocervical brush. Endocervical brush. Old Pap smear kit. I will give you these images. I will put poll questions with all these images which I consider that you should take a photograph. So you can save there on the Telegram group, this next Telegram at 9 p.m. Maybe after 1 or 2 days, I will make these image questions and will post. But today I will post at 9 p.m. theoretical question. IR spatula, this is endocervical brush. How we do, and this is a cotton stick. And this is a slide. This is the old Pap smear kit. Old Pap smear kit. So what we do with this IR spatula, with this concave end, this is uterus and this is cervix. We rotate it at a squamocolumnar junction by 360 degree. And whatever smears are obtained, they are put on the slide. Then we introduce this endocervical brush in the cervical canal. And whatever smears are obtained, they are put on the slide. Means this IR spatula, endocervical brush, they are used to take smears from cervix. With IR spatula, we take a smear from squamocolumnar junction, from endocervical brush, from endocervical canal, and with this cotton stick from posterior fornix. Whatever smears are obtained are put on the slide, fixed with 95% ethyl alcohol. And then this slide is sent to pathology. Now I will show you the new Pap smear kit. The new Pap smear kit, it is a liquid-based cytology. It is a liquid-based cytology. Now we are using this cytobrush. Now we use this cytobrush. You can see this is the cytobrush here. And there is a brush here at this place. This brush is used to take smears from every place. With this brush only we take smears from squamocolumnar junction. With this brush only we take smears from endocervical canal. And then what we do, we take this liquid methanol bottle. This is a liquid bottle. Now the latest pap smear is a liquid based cytology. So this is the liquid methanol bottle. What we do, we take the brush to the top of the bottle and then we cut the brush here. So this part of the brush, this top end of the brush dips in the bottle and we throw away this stick. So only this brush is cut and is put in this liquid methanol bottle. This is the liquid based cytology. Let me just show you. Let me put these images up. Let me shift them up and now. Fine. Latest or expensive is liquid-based cytology. Here, the device used is cytobrush and the fixative is liquid methanol. So put a tick on liquid methanol. It is the latest. If examiner gives you one question, what is the fixative used in Pap smear? If both are given, 95% ethyl alcohol and liquid methanol is a better answer. If liquid methanol is not given in option, then you can choose 95% ethyl alcohol. Pap smear is started at the age of 21 because risk of CIN starts at 20 year, 20 to 29 CIN. So we start Pap smear right at 21. Important MCQ. Pap smear is started at what age? 21. From 21 years to 29 years, we are doing it once in 3 years. 3 साल में एक बार करना. From the age of 21 years to 29 years, once in 3 years. Then from 29 years to 65 years. Then after 29 to 65 years. We have already written that once in 3 years. Then after 29 to 65 years. What we do, we prefer a co-test. Co-test is a combination of Pap smear and HPV DNA. And it can be done every 5 years, once in 5 years. But if she is living in those areas where facility for HPV DNA are not available, then PEPs alone is also sufficient. But if PEPs alone is done, it will be done after every 3 years. So be very clear what is best between the age group 29 to 65 years. Co-test. What is a co-test? Co-test is a combination of Pap smear and HPV DNA. Okay, fine. Then when co-test is done, after interval of every 5 years. And if she is living in those areas where facility for HPV DNA is not available, then Pap smear alone is also sufficient. But if you are doing only Pap smear, then it has to be done after interval of every 3 years. So we are done. Pap smear is started at what age? 21. Because risk of CIN start at what age? 20 years. Then, if last 10 years report were normal, we can stop screening at 65 because Pepsis cervical cancer bimodal 35 to 39 and 55 to 65. So if last 10 years report were normal, we can stop screening at 65 years of age. But if last 10 years report were abnormal, continue screening till 75 years, 10 more years. Even if one report was abnormal in last 10 years. Extend the screening protocol till 75. Otherwise, you can stop at 65. In HIV positive, annual screening is done, not after 3 years, because HIV is a cofactor for HPV. If she is HIV positive, risk of infection with human papilloma virus is high because HIV acts as a cofactor for cervical cancer. This is why in a HIV positive lady, every year screening is done. Pap smear report. Now she is coming to us with the report. This is a routine screening protocol. First possibility, let's hope for the best. If the report is normal, balle balle, party time, we will reassure her that nothing to worry now, but at the same time we will tell her to follow the screening protocol. Right now everything is fine. But if she is between 21 to 29, she has to repeat it after 3 years. And if she is between 29 to 65, she has to get done a code test after 5 years. Report number 2. If the report is unsatisfactory, pathologist is not able to conclude anything, then we will repeat Pap smear after interval of 2 to 4 months, average 3 months. If Pap smear report is suggestive of infection, Pap smear can diagnose infection also. We will treat infection and repeat PEPs after 2 to 4 months. on an average after 3 months. Which infections can be diagnosed by pap smear? Of course, HPV, human papilloma virus, can be diagnosed, and three infections of our vaginitis: Gardnerella, Trichomonas, Candida. Three of that vaginitis group can be diagnosed. Herpes can be diagnosed. Examiner is more interested in these most common causes of PID, chlamydia and gonorrhea. They can't be diagnosed by pap smear. So you will get an MCQ. All of the following infections can be diagnosed by pap smear except chlamydia and gonorrhea. Most common cause of PID, chlamydia. Most common cause of acute PID, gonorrhea. These two cannot be diagnosed by PAPs. Another possibility is atypical cells of unknown significance. If pap smear report says pathologist can't write anything beyond this word, pathologists see that something is abnormal, but pathologist is not able to finally conclude what abnormality it is. Atypical squamous cells of unknown significance, just remove everything, just remove everything, just write down if the report says atypical cells of unknown significance. What is the next step? Colposcopy. Pathologists can't see anything beyond this. Now we will put a camera in the survey to see actually what it is. Colposcope is a camera of cervix. Colposcope is camera of cervix. Another possibility is atypical glandular cells. Glandular cell. If pathologists use the word atypical glandular cells, glands may be from endometrium, wherever there is columnar epithelium. Endocervix has columnar epithelium. So if atypical glandular cells are written, we will take an endometrial biopsy. Columnar epithelium is there. Endocervical epithelium is also columnar. So we will do an endocervical curettage and of course colposcopy. We will put in a camera in the cervix. Now the most important MCQ zone begins. If pap smear reports suggestive of LSIL, pathologist clearly writes LSIL. LSIL means low grade squamous intraepithelial lesion. We have three MCQs here. Whenever pathologist is writing LSIL, LSIL means low grade squamous intraepithelial lesion, means CIN1. Three MCQs. What are these three MCQs? First line of the question will be pap smear report is suggestive of low grade squamous intraepithelial lesion. Second line of MCQ may be a so and so size. Suppose, for example, a 1 by 1 millimeter lesion is visible on per speculum examination. So, if lesion is visible, in cases of LSIL, we will do a punch biopsy. We will do a punch biopsy. How a punch biopsy is done? Let me show you an image of punch biopsy forceps. This is how we take a punch biopsy. This is punch biopsy. Look here. What we are doing. This is cervical biopsy, punch biopsy forceps. By this punch biopsy forceps, you can see we are taking the biopsy from this area. Why we are taking biopsy from this area? Because lesion is visible. So MCQ number 1, if pap smear report is suggestive of LSIL, full stop. Second line of the question, a so and so size lesion is visible on per speculum examination, full stop. Third line of the question, what is the next step? Answer is which biopsy? Punch. So punch can be done if you can see where from the punch has to be taken. So punch biopsy will be done if lesion is visible. Fine. Now, if Second possibility, if nothing is visible. First line is LSIL. Second line of the question, nothing is visible on per speculum examination. Now what to do? If nothing is visible on per speculum examination, we will do a colposcopy. How a colposcopy is done? This is the colposcope. This is the camera of cervix colposcope. And how we are looking at the cervix with the help of colposcope. So this is the camera of cervix colposcope. This is colposcopy procedure. So we put in a colposcope here in the cervix, and whatever we see here with this camera of cervix colposcope is visualized on the monitor here. So we can see directly on the monitor whatever we see with the colposcope. Colposcope is the camera of cervix. This colposcope image is given in our workbook. So if nothing is visible on per speculum examination, what is the next step? Colposcopy. Colposcopic biopsy from acetowhite area. What we do, we paint the cervix with acetic acid before doing colposcopy. So abnormal areas become white. Abnormal areas become white. This colposcopy is a OPD procedure. It can be done in local anesthesia, sometimes no anesthesia required. Filter used in colposcopy is green. Filter used in colposcopy is green. Filter is a device to enhance the quality of images. It improves the quality of images. So all colposcopy images are green in color. Our exam question, it was asked in December 21. What is the color of filter in colposcopy? This is green. Third variety of MCQ. First line of the question same. A lady presents with abnormal Pap smear report LSI. Full stop. Second line of the question, a colposcopy was done and nothing is visible even by colposcopy. If nothing is visible even by colposcopy, then we do conization. What is this conization? A cone-shaped piece is cut, including endocervix, ectocervix, and squamocolumnar junction. Let me show you conization, how we use this conization and how we cut this cone-shaped piece. This is conization. Look here. This is how this conization is done. We are cutting a cone-shaped piece like this. We are cutting this area, cone-shaped piece. And this cone should include all the parts. It should include ectocervix, it should include endocervix, and of course, part between ectocervix and endocervix is squamocolumnar junction. So we are cutting a cone-shaped piece in cervix, and this cone includes ectocervix, endocervix, and part between ectocervix and endocervix means squamocolumnar junction. So this conization is done if nothing is visible even by colposcopy. If you are cutting, this is the IPD procedure. You have to admit her. It will be done in general anesthesia. Cutting. You are cutting a tissue. She will feel pain. Another variety of MCQ, he may present with abnormal Pap smear report suggestive of HSIL, high-grade squamous intraepithelial lesion. Of course, same way, we will do a careful per speculum examination. Same three MCQs. If lesion is visible, we will do which biopsy? Of course, punch biopsy. We will do a punch biopsy. Plus, if it is HSIL, just add one word. Punch biopsy plus endocervical curettage. If it was LSIL, we were doing only punch biopsy. Second variety of MCQ. If nothing is visible on per speculum examination, If it was LSIL, we did colposcopic biopsy. Here again we will add just one word, endocervical curettage. Endocervical curettage. Third possibility, if nothing is visible even by colposcopy, if it was LSIL, we were finishing at the word conidation. But here again the same word. So the game has become very easy. If it is HSIL, we are adding just one word to all the three MCQs, endocervical curettage. If lesion is visible, punch biopsy plus endocervical curettage. If nothing is visible, colposcopic biopsy plus endocervical curettage. If nothing is visible even by colposcopy, conization plus endocervical curettage. Most common route of spread in cervical cancer is lymphatic spread. Most common route of spread in cervical cancer is lymphatic, while most common route of spread in endometrial cancer was direct spread. What is the meaning of word sentinel lymph node? You know with the knowledge of pathology. Sentinel lymph node means the first lymph node involved. The first one. First lymph node involved in a cancer is sentinel lymph node. So sentinel lymph node in cervical cancer is paracervical. If paracervical is not given in option, then second best answer will be ureteric lymph node. Ureteric. First lymph node involved in a cancer is called sentinel lymph node. So of course this is paracervical. If paracervical not in option, ureteric. And finally, the draining into obturator lymph node. So this is a obturator lymph node. This is a ureteric lymph node. And this is a paracervical lymph node. So accordingly, we can choose the answer. If the question is most common lymph node involved in cervical cancer, answer is obturator lymph node. If the question is sentinel lymph node in cervical cancer, paracervical. If paracervical is not given in option, ureteric lymph node. Few statistical questions. We know this basic microbiology that viral proteins, human papilloma virus proteins will be required for attachment of the virus to epithelium, to cervical epithelium. The viral protein required for attachment to cervical epithelium are L1 and L2. तो we can remember लाव epithelium के पास लाव attach L1 L2. Viral protein required for replication. Replication means doubling. One becomes two. That's replication of virus. So easily we can remember E1, E2 means one becomes two. One becomes two. So for replication, 1, 2. Viral proteins required for malignant transformation. So malignant transformation is something bigger. So we have the bigger number, E6 and E7. So viral proteins required for malignant transformation are 6 and 7, the bigger number. Now these proteins have to suppress the protective gene. E6 suppress P53 gene, while E7 suppress retinoblastoma gene. Again, it is easy to remember. 6 comes first and P comes first. 7 comes later, R comes later. So 6 will suppress the first number. P comes before R. 6 comes before 7. So 6 suppress P53 gene, 7 suppress retinoblastoma gene. Few statistical questions. Staging in cervical cancer is clinical. This is clinical staging. While staging in endometrial cancer was surgical. Stage 1. What is this staging? Staging is about how much this cancer has moved out of epithelium. How much this cancer has moved out of epithelium. Let's go back to our ray diagram quickly. How much this cancer has moved out of epithelium. Means invasive cancer means this is coming out of epithelium like this here or like this here. So this staging is about this. Staging means how much it has reached out, how much it has moved out of epithelium. One is divided in 1A and 1B. A and B are further subdivided. A1 if it is less than 3 millimeter. It has moved out of epithelium but less than 3 mm. A2, it has moved out of epithelium between 3 to 4 mm. B1, it has moved out of epithelium either 5 millimeter or more than 5 millimeter but less than 2 centimeter. B2, 2 centimeter or more than 2 centimeter but less than 4 centimeter. B3, 4 centimeter or more than 4 centimeter. So based on the distance, how much it has moved out of epithelium, we categorize the staging protocol of stage 1. Stage 2A. Now cancer comes out of cervix and upper two-thirds of vagina is involved. Upper two-thirds of vagina is involved. A1 and A2. A is further categorized as A1 and A2. A1 it is less than 4 centimeter, A2 4 centimeter or more than 4 centimeter. 2B, along with involvement of upper two-thirds of vagina, along with involvement of upper two-thirds, everything is fine. Along with involvement of upper two-thirds of vagina, there is extension to parametrium. Parametrium. Parametrium is the area around cervix. Stage 3A, lower one-third of vagina is involved. 3B, along with involvement of lower one-third of vagina, there is extension to pelvic wall. Extension to pelvic wall. 3C is further subdivided in C1 and C2. If pelvic lymph nodes are involved, this is C1. If para-aortic lymph nodes are involved, this is C2. 4A, so 3C1C2 and 4AB, they are similar in cervical and endometrial cancer. 4A, regional metastasis either to urinary bladder or rectum. While 4B is distant metastasis. This is the staging of cervical cancer. So staging and treatment, they have to be mucked up. Just few things in obs-gynae which have to be mucked up. Complication of cervical cancer or most common cause of death in cervical cancer is renal failure. How renal failure occurs in cervical cancer? Let me ask you an indirect question. If hydronephrosis develops in cervical cancer, what is the earliest stage? Look at the staging and answer me this question. If hydronephrosis, go through the staging and answer me this question. If hydronephrosis develops in cervical cancer, what is the stage? Earliest stage, chocolate question. Don't answer right now on the mobile, but this chocolate is due. If hydronephrosis develops in cervical cancer, the earliest stage is 3B. Because when there is extension to pelvic wall, ureter will come in between and hydronephrosis will develop. And because of hydronephrosis, there will be back pressure, which may result in renal failure. So, renal failure is common in cervical cancer because of hydronephrosis. Most common complication of cervical cancer or most common cause of death in cervical cancer is renal failure. Second most common cause is excessive bleeding, excessive hemorrhage, because most common symptom is irregular bleeding PV, but most common will remain renal failure. Other features may be pyometra. Pyometra can develop in cervical cancer also. If the lesion is large enough to block the passage of secretions, they will collect inside. Here just write down one MCQ. We have discussed the causes of pyometra, cervical cancer, endometrial cancer, Asherman syndrome, but most common cause of pyometra is senile endometritis. Senile endometritis means due to aging process. Due to aging process, there occur atrophy in endometrium. And because of this atrophy, infections occur. And because of this infection, some fibrosis may occur. So the passage is blocked. Just remember one word. Most common cause of pyometra overall is not cervical cancer. It is not endometrial cancer. It is not Asherman syndrome. It is senile endometritis. Senile endometritis. Most common cause of pyometra is senile endometritis. Why? Just a moment. Prevention by vaccine, it has been discussed in PSM. Management of cervical cancer. For CIN1, we do observation for 2 years. Observation for 2 years. Follow-up for 2 years. We'll take some 10-15 more minutes to complete this cervical cancer. CIN1 observation for 2 years. If it remains CIN1 in 2 years, means if it does not regress or it does not progress to CIN2. If it doesn't regress or progress, it remains CIN1, we do cryocauterization. We do cryocauterization. Cryocauterization means cold cauterization. We use nitrous oxide or carbon dioxide at minus 180 degrees Celsius. So we have cylinder of these gases, nitrous cylinder, and with this cylinder a tube is attached and this tube is attached to the gun. And then we are firing this cryo gun on the cervix. It is causing cold cauterization. So just remember, management for CIN1 is cryocauterization. For CIN2 and CIN3, this is LEAP. For CIN2 and CIN3, loop electrosurgical excision procedure, which is also called large loop excision of transformation zone. This is done with LEAP electrodes, and this is how this is done. This is the LEAP procedure, LEAP. This is how we do LEAP. This is the LEAP electrode. And by this LEAP electrode, we are cutting and coagulating at the same time. And up to 1 centimeter, 10 millimeter of depth can be destroyed with LEAP electrode, that is loop electrosurgical excision procedure, which is also called large loop excision for transformation zone. Just remember, treatment for CIN2 and CIN3 is one word answer, LEAP, loop electrosurgical excision procedure. This is the procedure LEAP. Done with the LEAP electrodes, OPD procedure, we cut and coagulate at the same time and up to 10 mm depth can be destroyed with this procedure leave. If CIN is extending to lateral fornix, it is beyond the range of leap, then we have to fire the laser beam on this CIN. It is extending laterally. It is not in the range of leap electrode. So we fire the laser beam if it is extending to lateral fornix. Management for recurrent CIN. If examiner write the word, she is having recurrent CIN. Management for recurrent CIN is total abdominal hysterectomy. So hysterectomy is done only for recurrent CIN. Hysterectomy is done only for the treatment of recurrent CIN. If recurrent word is used, then only use hysterectomy. Otherwise, treatment for CIN2 and CIN3 is leap only. Examiner will try to trap you with hysterectomy. We will not be trapped. Hysterectomy is done only if recurrent CIN word is written. Then for carcinoma in situ and 1A1. Let's discuss the rule. Rule of the surgery. Principle of the surgery for cervical cancer. Any surgery can be done for cervical cancer if size of cancer is less than 4 centimeter. If size of cervical cancer is 4 centimeter or more than 4 centimeter, no surgery can be done. Only management is chemoradiation, no surgery. That is inoperable. But if it is less than 4 centimeter, surgery can be done. And if the size is less than 2 centimeter, we can do a special type of surgery. What is this special type of surgery? Radical trachelectomy. What is this radical trachelectomy? Radical trachelectomy is removal of cervix and parametrium. Means we remove only cervix because cancer is there in the cervix. So we can remove only the cervix and then we can stitch uterus and vagina together. So she can have a baby. She can have future childbearing. This is radical trachelectomy. But this surgery can be done if size of cancer is less than 2 centimeter. So this is the rule of surgery in cervical cancer. Rule of surgery in cervical cancer. Any surgery in cervical cancer can be done if size of cancer is less than 4 centimeter. A special surgery in which we can save the uterus, we can remove only the cervix. Name of the surgery is radical trachelectomy. It can be done if size is less than 2 centimeter. So treatment for carcinoma in situ and 1A1. If she is young nulliparous, she wants a baby, we can do conization, cutting a cone-shaped piece, including endocervix, ectocervix, squamocolumnar section. If she is old multiparous, then we do total abdominal hysterectomy. Total abdominal hysterectomy. For 1A2, again 1A2 is 3 to 4 millimeter, so very well less than 2 centimeter. Young nulliparous radical trachelectomy can be done because it is less than 2 centimeter, A2. But if she is old or multiparous, in 1A2 we do Verdine hysterectomy. In 1A2 we do Verdine hysterectomy. 1B1. 1B1, what is 1B1? 5 mm or more than 5 mm but less than 2 centimeter. So this is also less than 2 centimeter. So if she is young and nulliparous, here also we can do radical trachelectomy, where we are removing only the cervix and parametrium and stitching uterus and vagina together. But if she is old multiparous, from 1B1 we begin radical hysterectomy. 1B1 If she is old and multiparous, we begin radical hysterectomy. What are the types of hysterectomy that we will discuss in the miscellaneous part of this obscine? That is the third part of our workbook. We will discuss that. 1B2. What is 1B2? 1B2 is 2 centimeter or more than 2 centimeter but less than 4 centimeter. So surgery can be done but radical trachelectomy cannot be done. So we can do radical hysterectomy but we cannot do radical trachelectomy. So we are not writing young nulliparous, old multiparous separately. Radical trachelectomy cannot be done. It is more than 2 centimeter. 1B3, 4 centimeter or more than 4 centimeter. In 1B3, only management is chemoradiation. No surgery can be done in 1B3 because it is more than 4 centimeter. Very important MCQ zone. In 1B3, we cannot do any surgery, but surgery can be done in 2A1, which is next to 1B3. 2A1 was less than 4 centimeter. So surgery can be done in 2A1, but surgery cannot be done in 1B3. And 2A2 onwards, only management is chemoradiation. Cisplatin acts as radiosensitizer. We have to write one point: pelvic lymph node dissection. Pelvic lymph node dissection is done in all surgeries for cervical cancer. Pelvic lymph node dissection is done in all surgeries for cervical cancer. Whenever we are doing any surgery in cervical cancer, pelvic lymph node dissection is done. That's for sure. Then, what about the post-op management? This was the operation. Post-op management. Do you want to do anything after the surgery? Post-op management in cervical cancer depends on risk factors. Post-op management in cervical cancer depends on risk factors. Write down: if there are no risk factors, if there are no risk factors, not required. No post-op management is required if there are no risk factors. If there are intermediate risk factors, if there are intermediate risk factors, then we do post-op radiotherapy. Post-op radiotherapy. What are intermediate risk factors? We operate cervical cancer if size is less than 4 centimeter. And pathologist rings up: oh, doctor, you committed a mistake. Size is more than 4. Oh my God. So we will take some corrective action. We will do something after the operation. We will give her radiotherapy. We should not do surgery if size is more than 4 centimeter. If there is stromal involvement, that is also a intermediate risk factor. And if there is lymphovascular space invasion, lymphovascular space invasion, these are intermediate risk factors, and in these cases we will do post-op radiotherapy. And if there are high risk factors, then we do post-op chemoradiation. Not only radiotherapy, post-op chemoradiation. Chemoradiation radiosensitizer drug is same cisplatin. What are high risk factors? If lymph nodes are positive, we do pelvic lymph node dissection with all the cases. If they are positive, if the margins are positive, and if there is parametrial involvement, these are high risk factors, and if high risk factors are present, we give post-op chemoradiation. And in radiotherapy, our exam question of last session, June 22, MCI exam question. In radiotherapy, we have point A and point B. They ask the position of point A, point B. Point A is situated 2 centimeter above and 2 centimeter lateral to external os. While point B is situated 2 centimeter above and 5 centimeter lateral to external os. Point B. Where is the point B? This was our last session question. June 22 FMG exam question. They asked the location of point B. What are these points? We are firing the lymph nodes. Which lymph node is present here? Paracervical lymph node. We are targeting paracervical lymph node here. While with point B, we are targeting obturator lymph node. So again, easy to remember, A comes first, B comes later. A comes first, B comes later. 2 comes first, 5 comes later. A comes first, B comes later. 2 comes first, 5 comes later. So obviously point B, 5. Point A, everything is 2, 2. 2 centimeter above and 2 centimeter lateral. Point B, 2 centimeter above and 5 centimeter lateral to external O. Let's solve the questions and then we will call it a day. Today we are completing the first part of Obsgynae, that is gynecology. Cervical cancer. Fixative used in pap smear is ethyl alcohol. And if which option is given here, then answer will not be ethyl alcohol. Liquid methanol. The latest cytology is a liquid-based cytology, but it is expensive. So liquid methanol will be a better answer if that is given in option. I'm just after the class will prepare questions for your telegram. Putting efforts, I have to put efforts to make the question. Hydronephrosis in cancer cervix can be seen earliest in which stage? 3P. There is extension to pelvic wall, and most common complication or most common cause of death in cervical cancer is renal failure. Management of CIN2 and CIN3 both is LEAP, loop electrosurgical excision procedure. If the word recurrent CIN is given, then only hysterectomy. If CIN is extending to fornices, lateral fornix, then later. Cryocautery is the management for CIN1. The given below instrument is used in which procedure? This instrument, this is a colposcope, and we can see whatever we see in cervix on this monitor. So this is a colposcopy. Given below instrument is used in which procedure? Colposcopy. Most common route of spread of cervical cancer is lymphatic. So we are done with the first part of Obsgynae, that is gynecology. Be ready to be trapped at 9 p.m. Try not to be trapped with the question. Bye-bye.